Hi, I am Dr. Jayanti Gurumukhani. Yeah, okay, all done. इसको मैं जेब में रखूं. You introduce? Yeah, you come. Yeah, yeah.
Good morning, all members. We are privileged to invite both our eminent speakers. Good morning. I am privileged to invite both our eminent speakers in the field of neurology. Our first speaker is Dr. Jayanti Gurumukhani, sir, our very own guru of neurology. He has a rich clinical experience and academic insight and has multiple prestigious degrees and awards on his name. And another speaker is respected Dr. Rahul Chakor, sir. He is professor and head Department of Neurology, TN Medical College and Nair Hospital. He has immense clinical experience and as well as an academic experience, and has been instrumental in bringing up training various neurologists in India. I welcome both the eminent speakers, and we are enlightened to listen to the talk. Thank you, sir.
Good morning, everybody. Thank you, API, for giving me this opportunity to speak on today on this top 25 cases of neurology. So before we start the cases, I have an idea to start with the quiz. So we'll begin with the quiz, after which we'll have this 25 cases. And I'll be joined by Dr. Rahul Chakor, who is a great neurologist from Mumbai. Let me tell you, yesterday he traveled from Mumbai to Bhavnagar in a car because the planes were, somehow we got the message that there's no plane coming to Ahmedabad. And so, he has taken all the trouble. So I wish all of you to remain present throughout the end so that, we'll have the good discussions. So don't think that I'm just speaking. It'll be an interactive kind of a things we'll have, right? So we begin with the headache quiz. Padhya, sir? Okay, right, yeah. So we will begin with the headache quiz. I'll be presenting very, very simple question answers, and you have to answer me for that. A 33-year male patient, he came with intermittent headache since last 5 years. When asked if his headache involves always one side of his head, he said, no, sir, it either involves the right side or it involves the left side of the head. This pattern is consistent with which of the following headache disorders? Is it cluster headache, hemicrania continua, migraine, or paroxysmal hemicrania, or right hemispheric lesion? Madam? Okay. Anybody differs? Nobody differs. It either involves the right side of the head or the left side of the head. 5 years of the intermittent headache, recurrent headache going on for 5 years, 2 to 3 times in a month, multiple episodes the person is getting all across since 5 years. Unfortunately, it's a migraine. It's a very simple case. See, migraine may begin unilaterally, right? But ultimately the patient will say it either affects right side or affects the left side, or from right side it becomes generalized, from left side it becomes generalized, or it starts generalized. So this migraine headache is usually not side locked. It keeps changing the sides from one to another, even different episodes. Whereas if you always get a one side of the headache, say for example, I always get a right side of the headache since last 1 month with a lot of autonomic features, then I think in terms of either a cluster headache or a paroxysmal hemicrania or hemicrania continua, or maybe I might be having a mass. If the headache changes the site, it's consistent with migraine. What is the definition of migraine? You have a recurrent episodes of headache lasting from few hours, which is usually by definition 4 to 72 hours if untreated. And you need only 2 of the 4. You don't need always unilateral location. It can be unilateral, throbbing, moderate to severe, and worse with the physical activity. If any 2 are present, it is sufficient to qualify for the migraine. So you can have bilateral headache, throbbing, moderate to severe. It's enough. And you should have one of the following: nausea, vomiting, photoinphonophobia. You always don't need photoinphonophobia. You always don't need nausea, vomiting. Either of the one is okay, and 2 of the 4 is okay. Simple language, if I have to say, if somebody gets recurrent headaches, not side locked, recurrent headaches, think of migraine. 90% time you will be right, right? So, and very few small percent of patients, maybe 10 or 15% would have aura. So, aura is not really required. And if it happens to have the aura, then it will be in the form of the visual scotoma. Gradually, they will say a visual loss happens in the one eye. It starts gradually over 5-7 minutes progresses. Some people see a zigzag lines around the eyes. And so, with that, and after that in few minutes, it will subside. Generally, after this aura, person will get the headache. Some people get the tingling and numbness in the hands and in the face as well. But the difference between the TI and this tingling numbness is it starts gradually, distally, and in over 5 minutes it progress and involve the face and the tongue. So that's a typical migraine aura that we expect. Hardly 10% of the patients, maybe sometimes people say 20% of the patients, and sometimes other auras. So headache, so okay, we come to quiz 2. 4 symptoms including polyuria, food carvings, irritability and mood changes are reported. Approximately 80% of patients with migraine in which of the following phase? There are phases of migraine. We said, is it the aura phase? Is it the headache phase? Is it the interictal phase between the episode of the headache? Postdrome phase after the headache, or prodrome phase before the headache? Which of the phases person would have these symptoms? Absolutely correct. Madam, perfect, both of them, gift for them. Great answers. So yes, migraine would have a lot of phases: prodrome, aura, headache, postdrome, and interictal, and the answer is prodrome phase. So while this overlapping symptoms, this may be present over various phases, but most of the times, person will come to know before the onset of migraine that he is going to develop these things. So he can have either a low energy, digestive issues, even a yawning can happen few hours before the onset of migraine. Some people get sensitive to light and sound. Mood changes, even the neck stiffness is very well known as a prodrome of migraine. Quiz 3. 24-year female, she's a known case of migraine. She comes to you saying that, sir, 1 to 2 days after attacks, she feels abnormal, something is wrong, she's not happy, whether or not she has taken the acute medication for the migraine. Which of the following symptoms would be typical of the migraine post-drome? So we talked about the prodrome. Now I'm giving you options. Which of the following are the migraine post-drome? Is it a cognitive dysfunction? Is it expressive language dysfunction? Hearing loss? Impaired consciousness? Or a visual scintillations? Which of the one you think is a migraine post-drome? Sir, migraine post-drome માં કયું હોય પાંચમાંથી? Absolutely correct, correct. So you are right. So after the migraine attack is over, a lot of patients would have the hangover kind of a things. Not everyone would have, but those who have, this could be mostly in the form of either cognitive dysfunction, vertigo, or fatigue. So these are the 3 common ones, and cognitive was one of the options in this. So you can have the either after the episode, some people feel depressed, some people feel exhausted, some people feel even euphoric, try to do a lot of work after the prodrome, and some people get a mood changes. Quiz 4. A 29-year female, she presented with the severe unrelenting migraine symptoms in the last 2 days, and she has not been responding to her usual medications like sumatriptan and chlorpromazine, which usually used to help her. And so it was decided that physician thought, let us give her dexamethasone. My question is, if you give dexamethasone in a patient of migraine, what is the role of this dexamethasone? Does it decrease the acute pain? Does it decrease the need for antiemetic medications? Does it decrease the rate of recurrence in subsequent days? Does it increase the need for opioids? Or does it increase the rate of hospitalization for migraine symptoms? Sir? Absolutely, perfect answer, great. I'm very impressed because a lot of people think that we give steroids, the headache pain will reduce, but that does not happen. So if you have a severe headache which is not responding to usual line of treatment, you may think about the secondary headaches, you may investigate that patient, but if he's not responding, you can give an analgesic like, diclofenac. Sometimes you give a lot of hydration. If somebody is vomiting away, that is very important. We can give the valproic acid as well. And so dexamethasone will only prevent the recurrence of the headache. Quiz 5. Which of the following medications used for the prevention of the migraine has received highest level of recommendations in European, Canadian, American societies among the options that I am giving to you? Is it amitriptyline? Is it candesartan? Is it gabapentin, topiramate, or verapamil? Which of these has the highest level of recommendation? Amitriptyline, topiramate is the right answer. Amitriptyline was in the past, but of late it has gone a little bit down. So topiramate is an answer. And so valproate, topiramate, propranolol, metoprolol, these have a high level of recommendations. Before 2012, even amitriptyline was considered to be a best drug. We can use it, no doubt, but I don't know whether pharma people have done some magic or whatever. It has gone to a level B nowadays, and so amitriptyline is considered second best, but we still do use it time to time. It's not like that. So it's a good drug as well. In which of the following situations should a preventive medication of migraine should be offered? Is it American Headache Society does not recommend it? You need to have 2 headaches per month with severe disability, or you need to have 3 headaches per month with some disability, or 4 headaches per month with some disability, or 5 headaches per month with no disability. What is your choice? 3. 3. What is your choice? 3. Anybody differs? 2. Anybody? Still we are not having right answer. Madam? 3. Society recommends what? Not recommend. That's also not correct. They don't recommend. We have to give the patient that disabling. So we have to give something. Now what is left out? So 4 headaches per month with some disability. These are guidelines. It's not necessary. You can have 2 headaches with disability. You can give the treatment. But the guideline says 4 headaches with some disability. So quiz next. Which of the following is a key diagnostic criteria for medication overuse headaches? A lot of patients have migraine, they take a lot of analgesic. Daily they take paracetamol, or daily they take ibuprofen, or some combination of the drugs. So they get a medication overuse headache. So there are some laid down criteria for the diagnosis of the MOH. So which are those? A, age of 50 years or younger. 2, headache occurrence on 15 days or more per month. 3, headache responsiveness to corticosteroid treatment. D, preceding diagnosis of episodic migraine. Or 5, regular overuse of analgesic medications for at least 1 year. Say it, sir. Anybody differs? Say it, sir. What is your choice? E. We are takers of E. What else? Yes, absolutely correct. So the answer is headache occurrence on more than 15. You need to have chronic, headache symptoms for this thing. And regarding the E, you need 3 months of the over medication. So a lot of drugs to be taken. So this is a criteria for the migraine medication overuse headache. You need to have at least 15 days per month of the headache. Usually in a pre-existing disorder. So somebody has a migraine, that's the second right answer. But you need to have at least 15 days because that option is better than this. And you need to have a lot of medication person should be taking. And this lot means what? You need to be taking simple analgesic like acetaminophen or NSAIDs more than 15 days per month. And this should be taken for 3 consecutive months, not 1 year. If somebody has taken for 3 months this many analgesic, he qualifies for the diagnosis of MOH. Whereas if he is taking triptan, ergotamine, combined analgesic or opioids, then you take 10 analgesics per month for 3 consecutive months, and then you qualify for the diagnosis of MOH. Quiz 8. Which of the following best describes the risk of relapse? See, once you treat the patient on MOH, the person is going to relapse. There is some chance in those who have treated the patients. What is the best describes the risk of relapse? A, is it a prior opioid use, which is not a risk factor for MOH? B, relapse rate can be as high as 50%. C, relapses are uncommon in the first year, but can be seen in 3 to 5 years. And tension type headache is associated with the lower risk of the MOH recurrence. And 5, younger patient age is a strong predictor of MOH relapse. Tension type headache is lower risk. No, tension type can have a good risk, same risk. See? What else? Madam? Yes, relapse rates can be as high as 50% in some settings. See, whenever you treat a patient of MOH, in the first year they would have the highest relapse. 3 to 5 years they may keep getting, but the first year is the most dangerous because they are left their drug which they have been taking for a very long period of time. And tension type headache is there, younger is there, elder is there, everybody can have the relapse. And so first year is very critical once you have treated the patient of medication overuse headache. What idea comes to your mind when you see a patient with unilateral headache with ptosis, meiosis, lacrimation and rhinorrhea? Cluster headache, absolutely. So my question is, which of the following is the most common time for the cluster headache symptoms recurrence? See, cluster headache has a circadian rhythmicity. It tends to occur on the same time, so which of this time is the highest recurrence? Is it 2 a.m., 7 a.m., 12 noon, 5 p.m. or 10 p.m.? Morning, what time? 7 a.m. How many of you differ? 2 a.m. is the right answer. Yes, 2 a.m. sir is right. 2 a.m. is the right answer. See, a lot of patients have cluster headache, they get up in the middle of the night and say, oh, terrible headache. And this I mean, it's not necessary. They are all, this was just an observation of the multiple studies and one meta-analysis. This is not right and wrong. This is just to say that this is the time when you get the highest, because there is a circadian rhythmicity seen in about 70% of the patients of the cluster headache. Question. Which of the following headache features best differentiates migraine from cluster headache? Can you tell any, without the slide? Autonomic symptoms? Okay. We'll give you the option. Now you select. Is it autonomic features? Is it duration? Is it premonitory features? Is it response to treatment with sumatriptan? Or is it triggers? What is your answer? Triggers. You? Duration. Autonomy. You all are partially right, but the best answer is duration. Madam is perfect. And so the answer is, see, in both in migraine and cluster headache, you tend to get the autonomic features. Although in migraine you might have both the sides, they are mild, unilateral, but there is autonomic features known in case of the migraine. And they both respond to sumatriptan, and then both can have the triggers. But duration is one very important thing. Most of the cluster headache would like 30 minutes, 45 minutes, unilateral headache with a lot of autonomic features. That's typical. Of course, the definition says 15 minutes to 180 minutes. Whereas migraine is a longer duration, 4 hours, 8 hours, 12 hours, 24 hours, up to 72 hours. That's typical migraine. So longer duration is migraine, shorter duration is our cluster headache. So the best answer is that. Quiz 11. 53-year male patient came with a 1-year history of a right-sided periorbital headache that was sharp in character, lasting 60 to 90 minutes, and was associated with lacrimation and rhinorrhea. What comes to your mind? 1-year history of episodes of headache, 60 to 90 minutes. No, 90 minutes. Cluster, it's a chronic cluster headache. So when it's happening for the long period of time, you are thinking in terms of a chronic cluster headache. So you do a MRI brain, which is normal. You give a trial of the cluster headache treatment. You give verapamil, you give lithium, you give galcanezumab, sir has been using, but they have not led to any improvement. So which of the following is the most appropriate next step? Now your option. You have got a difficult cluster headache. Now you are masters of clusters. So you are giving a difficult case with normal MRI brain. Which is it lumbar puncture you will do next? Is it prednisolone? Is it prolactin level? You give a repeat trial of lithium at higher dose, or you do a sphenopalatine ganglion stimulation. What is next? Prednisolone. Okay. Anybody differs? But that is an acute episode during. Here we want to prevent so many episodes the person is getting. During that episode, yes, oxygen is the best treatment that you give. I agree with you. But because they are getting so many, so then you have to give something. So what do you do, or what is it? So somebody said prednisolone. Okay, what else? Anybody differs? Who is saying? My God. The answer is prolactin level. See, most of the patients, it is said that when somebody has not responded to the 3 preventive medications for the cluster headache, which are the best treatment that they have received, and then MRI is normal. But you know, when you ask for the MRI brain, you should always write my diagnosis is a cluster headache. When you write the diagnosis of cluster headache, the radiologist will take, or otherwise you tell him to take over the pituitary some fine thin cuts. So if they take fine thin cuts across the pituitary, then you can pick up the pituitary microadenoma, which is one of the causes of the cluster headache. So somebody is refractory, before doing fancy things like sphenopalatine ganglion stimulation or other things, you should rule out this thing, and you should also look for the pituitary function test like prolactin. And therefore, all cluster headaches write this thing that we want an MRI brain with the pituitary cuts. Quiz 12. 44-year male presented with 4 months episode of a severe left-sided eye pain associated with conjunctival injection, lacrimation, and ptosis. This headache would last 12 minutes and occur 10 times in a day. Touching the face does not trigger the episodes. His MRI brain is normal. Which of the following medications is most appropriate for this patient? Is it amitriptyline, carbamazepine, indomethacin, lamotrigine, or topiramate? Carbamazepine. Okay, anybody differs? Sir, do you differ? Said, sir, you want to say, what is the diagnosis in this patient? What is the definition of short shunt? Shunt is few seconds, 1 or 2 seconds, up to 10 minutes. Usually it is 1 minute, half a minute, 2 minutes. It usually doesn't go to 10 minutes or 1 or 2 minutes. It's a 12 minutes headache. The cluster headache is definition 15 minutes to 180 minutes. So it is usually, we don't go the line, but this is just for the sake of it. Generally half an hour, 1 hour in that range. This is a 12 minutes, something in between. So what comes between shunt and the cluster headache? What comes in between? Madam, what comes between the shunt and the cluster headache? Yeah, so it is a paroxysmal hemicrania, and therefore you give a drug indomethacin, right? So this patient diagnosed with paroxysmal hemicrania, and so the shunt is a little shorter duration, right? So this is a graph to show that the shunt is of 1 second to 10 minutes. This is 2 to 30 minutes, and this is more than 15 minutes. So 12 minutes means it is paroxysmal hemicrania. Of course, nothing like that. Sometimes we are not sure. Person come with the 20 minutes of headache, so it can overlap. So we have to give a trial of indomethacin, and then you say, ah, India nahi hai. So then you treat like cluster headaches. Overlap is very common. So if you have a unilateral headache with autonomy features, think of these three conditions. And if the headache is continuous with the exacerbation in between, then you think of a hemicrania continua. Yeah, daily, for years together. Because because it is also NSAID, suppose naproxen is onset, but this works the acetic acid pathways, and where the naproxen and these other drugs, they work the propionic acid pathways. And so this because of the separate pathways, little different mechanism of the action, this indomethacin is very selective COX-1 inhibitor, it's highly lipid soluble, it goes to the brain very well, and therefore indomethacin works very well whenever you see this thing, and therefore it is in its own place. And it has been tried and tested a lot of times. Other drugs, somehow they don't work it. If when the person paroxysmal hemicrania comes to you, you can use another COX-1 inhibitor, celecoxib. You can try melatonin as well. So these are the other drugs. Sometimes topiramate also works in that situations. But other NSAID, that doesn't work. This is a difficult case. 65-year female, she is a pacemaker, and which was MRI unsafe, so you can't do the MRI in this patient. She came with a 25 years history of a daily headache that began abruptly. The headaches were holocephalic, means throughout, pulsating, 6 out of 10 in pain intensity, associated with photophobia, phonophobia, neck stiffness, hypoacusis, and tinnitus. The headache does not change with position, but the patient recalls that when it started, the headache, it was like this, it will be precipitated by the standing up. When he lies down, headache disappears. When he stands up, he gets a lot of headache. This had started in the beginning, but over a period of time, now it has become a chronic daily headache. And his neurological examination and fundoscopy is normal. You do a CT scan with contrast, it is normal. And so, which of the following is the most appropriate next step in this patient? You do a CT myelography, you do ESR, you do occipital nerve block, or you do a Botox injection. Correct is a jackpot. 2 pens, huh? 2 pens. Difficult question. Madam, gold medalist. Another gold medalist. See, she has. Yeah. So what are you thinking? See, once we say an orthostatic headache, I mean lying it disappears, and standing there is a headache. That suggests what? Low pressure headache. Low pressure headache. Lying the headache is not there. Standing somebody gets a headache, that's a low pressure headache. And this has been lasting for so many years. Over a period of time, the headache changes its characters, and now it becomes continuous. Here the patient was intelligent, he gave this history. That itself is a clue that it is a orthostatic headache, and therefore you are thinking of spontaneous intracranial hypotension. Whenever you say spontaneous intracranial hypotension is there, you are thinking that there is a leak of the CSF in the spinal cord, and therefore in these situations you do what is a CT myelography. So look for the leak. Once you treat the leak, this 25 years headache would also disappear. So you have to make really a good diagnosis when you are seeing the patient with headache. You should have the interest. So this patient has a spontaneous intracranial hypotension. So orthostatic headache was a clue, and CT myelography was the answer. Question 4. Guideline recommends that all children and adolescents with migraine should be screened for which of the following conditions? A. Depression. 2. Eating disorders. 3. Epilepsy. 4. Intracranial aneurysm. Or 5. Sleep apnea. Yes, you are a new person. Tell me. All children should be screened for what? Huh? What is the answer? Eating disorder. Okay. Anybody else? Aneurysm. What else? What else? ભાઈ કોમન વિચારો નાનો માણસ મારા સવાલો નાના 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 હોય છે. બાળકો તમારી પાસે રોજ આવતા હોય, એન્યુરિઝમ્સ વિચારો, ઇટિંગ ડિસઓર્ડર વિચારો, બેઝિક વિચારો. અત્યારે શું હાલે છે? જ્ઞાન મંદિરમાં ભણતા હોય, એટલા સ્કૂલોમાં આવું હોય. Think of a depression. Yeah, so depression is the right answer. So all the children who comes and see you, think about this as a Depression is very common. It is not that, see hardly once in a year. You don't see that. You see aneurysm hardly once in a year. So every migraine patient, you're not going to ask, epilepsy che? Or, no, it's not required. So you have to ask for the depression. No. See, migraine can have the comorbidities. And one of the comorbidities is depression. Yeah. See, recurrent headache is migraine. Simple. Or headaches are migraine. But any સાથે જે આવે સાથે સાથે જે લઈને આવે એમ, right? So this is what we think. This is an important question. 15-year female, she reports throbbing quality of headache associated with nausea and photophobia. This occurs at the rate of once per month and lasting 4 hours. So throbbing headache, nausea, photophobia, once a month, 4 hours, right? Her events responded to ibuprofen and naproxen. Her mother and brother had similar events. Her neurological examination, including fundoscopy, is normal. Which of the following is needed in this patient to make a diagnosis of migraine without aura? What is required to make this diagnosis of migraine without aura? A, is it EEG? B, is it lumbar puncture? C, MR venogram of the head? D, no additional diagnosis testing is needed? Or therapeutic trial of sumatriptan? Migraine kare kesho? Those who differ from D, raise the hand. Everybody says D. You all are genius. Absolutely correct. This is D. You don't need fancy stuff. You have to just ask the history. So this patient's history was highly consistent with migraine with aura, and this strong family history of migraine and the neurological normal examination. You don't need any test. ખાલી તમે MRI કરવા જાઓ and you get a small arachnoid cyst or subtle little 2 millimeter aneurysm, and then it adds only a headache to the, or small cavernoma, it adds to the anxiety. And therefore the guidelines says don't image these patients whom you are thinking of clear migraine. You have a doubt, of course you should do it. It's a chronic headache, you should do it. Worsening headache, you should do it. Yeah. Quiz 16. Patient with classical trigeminal neuralgia has a higher risk of developing which of the following disorders? Alzheimer's disease, ALS, glioblastoma, Parkinson disease, or restless leg syndrome? Sir, પાછળ ભાઈ તમે બોલો એકે નથી બોલ્યા. Restless leg syndrome. Anybody differs? Parkinsonism. Alzheimer's is the correct answer. See, he's an elderly man most of the time. So what they will do? They'll do Alzheimer's. I mean, it's just an association observation. RLS can also be known because RLS is also very common. A 73-year-old man presents with 3 months history of a paroxysmal severe shooting pain at the back of his mouth that radiates to the angle of the jaw and the ear. This will last few seconds and is triggered by swallowing and yawning. So swallowing and yawning triggering this type of a paroxysmal severe pain which occurs behind the mouth. Which of the following clinical features may occur in this patient? Is it diplopia? Is it dysarthria? Is it dysphagia, hearing loss, or syncope? What this patient will develop over a period of time? Dysphagia. What is your diagnosis, by the way? Absolutely correct, 100% marks, but the answer is different. Why glossopharyngeal neuralgia will develop dysphagia? It's a nerve that is compressed inside the brain. So, in case he develops as a secondary glossopharyngeal neuralgia, he might. But what is more common that he's supposed to develop is a syncope. Why? Because glossopharyngeal nerve connects with the vagus nerve. And so patients with glossopharyngeal neuralgia have the vagal manifestations, including syncope and bradycardia, and therefore syncope is the right answer. This 63-year-old man presented with severe stabbing pain that is located deep in the internal auditory canal. The internal અહીંયા બહુ જોરદાર દુખાવો આમ ચાસકા આવે lasting 30 seconds, and this is triggered by touching the skin around the ear. Which of the following is the most secondary cause of this patient's headache, this pain? A, is it AV fistula, herpes zoster, meningioma, multiple sclerosis, or vestibular schwannoma? Herpes zoster. What is the diagnosis, by the way, this patient has? What is the diagnosis? That's a rare condition, yeah, but this is not the manifest. This is a chaska, touching the ear, you get a lot of severe pain. So this is, no, you would not have listened to, this is, herpes zoster is the right answer, by the way, full mark, 100% mark. This is nervous intermediate neuralgia. See, we get 4 types of neuralgia. One is our trigeminal neuralgia, glossopharyngeal neuralgia, nervous intermediate neuralgia, and occipital neuralgia. So these are the 4 neuralgia. This is less heard, less known, but sometimes patient comes to you and we say, it doesn't happen like that. You have to look for the cause for that. Nerve compression could be a cause. Vertigo zoster is one of the very important cause, and you do treat it like a carbamazepine and other drugs with. No, ખાલી ચાસ કાટલામાં જ આવે. કઈ ન આવે. You look for the secondary cause in all these patients. They may give you a vertigo zoster over there. Some vesicles might be seen in the ear. It's quite possible. Now last two questions before you go to the cases. Which of the following primary headache disorders is most likely to improve by daily taking caffeine? રોજ રાત્રે 2 કપ કોફી પીને સૂઈ જાઓ ને એટલે આ હેડેક માથું મટી જાય. કયું હેડેક? રાત્રે સૂતી વેળાએ 2 કપ કોફી પી જાઓ માઇગ્રેન મટી જાય? So you have options: hypnic, new daily persistent headache, nummular headache, primary exercise headache, or stabbing headache. Hypnic is the right answer. Absolutely correct. What is hypnic headache? Hypnic headache is a headache that you see mostly in the elderly people. They get in the middle of the night the severe bilateral headache which lasts from 15 minutes to 3-4 hours. There is no autonomic dysfunctions. If it is autonomic or unilateral, you think of cluster. It is bilateral, moderate to severe headache, and keeps coming in the elderly. It does not occur during the daytime. So if you have 3 months this history, you are sure that this is a diagnosis of the hypnic headache, and it is not an alarm clock headache. રોજ એકને એક જ ટાઈમે ચાલુ થાય. 2 વાગે ચાલુ થાય તો 2 વાગે, 3 વાગે ચાલુ થાય તો 3 વાગે, and lasts for a few minutes to 1 or 2 hours. And you give a trial of caffeine in half of the patients, they'll be very happy. I have few patients, I don't know, it's such a rare condition, but I have a few patients, and most of them have done well with the caffeine, but some will require lithium, melatonin, or indomethacin. Last quiz. In a woman with migraine, when do they get the most reduction in the headache frequency? સૌથી ઓછું ક્યારે ઘટી જાય માઇગ્રેન? હનીમૂન જેવું થઈ જાય લેડીઝ માટે. Is it the first trimester of pregnancy? Is it a 1 month postpartum? Is it a perimenopausal period? Is it a surgical menopause following oophorectomy? Or is it a 3rd trimester of pregnancy? Those who say first trimester? Anybody differs? 3rd trimester is the right answer. Absolutely correct. Sir is perfect. It's the 3rd trimester. And that's the reason it is said, you know, in first trimester, the headache frequency will remain same. In 2nd and 3rd trimester, it will really stabilize or be significantly reduced. Because at this level, although the estrogen and progesterone levels are very high, but they remain very stable. There is no fluctuation in this estrogen and progesterone to produce this bad headache. And therefore, if you get a lady who comes in the 3rd trimester and he says, I am getting increasing headaches, you should be really worried about the secondary cause in that situation. Don't disregard the headache in the 3rd trimester or peripartum period. So whenever you see a patient of headache, 90% of headaches are the primary headaches. So there's nothing to worry. I'm chati kholi ne aro. You should know the diagnosis of the migraine and tension type headache. Cluster bluster બધું ક્યારેક જ જોવા મળશે તમને. પણ એ તો આવડે એક જુનિયર ઓટોનોમિક સાથે સંગસુના આ તે બધું ઇન્ડોમેથાન, it's fine. But migraine and tension type master થઈ ગયા 89% headache તમને આવડી ગયું. But 10% of the patients are the secondary headaches. So you should very worry. You should not miss even one secondary headache. Because if you miss secondary, it's a trouble. So how should be your approach? Whenever you see a patient of headache, always look for the warning signs that are present in that patient. If the warning signs are present, look for the secondary headache and investigate. If you are thinking of primary headache, the person is not doing well, there are typical features, you know, somehow he did not respond the way we wanted, then you again investigate. So how do you, what are the warning signs of the headache? Anybody?
Neurological deficit.
Yes, deficit is one sign. Everybody else? So persistent vomiting could be a sign, yes. So we say to remember SNOOP 10. This is the, you should have over here. S10 for the, if the person has systemic symptoms like fever, bye, light come karo bhaiya, idhar thodi der ke liye. I'll pass on, my all slides are yours at the end. So it should not be a problem, but I'm just telling you. So first is a systemic symptom, somebody has systemic symptom like fever, weight loss, investigate. Somebody has a neoplasm history, wherever the neoplasm and comes with headache, investigate. Somebody comes with neurological deficit, you investigate. Onset of the headache after the age of 50, investigate that patient. And onset of the headache is a thunderclap. धाड़ करता 1 minute अंदर full headache થઈ ગયું. Investigate that patient. So SNNOO I did. Now I talk about the P10. So P is a change in the pattern of the headache. So migraine सब मैंने महीना में 2 बार थતું હતું. Now I'm getting 10 times, 15 times. Instead of 1 hour lasting 4 hours, 6 hours, not responding to analysis. So the pattern of the headache changes, investigate that patient. If the headache is precipitated by lying or standing up, change of position થી જો headache change થાય increase thigh, investigate that patient. If the headache is precipitated by lifting weight, coughing or sneezing, investigate that patient. If the person is pregnant and gets a lot of headaches, investigate that patient. If the person has a papilloedema, investigate that patient. If the patient has pain in the eyes with autonomic features, investigate that patient. If the patient has a progressively increasing headache, investigate that patient. If the person has HIV, investigate that patient. If the patient is using a lot of analgesic medication overuse headache, investigate that patient. So these are some of the P's that you should remember to, and this P's will help you to prevent from mistakes. So this will be the secondary headaches, 90% are primary headaches. Thank you. Now I invite Dr. Rahul. We'll be having the 25 cases. We'll begin opener, Dr. Rahul, to come on and take this. Where is this?
Good morning, everyone. I'll be presenting few cases which I think are quite interesting cases. Most of the cases are admitted patients, like they are not OPD cases. And these cases needed some investigations and some time to reach the diagnosis. So they are not actually that easy cases, but they are quite interesting, and almost all of them are treatable conditions. So I thought that the physicians will really be interested in knowing these treatable conditions, and when they should think about these cases and refer the patients or just try to investigate these patients. So the first case, this is a 50-year-old man who presented with 6-month history of muscle twitching and undulation kind of movements in the various muscles of his body, like in the calf muscles, the thigh, the biceps, triceps, deltoid, etc. So continuously he used to get twitching kind of movements like this. And there used to be mini jerks in the hand, in the fingers, when he was sleeping also, when he was awake also. Also he complained of severe pain in the legs, in the calf, thigh, in the upper limbs, and the pain was quite disabling. And the patient had visited multiple doctors. Because of this twitching he visited, and the pain he visited physicians, orthopedic surgeons, and he was treated with various types of analgesics and painkillers, gabapentin, pregabalin, combination of gabapentin, pregabalin, on all those things. He did not have any complaints of any weakness. Neither there was any sensory complaint. No complaint related to higher mental functions like memory, speech, everything was normal. Cranial nerves also no difficulty in swallowing, no double vision. So otherwise he did not have any complaints, neurological complaints. Neither were there any comorbidities, diabetes, hypertension, nothing. So on examination, his overall neurological examination was normal, except this type of twitching movements which was seen. See, you can see this twitching. Light, just can you switch off the light? Light. See. You can see this twitching here. See. also you can see, see. If you can see closely, these muscles are continuously twitching. So some kind of muscle activity is going on continuously. See here. And almost all the muscles in the body, there was this type of activity. So, can anybody just think what it could be? This twitching of the muscles with pain in a 50-year-old man. Otherwise, the neurological examination is completely normal, no comorbidity. There is no weakness, no wasting. There is no wasting. Atrophy, wasting is not there. So anybody can think what it could be. No response to NSAID, atopic paracetamol, or ibuprofen, diclofenac, or whatever, Ultracet, pregabalin, gabapentin, everything was tried. And if you used to hold like that, you used to feel the twitching like that. It is like continuous movement is happening in the body. So whenever you see twitching in the muscles, you, immediately what you think about is that this is fasciculation. Muscle twitching, fasciculation. And people think that it could be just a fasciculation, cramp fasciculation, benign fasciculations, or it could be motor neuron disease, wasting, weakness, like that. But this patient didn't have wasting, neither was there any weakness. So, what all we think of when there are twitching like that it is fasciculation. It could be benign cramp fasciculation syndrome, which is quite common. But in cramp fasciculation syndrome, usually the calf muscles only are involved, particular group of muscles is involved, and there is pain only in that particular muscles which are twitching, not everywhere in the body. In ALS, amyotrophic lateral sclerosis, or motor neuron disease, there is wasting and weakness. The patient didn't have this. In this multifocal motor neuropathy, it is a neuropathy, and there is significant weakness. This patient didn't have weakness. Another condition is myokemia, that this twitching may not be fasciculation, but this is some other type of muscular activity. It is myokemia. It can be seen in a condition known as Isaac syndrome, or it can be radiation induced. If patient has taken radiation for breast CA or whatever, then they can get this type of twitching in the region which has been given radiation. Some other rare conditions are there. I will not go into that. Metabolic problems, calcium deficiency, magnesium deficiency, potassium, hypothyroidism, hyperthyroidism. Sometimes drug induced also it is possible that there is twitching. Like antidepressants, levodopa can cause involuntary movements, dyskinesias. One can get confused whether these are dyskinesias. Chorea, like that chorea can happen. But here there is not movement of the joints, it is just muscular twitching. Sometimes myoclonus like that jerks can happen, but here there is no entire body is not jerking, only the muscles are twitching. Or tics. So we did a needle EMG, and in needle EMG we found that there is myokemia. There is a particular type of discharges you get in the EMG, wherein there are doublets and triplets, that is myokemia. Otherwise the nerve conduction was completely normal, the velocities were normal, and this patient was investigated for, so we diagnosed it as a myokemia or neuromyotonia or Isaac syndrome, and it is caused by some antibodies, and it is antibody mediated disease, voltage gated potassium channel antibodies or Caspar antibodies, which were positive in this particular patient, and we diagnosed him with the neuromyotonia Isaac syndrome. So the patient was treated with immunotherapy and the patient improved subsequently. So another case I will show you quickly. This is a 55-year-old man who was actually referred from neurosurgery with a complaints of pain and stiffness in the back and legs and difficulty in walking. This complaint was since many years, like 2-3 years. The patient's wife reported that he is walking very stiffly like that, like a robo. I'll show you the video. And there was no other complaint. He had, along with stiffness, Also he had pain and this difficulty in walking, otherwise there were no other complaints. He was investigated earlier since there was pain in the back, upper back, lower back. He was investigated for spondylosis by doing MRI of the cervical spine, lumbar spine. Multiple times MRI was done. And calcium deficiency, vitamin D deficiency, hypocalcemia. He received multiple times vitamin D course with calcium. Thyroid was investigated, was normal. MRI showed some minor spondylosis and he was being treated for that, but he didn't improve. On examination, what we found is that whenever he used to stimulate the patient for examination and touch his paraspinal region, there used to be spasms. He used to go into this kind of a jerk. That is what the positive finding we found. The deep tendon reflexes were brisk, but the plantar reflex was flexor. So even when the reflexes were brisk, the plantar is flexor. So there was no actual pyramidal system involvement. So you can have a look at the video. Otherwise, the examination was normal. You can have a look at this video and just see the way he is walking very stiffly. He is not moving the hands from here, and his trunk is also very stiff. See here, it's quite stiffly walking, and looks like he walks like a robo, like that, like that, like that, without moving his hands too much. And complaints of lot of pain in the paraspinal region with this stimulus sensitive kind of spasm. So you can see this abdomen, it is like board like, it is gone into a spasm. These paraspinal muscles are also completely into spasm. So what do you think about this? What it could be? Sorry? No, MRI was done. Presentation mode में कैसे next slide दिखता है ना? एक स्लाइड दिखता है, एक दूसरा स्लाइड भी दिखता है, पहले का वो किधर है? ये क्या है? ये प्रेजेंटेशन मोड नेक्स्ट स्लाइड में दिखता है, स्लाइड में ये वाला भाई कहीं जमने नहीं का करो नहीं पर ठीक है जानते ठीक व्हाट डू यू थिंक देन ठीक है जानते. So as madam said that paraspinal some collection abscess, that is a possibility, but his MRI was normal. Spinal cord, some spinal cord lesion we can suspect because of this spasticity kind of a thing, but plantar reflex was flexor, so there is no involvement of the pyramidal system. Hereditary spastic paraparesis, but in this condition usually patients will only have spastic paraparesis. The upper limbs are not that much involved and the trunk is also not that much involved. In Parkinsonism we have typically rigidity, not spasticity or not stiffness like that. The patients don't complain of that. Dystonia, there is abnormal involuntary movement in this, like abnormal posture. The patient didn't have. Another important condition one should remember is tetanus. Tetanus can have this type of presentation with spasms and stimulus sensitive spasms and patient having this type of a pain. But he was having this problem since 2-3 years. So tetanus cannot go on continuously for 2-3 years. And there were no other features kind of in this patient to suggest of any other diagnosis. So the description by the wife that the patient walks like a robo gave us a clue, and this type of walk like a robo is typically described in stiff person syndrome. So this patient had stiff person syndrome and his anti-GAD65 was positive, and he was treated with the muscle relaxants and immunotherapy, and he became better. So this I have discussed already, like he didn't have any other features. His anti-GAD65 positive, other antibodies also can be seen, anti-amphiphysin, anti-glycine. Anti-GAD65, many times it is not paraneoplastic, it is just an autoimmune condition, but if there is anti-amphiphysin, it could be paraneoplastic. Anti-glycine receptor antibody can also cause this cause similar presentation, but it is much more wider spectrum of presentation with paraneoplastic encephaloradiculitis and myelitis. So patient can have encephalitis, radiculitis, myelitis. Here in the EMG of this patient showed continuous muscle activity at rest, which is diagnostic. MRI was normal, other investigations were done, they were normal. And malignancy screening we have to do if amphiphacin comes positive, but this patient had anti-GAD65 positive. So we treated the patient with muscle relaxants, diazepam and baclofen, and steroids and IVIG, rituximab can be given in refractory cases. So I request Dr. Jayanti to take over. Next.
I don't want off now. So I'll be presenting a case. You have to be active once you are listening. Be careful. I'll ask any of you the questions. Case 1, 60-year-old farmer. He came with difficulty in walking, with progressive weakness of all 4 limbs and slurred speech since last 4 days. Progressive weakness. He had a rapid worsening of the weakness with respiratory distress and pooling of the secretions and required invasive ventilation. There was no history of fever, no headache, no vomiting, no viral infections, no loose motions, no vaccinations, no ingestion for occupational exposure to insecticide. So what comes to your mind at this stage? GBS, myasthenia, anything else? Snake bite, yes, absolutely correct. You all are genius. When you examine this patient is on a ventilator, he's febrile, 101-degree fever. His right inframammary craps, there's no neck stiffness. He was a little drowsy, but he was arousable. He was on the ventilator, obeying simple commands. Pupils were reacting to the light. His dorsal movements were present, but he was not so cooperative for the full extraocular movement examination. Maybe restricted, maybe it was there. Off reflex was really poor, and he was quadriplegic. And all deep tendon reflexes were absent, and plantars were mute. So what is your differential diagnosis after examining the patient? Again, same, or you differ or add or delete anything? Okay, so you all are right. We would think in terms of a GBS or GBS-like illness. Why GBS-like? Because he had a fever. So sometimes if you see at the GBS onset fever, you really think maybe this GBS or something else, or GBS with some septic encephalopathy, which would also be a thought, or else it's a Miller-Fisher syndrome kind of a thing, because eye movements are a little involved or maybe involved, and then that Miller-Fisher-like syndrome, they will come with the ataxia, areflexia, and ophthalmoplegia, right? So that was one of the thought. And in this patient, they may be a little drowsy. We think in terms of a Baker-Staff encephalitis. Another important differential, as you rightly said, acute neuromuscular paralysis like organophosphorus poisoning, and with encephalopathy or some occult snake bite. That was another thought. And third thought, we thought whether it is some encephalitis with the peripheral nerve involvement like ADEM, although we should see in younger patients, but in this age it is known, or rare viral illness like Westine virus would come with the neuropathy and the encephalitis. So these were really the thoughts. Any other thought you have at this stage? In case, please shout. So this was the basic thought we had, and this is how we investigated him further. With the MRI, brain was done, and it was reported to be normal. The further investigation revealed his counts were a little high. Hemoglobin was 12, and over 3-4 days, it rose to 25,000. His urea and creatinine were elevated, and it settled down over the next 4 days. His liver function tests were normal. His urine for formaldehyd was normal, which we do in GBS patients. His pseudocholinesterase levels were normal. His HIV was negative. Now conduction revealed axonal neuropathy, and X-ray had shown a patch, right? So, and we did a CSF as well, because in all GBS and GBS-like illness, CSF was done, and it had showed a high protein 76, sugars were 46 with a normal, with simultaneous blood sugar 82, cells were 54 with 95% lymphocytes. Gram-stain, Zil-Nilstain, India-Ing, bacterial culture, ADA negative, CSF varieties of the viral things were seen, herpes zoster virus, simplex virus, CMV PCR, all negative. Even for the listeria and TB PCR, they were all negative. So what comes to your mind at this stage? Anybody? This much of a rapid onset of a progressive weakness of all falling onto the ventilator, areflexia, little drowsy patients, little cells in the CSF, MRI normal. What comes to your mind? Shout, shout, shout. Autoimmune encephalitis, which is a good thought. What else? But we know MRI is normal. I mean it can be normal in a lot of patients. It's not perfectly fine. But this is also a thought. What else? So AIDP, GBS and GBS, but it had a little bit of odd 2, 3, 4 small points. A little bit of fever was there at the onset. Patch had developed at the beginning. It can also be possible. It's not, and he had a cells in the CSF, which we generally expect albuminocytology dissociation, right? So these are all good thoughts. I'm not saying denying. These are the real thoughts that should be there. So in the course of the hospital, what do you give this patient? So because odd patient, fever, this, that, you give masala treatment, which we all do. And he was given ceftriaxone, ampicillin, cyclovir, કાંઈ બાકી ન રહેવું જોઈએ, doxycycline, scrub, બાડવોડું કાંઈ હોય તો બધું cover થઈ જવું જોઈએ. We did all these things. And we sent the GQ antibody, Miller-Fisher variant negative. We could not send autoimmune encephalitis panel, as you said, because cost is a constraint. We are like a government hospital only, madam. And so there was a problem in this patient. No other autoimmune work. He said, nah, kind of happen. So what we did is, after giving 3 days of the antibiotic, we gave him methylprednisolone, right? So that, that autoimmune hoy to even cover થઈ જાય. This is what we did. We didn't do plasma exchange or IVIG because we were a little unsure about the diagnosis, not looking well patient. Doing plasma exchange was a bit tedious and cost was a huge factor. No improvement at all at this stage. Now, what should we do? Anybody? ઘણું કરી નાખ્યું આપણે. આટલા બધા એન્ટીબાયોટિક્સ આ તે ઘણું બધું કરી નાખ્યું. Quick, shout. IVIG. Okay, let's say we gave IVIG, didn't do well. Now what? So because he was a little drowsy, some fever was going on, cells in the CSF, IVIG આપી આમ માઇન્ડમાં આમ બેસતું નહોતું સારું કે આમ ક્યાં બેસાડીએ એમ ફિટ ક્યાં કરીએ એમ એક ક્લિયર ટ્રેક મળી જાય ને એક નામકરણ થઈ ગયું હોય then we are really more sure what we are doing it. What would you do? AKT, wow, that's also a thought. 4 days history of rapid quadriplegia, a little bit bigger ask, but yeah, you may give additional. ચલો એ આપી દીધું, no improvement. So what we did is, we inquired about the history of bite in this patient. They said, nah, sahib, okay, hota hai. Yeah, this is a thought, yes. So he has been sleeping in the farm to guard the crop since last 20 days, right? And so we performed the neck biopsy to say, okay, nah, rabies hai jashe. Biopsy was negative. Now what? So we said, nah, I would know, CSF for rabies virus was in PCR, again negative. Now what? Anybody? આપણે rabies વિચાર ના પાડે સગાવાળા, આટલું બધું કરી નાખ્યું, પણ ના પાડે હજી. Now what would you do? What is that? Tick paralysis? Okay. But we are giving him doxy and giving him ceftriaxone, બધું કવર કરવા માટે આપણે બધું આપી દીધું છે એને આમ કદાચ હોય તો ટિક આપણે ત્યાં એક તો રેર છે, but yeah, that can be a thought. What else? So what we did is, we thought of, that rabies only, and so we sent a saliva rabies virus PCR. We sent 3 samples at the different times, and the 3rd sample was positive, and so it is a dumb rabies. You are absolutely right. Big clap for sir. Great. So the paralytic rabies. There was one clue in the history and examination or investigation that this is the rabies. Can anybody tell what was the clue? Genius person. Residents. There was one clue in the history, examination, investigation. Kya rabies howana chances bahut vadare છે. You know what? That if it was not there in this patient actually, we would have allowed that. If you get one side paresthesia, fasciculations, arm weakness, unilateral focality, then we can think, okay, ત્યાંથી rabies શરૂ થઈ ગયો છે કદાચ, but that was not there. CSF, there was a clue in the CSF. His CSF had shown more than 50 cells. Whenever you see a 50 cells in a GBS-like illness, think of 3 conditions. HIV is negative, polio is out, and 3rd was a rabies. And therefore, rabies is a strong contender. GBS-like illness, cells, think of these 3 conditions. And when we look back again the MRI of this patient, which was reported normal, there was a patch which was seen in the dorsum of the pons. So whenever you see a little bit of a patch in the dorsum of the pons, midbrain or medulla oblongata, that somehow in this type of history would tend to think more in terms of the rabies. So the diagnosis of the rabies should be when you are thinking you should send a salivary PCR, good sensitivity, 80 to 90%. You have to send multiple samples because the shedding is intermittent. PCR was the routine what we send CSA PCR, 50 to 60% sensitivity, still good. Neutralizing antibodies, not so good. And so if you really send anything, do a combination of skin biopsy of the neck and salivary PCR. This combination would work best in this situation. So my poll of the case is differential diagnosis of rabies should be considered in any patient with and without history of exposure, those who come with a clinical picture of agitated or paralytic encephalitic illness. But the encephalitis is vicharanoj. All patients of GBS or acute flaccid paralysis think of the rabies. And whenever the encephalitis progresses very fast, think of a rabies in our situation. Thank you. Rahul. What is that? Level drowsy, little mildly encephalitic like illness on this thing. And so this is very typical. So whenever, another one important clue is, whenever you get a fever at the onset of a GBS, think about rabies. Local paresthesia, as sir said, think about rabies. Fasciculations, if I had one patient who admitted as GBS, nothing was told. And second day when I went, રાત્રે 12 વાગે દાખલ થયો, મને ખબર જ ન પડી, 10-15 સેલ્સ આવ્યા હતા ખાલી. 3 દિવસ history. And morning I went and fasciculation. I was just wondering, what is this fasciculation? Then we asked the history, and they gave the history of a rabies. One of the relatives get the history of rabies. So all across fasciculation, GBS like illness, yeah? Once you diagnose, 5-7 દિવસ. ક્યારેક લાંબુ. No, overall 10-12 દિવસ હાલે, 5માં 6 દિવસે diagnosis, 6-7માં દિવસે diagnosis, 4-5 દિવસ બીજા. 5 દિવસ જોવે, 12 દિવસ જોવે, 14 દિવસ જોવે, what difference it makes? We are all done. But there are case reports in the literature, some MICU's methodology, they give a lot of ketamine and diazepam like drugs, and these people, they survive somehow a little longer, but I think those are all case reports in the literature. At least I haven't seen any patient surviving. Neither we are so aggressive in managing this patient for months together on the ventilator. 30 વાળા કદાચ કરી શકે આ બધા protocols.
ठीक है
नेक्स्ट ऐसे चेंज होगा, लेकिन वो जो आप चाह रहे हैं वैसे वो आ जाता है यहीं पे इसी में।
इसमें नहीं है, एक्सटेंड में है क्या?
हाँ एक्सटेंडेड किया, लेकिन एक्सटेंडेड में चेंज नहीं हो रहा आपके, एक बार करिए फिर हो जाता है इसमें, लेकिन हो नहीं रहा, यहीं से होता है।
डुप्लीकेट करो ना,
डुप्लीकेट करके देख लीजिए, चेंज नहीं कर रहा अपना। जो वायरिंग है इसको रिलेटेड में यहीं पे रहने दीजिए, यहीं पे रहने दीजिए।
Hello, yeah. So we'll move to the next few cases. So this is a 20-year-old girl who presented with irritability, confusion, change in personality since 3 months. She became drowsy since 2 weeks, and we noticed orofacial involuntary movements, that is dyskinesias on the face. So this is the video of orofacial dyskinesias, you can see. See, this type of orofacial involuntary movements were seen here. So what do you think? Like patient presented with orofacial involuntary movements, cognitive decline, and encephalopathy. So with this type of presentation, you always think of that it could be some viral encephalitis or autoimmune encephalitis. So very simple. So this patient was investigated for autoimmune encephalitis. Example: NMDA, LGI1, Caspar-2. Out of these three things, which one is more likely to be there in this particular patient? NMDA, LGI1 or Caspar-2. I'll start from the reverse way. Caspar-2, it is a antibody against the potassium channels. It can have central nervous system manifestations and peripheral nervous system manifestations. So central nervous system manifestations, usually myoclonic jerks, seizures. Peripheral nervous system manifestations, I showed you earlier, muscle twitching and myokemia, neuromyotonia, and continuous muscle fiber activity. LGI1 encephalitis usually seen in elderly patients. Male and female equal frequencies, male slightly higher frequency I think, but usually seen in elderly patients with cognitive decline, dementia which progresses over a period of few months, along with faciobrachial dystonic seizures. NMDA receptor encephalitis typically seen in young adolescent females, young females, much more common in females and at a younger age, associated with ovarian teratoma, and typically has a presentation over a period of few weeks or months, with initial presentation being like a psychiatric condition like anxiety, irritability, depression, behavioral disturbances, followed by that seizures, status epilepticus, focal seizures, and involuntary movements involving the orofacial muscles. So this particular patient fitted more into NMDA receptor encephalitis, a young patient with behavioral problems, followed by that encephalopathy and orofacial dyskinesias. Another possibilities you can think of is Wilson disease, but it is usually this presentation was very fast. There is no hepatic involvement. SSPE, subacute sclerosing parencephalitis. Usually they present with cognitive decline and falls because of myoclonic jerks. So they don't have this orofacial dyskinesia, but they have axial myoclonia, and the myoclonic jerks leads to recurrent falls. Prion disease at this age very unlikely, and they also have stimulus sensitive myoclonus. Drug-induced dyskinesia, it can happen with involuntary movements with dopamine blockers, but usually those patients will not have any encephalopathy or cognitive decline. So this particular patient, 20 years old, typical age presentation for NMDA encephalitis, duration of illness 3 months with irritability, confusion, neuropsychiatric presentation, personality change, which in many cases is the initial manifestation. Then many patients will be misdiagnosed to have some psychiatric condition or a primary psychiatric disease like psychosis or something like that, and they may be treated in the psychiatric ward, but then later on when the patient develops seizures and orofacial dyskinesia, at that time only it may be suspected that they have NMDA encephalitis. Progression to decreased level of consciousness over a period of few weeks after the initial presentation, that again suggests that there is something happening in the nervous system. It is not just a psychiatric problem. And this particular typical characteristic movements are very typical of NMDA encephalitis. Orofacial dyskinesia, like that, some kind of movements, lip smacking movements, tongue movements, grimacing, facial twitching are very characteristic. So initial psychiatric presentation, which is actually a neuropsychiatric presentation, that means that the psychiatric presentation is because of underlying neurological problem, followed by that there is cognitive decline in the form of a subacutely evolving encephalopathy, forgetfulness, etc. Followed by that impairment in the level of consciousness. Patient can become drowsy. Patient can have seizures, and they can have focal seizures or focal status epilepticus. along with movement disorder. So whenever you have this type of a presentation in a young patient, especially in women, then NMDA encephalitis is a very high possibility, and these patients have to be thoroughly investigated for the presence of ovarian teratoma. So ovarian teratoma, you screen them with a ultrasound or MRI scan of the pelvis. Many times ultrasound may not detect it, so MRI scan of the pelvis may detect a small ovarian teratoma. In some cases they have said that if the NMDA encephalitis is positive in the blood and the presentation is very typical, and the patient is having refractory seizures or refractory kind of encephalopathy, drowsiness, involuntary movements or status epilepticus, then in those patients, even if a teratoma is not shown to be present on MRI scan, they have done exploratory laparotomy and tried to remove the ovary. And there are some case reports that this type of patients have actually benefited from oophorectomy. So this you have to keep in mind. Another similar case, quite similar, I will just run through this case. 17-year-old female resident of Latur district in Maharashtra came with complaints of seizures and behavioral changes for 15 days. She was apparently all right before this illness. She had mild fever for 2 days. So it was like a viral encephalitis, they thought. There is a fever and patient became altered and had seizures. She had multiple episodes of seizures with impaired awareness, required admission. Then she went into status epilepticus. She was given injectable anti-seizure medicines outside, after which the seizures stopped, but again the seizures recurred. She was investigated, MRI brain was normal. She was discharged subsequently from the private hospital in the district place on oral anti-seizure medicines. She was alright for 2-3 days. Again the behavioral abnormalities increased in the form of irritability, crying, calling out names of different deities and calling out the relatives which have already passed away. And she also had this typical orofacial dyskinesia. You can see these type of movements. I deviation to one side suggesting that there is a focal seizure going on along with these movements. Patient is encephalopathic. She was drowsy, partially responding to commands. Further she deteriorated, and then she was treated with, we investigated the patient, CSF was just, it was normal, MRI brain was normal. EEG showed typical delta brush activity. Delta brush is a particular finding on EEG. When you get this type of delta waves, along with that there are small brush-like appearance on the top of the delta waves. This is delta brush activity, which is highly suggestive of NMDA encephalitis. Her NMDA report came positive and she was diagnosed to have NMDA encephalitis. So this is the positive report, and this patient was treated initially with, as soon as we saw the patient, we were just leaving, then again they called, see patient is having these involuntary movements. So then we saw in the patient again, and with the presence of these involuntary movements, we were sure that this is NMDA encephalitis. Even before the report came, we started the patient on methylprednisolone, and once the report came, we escalated the therapy to plasmapheresis. And even after 5 cycles of plasmapheresis, the patient was not completely normal. So after a week, we initiated early rituximab in this particular patient, and this patient received rituximab, and after that now she's better and the encephalopathy is not there, the seizures have come under control, and she is going to be discharged. She was still admitted till recently, she was going to be discharged.
Excellent case. Excellent. In our setup, whenever we see such encephalitis illness, if you give them methylprednisolone, then talk of plasma exchange, patient ઘરે બહાર અમદાવાદ આવી જવું છે ને જવાની વાતો કરે. We do not able to sustain lot of patients. You are lucky people to be in the tertiary center. ये भी कर दिया, प्लाज्मा में भी कर दिया, उसके बाद भी पेशेंट इंप्रूव नहीं है कि चलो अभी उसको रुटुक्सिमैब भी देते हैं, and then get the surgery done for the ovarian teratoma and get the relief. You people are all born with a golden spoon, I think. Okay, we begin with case 2. This is a 39-year female. She presented with progressive difficulty in walking and multiple falls since the last 6 months. She had a gastric bypass surgery done 1 year earlier before this presentation, and she was maintained on adequate diet and multivitamin supplements. So she was doing pretty well, and last 6 months, this was a difficulty in walking with falls. Her symptoms started in the form of mild imbalance with tingling in the toes since last 6 months. This progressed to the point where she could not feel the feet on the ground, and she had a very difficulty in walking in the dark. More recently, she had lost the feeling in the fingers, and she reported they are like numb, and she had some stiffness in the legs. What comes to your mind at this stage? My God, we are having a genius people sitting in the crowd, you know. So you have seen so many cases. Post bypass. Why? She was very well maintained. She's on vitamin supplements. She's having an adequate diet. Yes. So his neurological examination did reveal spasticity, increased reflexes, plantars were extensors, and there was an absent ankle reflex and loss of joint vibration sense and ataxic gait, and everything is like that. And therefore, this investigation had shown two things: axonal neuropathy, and he had an inverted V sign on the MRI. This inverted V sign is very important. Whenever radiologists see this inverted V sign, they just jump into the diagnosis. This is subacute combined degeneration. So this V is involved in the posterior columns, and this laterally, these white signals that you see, these are the involvement of the lateral column. So this is a pyramidal tract involvement, and that is a posterior column involvement. So this is a combined degeneration of the two columns, lateral column and the posterior column. And so whenever you get this combined degeneration, you are really thinking in terms of the subacute combined degeneration of the cord. And in these patients, the B12 was borderline low. What do you think? Nothing karelu. Multivitamin haldi thi. I still agree with you. So you know what happens whenever somebody's B12 is little low, you send a homocysteine level. If homocysteine level is high, as it was seen in this patient, you are again thinking in terms of a B12. But both B12 and folic acid would produce elevated level. And so what is more helpful is a methylmalonic acid level, which was elevated in this patient. So ekad injection ne laine aayo and B12 level high padave ne, you not to worry. You to send the methylmalonic acid level. So in a proper clinical context of this subacute progressive course with a subacute combined degeneration with an elevated methylmalonic acid level, you are really thinking in terms of the vitamin B12 deficiency as a cause. So what are the three common manifestations of B12 deficiency? Posterior column and lateral column subacute combined degeneration. Second is a peripheral neuropathy, they come with just a neuropathy. And third is a middle cognitive decline. So these are three common manifestations of the vitamin B12 deficiency. So how do you treat this patient? We all know. Oral or injectable? Injectable. Yes, absolutely. So we should always give injectable B12 this patient, simple case, initially daily, then weekly, then monthly, and subsequently you can put this patient on the oral once the patient has improved. And so the So this was multivitamin na આપણે કેમ બેપ્લેક્સ ફોર્ટ થોડું દુનિયા બનવું આપી દીધું હોય કંઈ B12 particular ન આપ્યું હોય, you know, and this absorption of this B12 would occur in the, there is a gastric acid it is released, and then finally at the end of the jejunum it is released. So that pathway is not so working well. Ideally these patients should be periodically examined. Moment of the little symptoms, they can be put on the monthly B12 injections. Like you should not progress to this stage. And a lot of time if subacute combined degeneration is diagnosed late, patient may not have that good recovery. It may look good in the class, but when you see the patient, they are still walking stiff, even if they are recovered partially. They may express their happiness, but they still walk with some deficit. So earlier you diagnose, the better it is. So all of the cases, this is a classical presentation of SSED with peripheral neuropathy, and B12 is a cause. So this MRI and elevated methylmalonic acid is a clue. And the simple case. This 27-year lady, left-handed, gravida 1 para 0, was admitted with this side, they are all genius people, this side. They are also genius, but we will want this side to answer. She came with double vision, ataxia and confusion since last 2 days. She was 36 pregnant and having a severe hyperemesis gravidarum throughout her 3rd trimester. The day before the admission, she was feeling drunk and seeing double. And on the day of admission, she was disoriented and delusional. So what thoughts come to your mind? So you examine this patient, she's an unattentive, apathetic patient who is actively hallucinating, diffusely ataxic, and she has a little bit of a horizontal nystagmus, a little bit of a restriction of the movement on the left side when she looks, and so she had a diplopia with a nystagmus, she had a severe ataxia, and she was apathetic. So What are your thoughts? Hyperemesis gravidarum lady coming to you with ataxia, ophthalmoplegia, and confusion. What comes to your mind? Genius people? No. Wernicke's encephalopathy. Who said that? 2 gifts to that person, genius person. See, whenever we always think, like, you do an MRI of the brain in these patients. The MRI did show there are these lesions. There is a, around the midbrain or periorbital region, you get that hyperintense signal, which is also seen on mammillary bodies and in the medial thalami. When you get this, you are like, okay, radiologists would love to see this. And so this diagnosis is Wernicke's encephalopathy. We always think Wernicke's encephalopathy means alcoholics. Of course, 90% of the time it is alcoholics. But what about the 10%? They can also come like this. Short history, best treatable condition. You should always think this condition in the mind. So her serum B12 level was sent, somehow it was low. And she was emergently treated with thiamine. It's a very big dose, 3 times a day. And after that, she was put on 100 or 200 milligram daily for a week. Her ocular symptoms improved in 1 day only. And subsequently, there was a resolution of ataxia and encephalopathy. So my poll of the case is, this is a non-alcohol related Wernicke's encephalopathy due to hyperemesis gravidarum. See, vitamin B1 doesn't remain in the body too long. And this patient was vomiting away, and she was not, whatever vitamin B1 she was taking in the food was not remaining, and the fetus will deplete that store as well, and resulting in Wernicke's encephalopathy. So prolonged vomiting is one of the reasons why people develop the Wernicke's encephalopathy. And it is only hyperemesis gravidarum where you get this full triad of the encephalopathy, ophthalmoplegia, and the ataxia. But in alcohol-related encephalopathy, they can come only with 1 or 2 things of the triad. So in alcoholics, you have to be really vigilant. You may give just out of this thing, thiamine. There is no harm in giving thiamine. It's a very cheap drug. But this Wernicke's encephalopathy due to hyperemesis gravidarum will come with usually with complete trial. And recognition is very important because it carries a high mortality. And so this is a photograph to show that thiamine deficiency can come as a dry beriberi or as a wet beriberi. When it comes in the form of the dry beriberi, you have your encephalopathy, ataxia, ophthalmoplegia. They can also come with this calf pain, tingling numbness in the limb, severe peripheral neuropathy. So this is one side. On the other side, they can come with orthopnea, dyspnea on exertion, edematous patient, lot of edema, feet of the whole body, and the dilated heart with the basal capitations. So this could be either the presentation, and this you will usually see in a patient who is elderly or with bedridden, poor intake, alcoholics, or HIV end-stage patients, and CRF patients, and so forth. So what is the list of the, I'm going to list of the non-alcoholic causes of the Wernicke's encephalopathy. So this would include the prolonged starvations. Our Jain people, once they stop the fast, they are in the trouble if they just drink only the glucose. Second, hyperemesis gravidarum. Bariatric surgery, and those bariatric surgery which is complications, HIV and AIDS patient, complicated GI tract disease, celiac disease, or those chronic diarrheas, they are not able to retain the thiamine, they are at risk of developing these disorders. Cancer that has spread throughout the body, poor intake that can be responsible. Heart failure patients who are on long-term diuretic therapy, long periods of IV therapy without receiving the thiamine supplement. Head injury patient, babbe mahina badi rahe ICU ma, and when the thiamine appa no aave, they can develop these complications. Long-term dialysis patients, very high thyroid hormone, thyrotoxicosis can have this. CRF patient can have this. Carbohydrate reloading, કે ભાઈ આપણે સાધના કરી પછી કાર્બોહાઈડ્રેટના જે જ્યુસ પીવડાવી નાખે 2 ગ્લાસ, you can rapidly deplete the thiamine and you can have this Wernicke's encephalopathy. So feeding after starvation, if it's only a glucose, then you can land in the Wernicke's encephalopathy. Thank you. You all know this cases, but I just revise for you. Come. Any questions so far till Rahul changes this, because we would not waste the time. What is that? Lifelong. Monthly, madam, month. So initially you can load it for 3 or 5 days because you want the stores to be depleted. See, once you are full now with the B12, the stores will remain for you for 5 years. Almost that much is the storage capacity of the B12. So it remains. But if you stop, you forget, 6 months, 1 year, 2 years line, now you become suboptimal. Then you up mein jo baat ho, you thodi kam ho jayegi. You would not dementia, you end at the very late stage. Tiredness and little bit of other symptoms, they keep coming to you, which you will not realize it. So if you have a significant B12 deficiency, there is no harm in taking one injection. And US people, they keep taking oral supplements daily. I mean, so once in a month, I believe that, but it's a personal choice. You can take oral B12 if you are severely deficient. Prolonged fasting में છે ને ખાલી ગ્લુકોઝ પીવડાવે એના કરતા એક see, I mean, ideally you would document it કે thiamine low છે એવું તો થતું નથી હોતું. So you can give them vitamin supplements, or if possible, you can give them one drip of, optinone ની એક drip આપી દો, સેફ થઈ ગયા, ગમે એટલું પછી ખાય. કારણ કે પહેલા છે ને ગ્લુકોઝ 2-4 ગ્લાસ પીવડાવી નાખતા છે. I mean, it's a dangerous thing. હવે ગાડી ફાસ્ટ રાખી દરેક વખતે એક્સિડન્ટ નથી થતું, પણ થવાની શક્યતાઓ ઘણી સારી હોય છે. So I believe that if you are on a prolonged fast, એક બે ચમચી પીધી હોય ત્યાં સુધી બરોબર છે, પણ લોકો ઘણા ગ્લાસ પીવડાવી દેતા હોય છે. જો એવું થાય તો you run that risk of vertigo encephalopathy, because moment somebody is depleted with thiamine, you take glucose, the glucose depletes the thiamine acutely further, and so it precipitates vertigo encephalopathy. The chances are there, not necessarily it will happen, but I would say that એક ઓપ્ટિનોન ઇન્જેક્શન લઈને લ્યો તો શું વાંધો છે. આપણે આલ્કોહોલિક પેશન્ટ સીઝર સાથે આવે તો આપણે ગ્લુકોઝ નથી આપતા, પહેલાં આપણે એને થાયામિનનું ઇન્જેક્શન આપતા હોઈએ પછી ગ્લુકોઝ આપતા હોય. હવે આપણે રેસિડન્ટ હોય કેટલા એમને આપી દીધા, કંઈ થતું નથી, એ જુદી વસ્તુ છે. બટ ધ લો ઇઝ do it in a proper fashion. Thank you.
Coming to the next case, this is a slightly longer case, and it will be nice if there is some interaction in this case. This is a 27-year-old male who presented with history of recurrent pleural effusion for 2 years. He was treated empirically with anti-TB treatment, though there was no AFB found in the pleural fluid. Now he presented with complaints of cough, breathlessness, chest pain, and again there was a pleural effusion. The reason why he was referred to the neurology department at Nair Hospital was that he started complaining of double vision in the horizontal gaze. So there was some involvement of the cranial nerves, horizontal gaze, double vision. So it could be either lateral rectus palsy or it could be medial rectus palsy. On examination, you can see there is abduction impairment here. You can also see that this palpebral fish is slightly wider because of the left element facial nerve palsy. So 2 days later, he developed complete facial weakness, which became more apparent, and he had complaints of swallowing difficulty also, with deviation of uvula to the right and gag reflex absent. So can you just interpret what is happening to the patient? Causing what? No, there is cranial nerve involvement. There is no encephalitis. There is cranial nerve involvement with 6th nerve on the right side and the 7th nerve on the left side. So there is multiple cranial nerve involvement in a patient who was being treated for tuberculosis, pleural effusion since 2 years. But this is getting recurrent pleural effusion. TB bacteria was not demonstrated most likely. So there is lower cranial nerve involvement also. Uvula deviated to the right. That means left 9-10 nerve is affected. So right 6th, left 7th, left 9-10th. Yeah, so anybody would think that the patient has got TB meningitis with involvement of the lower cranial nerves and involvement of the basal cisterns. The patient has got 6th nerve palsy. Like that is a common whatever. I mean, anybody would think that. So this localizes to, first we go to localization. Now always in neurological examination we want to localize. So this localization is correct. There is involvement of multiple cranial nerves which are mostly getting affected in the basal cisterns or basal meninges, or there is something happening in the leptomeninges at the skull base with involvement of cranial nerves as they go through the subarachnoid space. So right 6th nerve, left 7th nerve, left 9th and 10th cranial nerve involvement. So multiple bilateral cranial nerve involvement, but these nerves are not near each other. The 6th nerve is on the right side, seventh nerve and the other cranial nerve on the left side. So they are multiple here and here. So it is patchy or multifocal involvement of the cranial nerves. So the pathology mostly is not just spreading like that. It is affecting in multiple regions. Here also, in the chest also, like that it is happening. So this could be classical for basal meningitis, leptomeningeal pathology, rather than a focal brainstem lesion, because it is affecting at different places. If there would have been brainstem inside lesion, patient would have been more drowsy, there could have been long track signs, pyramidal findings, but that is not there. So we thought that there is basal leptomeningitis, leptomeningeal involvement, and some kind of inflammatory disease. If TB bacteria is not demonstrated, it could be some other inflammatory or infiltrative condition, like sarcoidosis, for example, which can mimic tuberculosis. It's a great mimicker. So we thought of that. So given 2-year history of pleural effusion, patient was already on anti-tubercular treatment in the general medical ward at Nair Hospital. Then, since he started developing these neurological problems, we got involved. And we said that this is a progressive multifocal involvement, multiple cranial nerves are affected, there is a cranial polyneuropathy, we need to investigate the patient. So we kept a differential diagnosis as we discussed tuberculosis. Fungus is unlikely because patient usually, if it is immunosuppressed, then you can have this. Neurosyphilis, you don't see that much. Another possibility which we thought is it could be some kind of a carcinomatous meningitis. That carcinoma is hidden somewhere, and there is carcinomatous meningitis or leptomeningeal carcinomatosis, lung, sometimes it may be just hidden. Lymphoma, I thought that it could be lymphoma with involvement of the chest, lymph nodes. Pleural effusion could be because of some malignancy, if there is a bronchogenic carcinoma. But there was no RBCs in that. So I thought, you see whether RBCs are there. RBCs are there, but there are no RBCs. It was not a hemorrhagic pleural effusion. So probably it was unlikely that it is a bronchogenic carcinoma. Another possibility, we thought it could be a lymphoma, lymphoma which is spreading into the nerves like that. Or I told that neurosarcoidosis, which can mimic to TB. It can cause pleural effusion, mediastinal lymph nodes, and cranial neuropathies. Or some other conditions like IgG4 mediated diseases. IgG4 mediated diseases can present like that. They are infiltrative diseases where there is deposition of IgG4 plasma cells and fibrin deposition happens. Some unusual immune mediated condition, vasculitis, etc. is possible, like that we said. So then this patient underwent a CT chest, and you can see there is a mediastinal lesion here like this. There is a big mediastinal lesion. So they thought it could be a thymic, lymphoma. Lymphoma was a possibility, or a thymic neoplasm. Thymic neoplasms usually don't spread like that to the nervous system. So lymphoma, which was considered in the differential diagnosis, remained very high suspicion. And this patient underwent CT guided biopsy. And CT guided biopsy showed T lymphoblastic lymphoma in the mediastinum, and which was spreading over there in the nervous system, causing multiple cranial neuropathies. So a very interesting case. The patient received chemotherapy, and now subsequently the patient is fine. Okay. So lymphoma with multiple cranial nerve involvement, multiple cranial nerve involvement was evolving. When the patient was referred, initially there was only diplopia, then seventh nerve came after 4-5 days. In the beginning only little bit flattening was there like that, and then afterward complete seventh nerve palsy, then lower cranial nerve involvement. So we thought that it is basal meningitis, infiltrative lesion, TB, sarcoidosis, and lymphoma, because the TB was unlikely actually, because the patient didn't have any constitutional symptoms, and patient was not toxic. TB, if it is involving the basal meninges, then patient will be toxic. Patient will have a lot of headache and fever and altered sensorium. This patient didn't have that, so it looked like more of an infiltrative lesion rather than an infective lesion. Infection means there should be some fever, headache, vomiting. TB typical presentation was not there. Already patient was on TB treatment, but recurrent effusion, pleural effusion was happening, and TB bacteria was not demonstrated on that gene expert and other tests. So TB was actually unlikely, and we had, before the biopsy report only, we had thought of lymphoma as a high suspicion. So consider lymphoma if there is this type of multifocal involvement, And lymphoma should be considered if there is mediastinal involvement, anterior mediastinal, with especially lymph nodes. If they say the lymph nodes are enlarged, then lymphoma has to be kept in mind.
After Rahul's difficult cases, I come with a simple case. जो जैसा बोले करो. Yeah. A 48-year male patient who is obese and alcoholic. He came with an acute onset of dizziness and difficulty with balance. His blood pressure was 210/113, normal pulse saturation, little bit high sugar 187. His NIH stroke scale was 2, that means he had just an ataxia in the limbs. The rest of the neurological examination was fine, unremarkable. He was given a medication lisinopril few months back for hypertension, didn't take it, which is our usual story. And he was not on any antiplatelet or anticoagulants. So acute onset of a dizziness, difficulty in balance, obese, alcoholic, severe hypertension. And his labs were also unremarkable, coagulation factors and platelets were within normal limits. What do you do at this stage? MRI. Okay, you may do MRI, but we are small people, we did a CT. So CT had shown, because the person did not have money, so we did a CT, and CT had shown this. What do you think he has? Yes, excellent. So this is a cerebellar bleed, but if you see carefully, there's a mild hydrocephalus as well. And if you see the size of the cerebellar bleed, it is more than 3 centimeters. On one single cut, if it is more than 3 centimeters, this is something, at least I don't like it. So, and his CT angiogram was done, and which did not show any vascular malformation. So what do you do next in this patient? This patient, very good. So that is excellent. Big clap, big round of applause to you. This is the excellent thing that you should do in all the patients. But suppose you don't do that, then what do you do? Suppose you have to manage, surgeon bahar se, so what do you do? ધક્કો મારવાનો કે બીજે વયા જાઓ ભાઈ. But this patient says કે ના ના સાહેબ અમારે તમારે ત્યાં રહેવું છે, સર્જનને નથી બતાવો, દવા કરો. Which is possible. So what we do is we manage with the blood pressure. Yes, so blood pressure control is a very important thing in this patient, and you try and bring down to 130 by 130, 150 systolic within 2, 3, 4 hours. The most important thing in the blood pressure control is there should not be peaks and ups and downs rapidly, and therefore, if possible, you can give an IV infusion, whatever you like it. I like labetalol, and that will bring the sustained reduction of the blood pressure. That is very important. When the blood pressure jerks in between, then there are chances of the hematoma expansions are very high. Another important thing, if the patient has been on, by any reason, on anticoagulants, then you have to reverse that. Even hypertensive patients with this type of bleed, they might be on, for any reason, warfarin, and they can come, and therefore you have to really look in all the bleed patients for this thing. And in this patient, there was no issue. And third thing is you should always talk about the surgery in all these patients. At least વાત તો કરી લેવાની, ન કરાવો એની ઈચ્છા થાય છે કે એમ ના પાડી તેમ કા patient. And nimodipine, you give nimodipine generally when you are suspecting the aneurysmal bleed. This is a pure bleed in the area. There are 4 hypertensive sites. One of the sites in the blood pressure is the cerebellum. Whenever you get a cerebellar bleed in a severe hypertension, we really think that this is a hypertensive bleed. Although in this patient, CT angiogram was done because somebody said, karao. And so therefore, we had ruled out that aneurysm thing. If there is that, then yes, there is some role of nimodipine. Another important thing in all the patients who come with this bleed is a bundle care, we use the word. That means you do a good neurological examination hourly because this is a serious patient. You look for the sugars, you do maintain the sugars, you look for the temperature, each and every important things, they increases the mortality, right? So you do a thorough examination every hourly, good glycemic control, euthermia, good nursing care. If you're not confident, shift to the centers, stroke center, and if the person slightly worsens, you repeat the imaging. And so 4 hours later, this blood pressure of 147/98 on labetalol infusions, but now he become more lethargic, difficult to arouse, does not maintain attention during exam. He closed the eyes shortly after he was told to open, and so he has worsened in 4 hours only, right? We saw it was a more than 3 centimeter size on one plane. When you see, these are the dangerous people. Dhakko જ મારી દેવાનો હોય, but he said no, and therefore what would you do? We would repeat the CT scan of the brain. So CT scan had shown now the bleed which has become a much bigger size, more compression force ventricle, and the hydrocephalus which was initially minimal and now has become a reasonably big size. So what do you do now? ધક્કો તો મારવો જ પડે, right? So then he said, हाँ साहब તમે જેમ કરો, patient બગડી ગયું છે આમ તેમ, and therefore he was referred to the surgery, and emergency suboccipital craniectomy was done with EVD placement. But because it was a late, his luck was also not good, and there was a complications because of that tract hemorrhage with the EVD placement. Significant intraventricular hemorrhage occurred subsequently and a lot of cerebral edema. So when you treat the patient late, chances of getting the problems are very high. And post-op, he did not do well. He was intubated, remained comatose for a long period. Although his scan improved, if you see the post-op scan, some improvement. Surgeon had done great, but because of the third ventricle bleed, lateral ventricle bleed that he has developed, the patient did not do well. They look at his big ventricular bleed is seen now. And so he remained on the ventilator for a few days and passed away. So you have to be sometimes very aggressive whenever you see a big bleed in the cerebellum. You can't afford to wait. Another similar case, this 52-year-old lady, she presented with acute vertigo and imbalance, similar presentation. She was awake, did not have any weakness or sensory symptoms. She had a history of hypertension and she was on 3 antihypertensive medications, right? What do you do when she comes with acute vertigo and imbalance? We did a CT scan, and CT scan had shown intracerebral hemorrhage in the cerebellar hemisphere. It was a 13 ml volume. And there was a mild effacement of the fourth ventricle and without any hydrocephalus. This is very important. Whenever you see a cerebellar bleed, look how much it is compressing the fourth ventricle and how much is hydrocephalus. If the compression is remarkable and hydrocephalus is moderate or so, then you are really to be aggressive. You have to push the patient for the surgery. But here was a conscious patient, no hydrocephalus, minimal, and this is the bleed. If you see the previous bleed, this looks reasonable. It's still a big bleed, right? And so whenever we see a cerebellar bleed, if we see one cut more than 3 centimeters, we are more worried. Or overall volume in 3-4 cuts we see, if it is more than 15 ml volume, these are the dangerous patients. You push them. If the less than 12 ml volume, then you generally are safer. But in 12 and 15 ml volume, it is a in-between area. So this was a 13 ml volume. So, patient was conscious. And therefore, his blood pressure was 188 by 104. She was put on labetalol drip as we did it. And so how would you manage this patient? Medically or surgically? Surgically. Medically? Arey bhai, you have to answer it. Medically? Medically? Medically, medically. So this was a patient who was neurological examination was reasonable. It was absence of hydrocephalus, and because the volume was 12 to 15 ml, that gray zone, because of the patient was reasonably stable, it was thought that chalo, we'll treat you medically. Our patient has surgery, so it was decided to treat you medically. And so she was admitted in the neurocritical care unit and close monitoring was done. CT scan was repeated on day 3 and it had shown some evolution of the perihematoma. She did not worsen. Clinically she was fine. A little bit of a perihematoma edema was there. Partial effacement of the fourth ventricle, but still there was no hydrocephalus on day 3 and 4. So this is a little bit of the edema that you can see. And so generally whenever we see edema, we give anti-edema measures like people give mannitol or hypertonic saline. And over the next few days, her condition remained stable. And she was eventually discharged with good rehabilitation. And at 3 months follow-up, she did not have any symptoms. She had recovered fully. So sometimes, if you have a good conservative medical management, it is enough. But you have to see what it is. Between 12 and 15, this zone, you have to really explain the patient, you might worsen. If it is small, 8 or 10 ml bleed, we are okay. We can still say small chance. But if this gray zone, you have to prepare the patient. If it is more than 15 ml or more than 3 centimeter one cut, you have to really push the patient for the surgery. It is share the responsibility for neurosurgeon, whatever it takes. If there is a compression of the fourth ventricle, some hydrocephalus, be aggressive. So this patient did not deteriorate and he was monitored closely because it was a 12 to 15 ml volume. So my pearl of the case is surgery in cerebellar ICH is recommended when there is a large hematoma, more than 3 centimeters in diameters, if there is a rapid neurological deterioration, if there is a brainstem compression, if there is a hydrocephalus because of the compression of the ventricles, or if there is a volume more than 15 ml with the patient becoming a little drowsy, GC is going less than 10, you should operate. Now I have one quiz to you. Hypertensive patient comes to you with these 4 sites of bleed. What do you think he has? One is a thalamus, one is a basal ganglia, one is a pons, and one is cerebellum. So yes, so you always think this is a these are 4 classical sites of hypertensive bleed. For the sake of completion, you may send PT-PTD to just rule out in case he is on any of the oral anticoagulants. Otherwise, these are the classical sites. This is another patient, young patient, hemiparesis, this bleed. But apart from this bleed, there is something seen over here where the arrow is marked. This, what is this in CT angiography? Residents, genius people. So this suggests that this patient is going to do bad. This bleed is going to expand. This is a sign of hypopnea expansion. What is the name of this sign? This is a spot sign. So whenever you see a spot sign, suppose this patient's bleed is there, this is a spot sign, for a few hours, this big bleed happens. So spot sign is very dangerous. Whenever you get a spot sign, be aggressive, refer the patient, share your responsibility, go to neurosurgeon, don't sleep down, कि हाँ भाई patient तो सारू है. Spot sign is dangerous sign. Of course, it doesn't happen to everybody, 60-70% patients. But you know, even those who do not have spot sign, they also worsen. So nothing like that. But if you see the spot sign, you have to be really on guard. So what do you think when you see a patient with hemiparesis and you see this type of bleed with the blood and the fluid level clear? What comes to your mind? Anybody? No, this is a bleed. And yeah. No, whenever it comes with this type of a bleed, you think this level tells you that this patient would have underlying coagulopathy. You have to be very aggressive in seeing PT, platelet count, other things. Dig for the history. Drowsy patient એમને લઈ આવ્યા સગાવાળાને આપણે કાંઈ નથી એમ તેમ અને હલાવ્યા કરી હાઇપરટેન્સિવ બ્લીડ કરીને આ ન ચાલે. This you have to really search and you have to be really aggressive. 2/3 of this patient they die, no matter whatever you do. So you have to be really aggressive, try and survive these patients. Refer to a neurosurgeon. If an elderly 80-year male patient comes to you with a multiple 2-3 sites of the bleed like this, and there's a peripherally you see lots of micro bleed, what comes to your mind? Amyloid angiopathy, genius. Great. And if the hypertensive patient comes to you, the same microbleeds are seen within. That means they are seen in the thalamus and the basal ganglia. Periphery, it's amyloid angiopathy. Thank you. What? In cerebellar ICH, I said 5 criteria. Is there a bigger size, more than 15 ml volume, one cut 3 ml? If there's no, most of the patients from few hours to 5 days or 7 days, up to that, the edema happens in most of the patients. And that's the reason, if the volume is big, 3 centimeters bigger, you know that if he's going to have some edema, brainstem is going to go away. So you have to be very vigilant if you are waiting for that. And rather shift him to the neurosurgeon. અડધી રાત્રે 2 વાગે પણ થોડું કંઈ લાગશે તો કરી નાખશે. બટ આટલી બધી big size હોય, જનરલી સગાવાળા માની જતા હોય છે. અથવા તો થોડું કંઈ વર્સન થાય 1 કલાક કે 2 કલાક પછી 4-6 કલાકની રાહ ન જોઈએ. And then patient gets operated. અમે લકી પેશન્ટ તો બહુ જોયા છે, બધી વાતો કરીએ. આનાથી મોટા બ્લીડ એ સારું કાંઈ નથી થતું. ખબર નહીં ક્યારે ક્યારે ઉપરવાળો વધારે મહેરબાન હોય છે અમુક લોકો ઉપર. બટ યા, થેન્ક યુ.
Coming to the next case, this is a 35-year-old man working as a sales manager in Mumbai, no previous comorbidities. He presented with insidious onset progressive painless vision loss in the left eye over a period of 4 months. He also noticed that there was loss of smell when he was trying out a perfume at a department store. There was associated mild frontal headache. So this history itself tells you a lot of things. So what it could be? Huh? Correct, frontal lobe tumor, where he has unilateral vision loss and unilateral, same side there is impaired smell sensation along with mild frontal headache. So there is something happening in the frontal region only, because there is frontal headache and there is vision loss which is unilateral. So if there is unilateral vision loss, then obviously the lesion is before the chiasma in the optic nerve, and also there is unilateral smell sensation lost. So the lesion has to be in the olfactory nerve. So the lesion is somewhere over there near the optic nerve, which is also involving the olfactory nerve and frontal lobe. Now frontal lobe per se, frontal lobe lesion inside the brain will not cause headache because the brain parenchyma itself is pain free. It cannot generate pain. So there could be some involvement of the meninges, so which is causing the headache. Or the lesion is so big that it is causing raised intracranial pressure and there is traction of the vessels and which is causing headache. But here there is only frontal headache, they are telling, mild. So probably it is involving the meninges. So you can see on examination he had anosmia on the left side. Left side there was anosmia. In vision, visual acuity right side finger counting 6 meter, left side it was impaired 4 meter. Left eye optic atrophy was there along with RAPD, relative afferent pupillary defect. And on the right side you can see there is papilledema, yes, see. Papilledema, optic atrophy. These are the images from this particular patient with these findings of impaired vision, left side, impaired smell on the left side. Rest of the examination is normal. Plantar also was flexor, nothing there in the plantar. So just to summarize, there is progressive unilateral visual loss, ipsilateral anosmia with frontal headache. So the lesion has to be in the frontal region, anterior cranial fossa, that is, involving the olfactory groove, involvement of the olfactory nerve which is leading to anosmia, optic nerve pre-chiasmatic because only the single optic nerve is affected. On the left side it is painless and progressive, monoocular vision loss with involvement of the frontal meninges probably leading to headache. This strongly suggests that there is something happening in the olfactory groove or plenum sphenoidal region. So in the olfactory groove meningioma. Okay, that is the most likely possibility. Why? Because it is slowly progressing. Meningiomas increase slowly like that over a period of few months, sometimes years. And they are so slow to grow that headache may not happen. And only vision loss because of pressure, smell sensation, because of involvement of the olfactory nerve, like that it will happen. It will be very slow, patient will not realize. There will not be any other symptoms related to frontal lobe dysfunction. Some patients may present with frontal lobe dementia in these cases. So in frontal lobe dementia, they always ask in the exam in DM neurology, have you checked for smell sensation or have you checked for vision? Because frontal lobe tumors can present with frontal lobe dementia and then they can have this problem. But this particular patient didn't have. So there is painless vision loss, anosmia, mild frontal headache with optic atrophy on the same side and papilledema on the other side. So this is a typical Foster-Kennedy syndrome. Ipsilateral atrophy of the optic nerve, anosmia on the same side and contralateral papilledema. Okay. Other possibilities could be there, frontal glioma and some other rare condition, tumors. Pituitary can also happen, but pituitary will not present like that. Usually they have bitemporal field loss because involvement of the optic chiasma. Here it is unilateral. Some other inflammatory conditions can be there, but they will not present so slowly. So Foster-Kennedy syndrome secondary to olfactory groove meningioma was the clinical diagnosis, and the MRI was done, and this particular patient had this olfactory big lesion. It was big olfactory groove meningioma was diagnosed in this particular patient. Okay. So we'll go to the next case.
One more simple case for all of you. A 30-year male patient, he presented with severe headache that developed after playing a basketball and had persisted for a month. The pain was located bilateral temple and occipital regions, was throbbing in quality. There was photophobia, phonophobia, and vomiting. And however, this headache would worsen immediately after he stands up. And once he lies down, within 5 minutes, he is absolutely okay. So this 30-year male patient comes to you. He was actually a surgeon, and therefore he could not perform a surgery because headache becomes unbearable once he just starts operating. Because once he stands up, headache really is very bad, and therefore he stopped doing the surgery. He had no past history of migraine or other primary headache disorders. The neurological examination did not reveal any abnormal findings. So, what are your thoughts? What is the next investigation? MRI. CT, MR, શું કરશું કે બીજું કંઈ? What are your thoughts? At least hematoma, intracranial, SOL. What is your thoughts? No, I didn't listen to you. Sorry, Dabi sahab. હા, તમે સવારે અટેન્ડ કર્યું હતું પેલું talk. You should not told. Anyway. Yeah. So this patient's post contrast MRI was done, which showed pachymeningeal enhancement, pituitary hyperemia, and flattening of the pons. So this is what you see is there is a pachymeningeal enhancement. So these meninges are all enhancing, and this pituitary is hyperemic, and this pons is flat. So when you see this thing, your diagnosis is spontaneous intracranial hypotension. Now, what is spontaneous intracranial hypotension? In spontaneous intracranial hypotension, CSF escapes from the spinal dura, and so there will be a leak of the CSF on the cord, and therefore this patient would have the orthostatic headache because there is a sagging of the brain. So once he lies down, no headache. Once he stands up, within few minutes he gets a headache. So this is a typical orthostatic headache. But apart from the headache, a lot of patients would have the non-headache symptoms because there is a sagging of the brain. They may have the lower cranial nerve palsy. They can come with third, fourth cranial nerve palsy, even the vestibulocochlear symptoms. Some people will come with the gait ataxia, personality change, Parkinson-like features. They have acute onset with this headache, 10 out of 10 headache, bad headache on standing. With this, if they have these features, or even sometimes they can have these features without a headache. So non-headache features are also very well described in case of the spontaneous intracranial hypotension. So whenever you send the patient for some other reason, and the radiologist એમ કે આમાં તો સાયન્સ બધા આવે છે low pressure headache ના, આપણે એમ કે અમથો કહેતા લાગે છે. But no, non-headache, there are non-headache manifestations of the spontaneous intracranial hypotension. So whenever you see this low pressure headache symptoms, or in the MRI it is confirming brain, you have to ask for the spine MRI. Ideally, you should do a CT myelography in this patient along with the MRI, but MRI spine gives a reasonable answer. So in this patient, MRI had disclosed there was a leak in the CSF at T2, 3C levels. If you see this is a cord, around that there's a normal CSF, but beyond that, where the arrow is there, that's an additional leak of the CSF, and so that leak is responsible for the low pressure headache that this patient has. So when do you suspect in any patient having a spontaneous intracranial hypotension? When you suspect this patient, when the person has a diffuse or a holocephalic headache which worsens within 15 minutes of standing, or from lying to sitting position, if he goes within 15 minutes, સવારે સૂતો હોય ત્યારે સારું હોય, જેવો ઊભો થાય બ્રશ કરીને થોડીક વારમાં જ એક headache ચાલુ થઈ ગયું. This is where you typically suspect that this patient can have the orthostatic headache. Of course, not every orthostatic picture is because of the low pressure. There are other differences as well. But once you suspect this, if you get an additional symptom like bit of a neck stiffness, tinnitus, hypoacusis, photophobia, and nausea, it adds to your clinical suspicion. And then you look for the objective evidence for this low pressure headache. And this objective evidence you get either in from the MRI or you get in the form of the CSF. Most of the times we rely on the objective evidence on the MRI to see the signs of the CSF leak. So first we ask the MRI of the brain, which will show that pachymeningeal enhancement, pituitary hyperemia, and flattening of the pons. આપણે બધું યાદ રાખવાની જરૂર નથી. આપણે એમ કહીએ ને લો પ્રેશર હેડેક, તો રેડિયોલોજીસ્ટ લખી નાખશે આ બધું અને આપણને કહી દેશે કે હા ભાઈ સાહેબ લો પ્રેશર હેડેક લાગે છે. So but we really rely on this science. But for any reason, you have done only a plain MRI because you have to do a contrast MRI in this way. If you do a plain MRI or CT scan, it is normal, and then you know person કે ના ફરી ફોટો નથી પડાવો, then you have to rely on the CSF. But the problem with the CSF is you need to document less than 60 mm of Hg of the CSF pressure. So it's a low pressure. The problem is very few patients would have this much low pressure because when somebody does LP, technique also matters. If technically is not good, he will give you a falsely little higher pressure. Because suppose કે પેશન્ટને આપણે કેમ LP કરતા હોઈએ તો પેટને આમ દબાવીને આમ પછી ઉડાવતા હોઈએ, તો જ્યારે પ્રેશર મેઝર કરવાનું હોય ને તો જે પેટ દબાવેલો હોય ને એને થોડું ખુલ્લું મૂકી દેવાનું હોય. હવે એને ખબર ન પડતી હોય આમ દબાવેલા પેટ સાથે રેસ્ટ એબ્ડોમિનલ પ્રેશર સાથે જો એને CSF મેઝર કર્યું હોય તો હાઈ જ આવવાનું છે. And therefore, you may get a normal pressure. The law of pressure measurement is give a good position, put the needle, and then pug સીધો કરી દેવાનું કહેવાનું એમ. If they do that, and wait for a few seconds for things to settle down, then measure the pressure. બહુ ઓછા લોકોને technically correct હોય. So it's a technicality, and therefore in a lot of patients, તમને normal pressure આવે તો તમારું diagnosis આખું વયું જાય. And therefore we highly rely on the MRI findings. Do MRI brain with contrast. Tell the radiologist, I'm suspecting this, and they will do the MRI properly. And so how do you treat this patient if there somebody has SIH? કેવી ટ્રીટમેન્ટ કરશો? So see, low pressure headache means you tell the patient, તમે સાહેબ rest લો થોડા દિવસો, you give analgesics, and we hydrate the patients. કારણ કે volume ઘટી ગયું છે ને, actually we say it's a pressure that is low, actually it's a volume that is low in true sense. So we hydrate the patient. 3, 4, 5 લીટર ફ્લુઇડ આપીએ, એટલે 3 લીટર જેટલું આવી આપીએ, 2-3 લીટર મોઢેથી આપીએ, 5-6 લીટર લે, 2 કે 3 દિવસ લે એટલે પેશન્ટ લગભગ સાઈડ થઈ જાય. બધા નહીં હો, અમુક. Yeah. So we give this patient a lot of IV fluids, analgesics. Some people give abdominal binders, and some people give an caffeine-like drug and theophylline, which are theoretical known to increase the CSF production, but doesn't happen actually practically. But then you can try all these things. But if the patient doesn't settle down, then what do? Next. Document કર્યું છે કે આ બધું CSF leak થાય છે, આનાથી કાંઈ ન થયું. Blood? Yes, absolutely correct. You all are genius. You do a epidural blood patch. So what you do is take a 20 ml of blood of the patient and inject him in the epidural space. That was done in this patient. You can do it targeted area wherever there is a lesion, wherever you're getting a leak, or you can do in the lower down and then put the foot and the patient's elevation. So if you put the blood in the epidural space, this blood will trickle down and go and seal that hole which is responsible for the leak. And so the leak gets solved if you do this epidural blood patch. So this was done in this patient, and he had partially improved. And so I'm just showing you the methodology. This you don't have to do. This our anesthetist friends, they do it. You should be a person who is doing this frequently. સબારેક્ટોઇડમાં વયું જાય ને ત્યાં બ્લડ જાય તો બહુ પ્રોબ્લેમ થઈ જાય. So you have to tell the patient, we are doing epidural blood patches. હવે તો epidural anesthesia આપે છે, શું કહેવાય, deliveryમાં, એટલે આપણા anesthetists લોકો used to છે, and therefore if you tell them to do this, they will do it. So put the needle in the epidural space, tell the other colleague to collect 20 ml of the blood, and you just inject it. It is very simple. It looks simple, but you have to be technically good to inject this 20 ml of the blood. So in this patient, once you do this, now within immediately the person would be better, or sometimes it may take a day or so to improve. This patient had a partial improvement, and therefore it was thought that at day 3, let us do one more epidural blood patch, and one more epidural blood patch was done. But the problem was, when second patch was done, feeling એટલું બધું થઈ ગયું કે it was paradoxical symptom. સુવે તો headache થાય, ઊભો થાય તો headache બંધ થઈ જાય, ઘાણી બોલાવી દીધી. So we gave acetazolamide for 2 days, and the patient improved completely. So it's a highly treatable condition. The surgeon coming to you, MRI normal લઈને આવે for you, plain MRI, and તમે કાંઈ નથી. It's not, we do a contrast MRI, have a good history in this patient. So the pearl of the case is, this patient's headache had the features of migraine, and a headache had the photophonophobia, vomiting, everything was there. So sometimes if you are not aware of the definition of the migraine, you may just say, then the migraine લાગે છે ભાઈ. But you have to really spend the time in the patient, all the patient. And the red flag was orthostatic features. So the headache બંધ થઈ જાય and ઊભો થાવ તો headache થાય છે. And this patient MRI revealed all the typical features of the low pressure. And therefore, in this patient did very well after 2 epidural blood patches. Another case, this 52-year-old man presented with pulsatile headache. He came with drowsiness after 2 weeks of the weightlifting program. બહુ વજન ઉપાડી દીધા. And so he had a significant bilateral headache, 8 or 9 out of 10. And he was debilitated. And he said that he feels sleepy and does not look motivated. So to mild encephalopathic like picture, 2 weeks, nothing is happening. So again, in this patient, when MRI was done, this MRI had shown the signs of low pressure. If you carefully see, there was no angle seen between the pons and the midbrain. It was 0. And this angle between the straight sinus and the vein of Galen was very obtuse. And posteriorly, you don't see any CSF. So there is a crowding. That means whole of the brain has sagged. This suggests this is a sign of the low intracranial pressure. And this patient received 3 epidural blood patches. And after that, look at this MRI. This angle between the midbrain and the pons opened up. This angle became much better, and the CSF came down behind the cerebellum, and so the crowding got reduced. So sometimes the patients come with the non-headache symptoms, even the drowsiness, not just an orthostatic headache, but they can come with the non-headache symptoms as well. Like in this patient, some cognitive decline. Some people with this non-headache symptoms can have headache, and some people can have isolated headache symptoms. So this is a list of the non-headache symptoms which we expect in a patient who comes to you with a spontaneous intracranial hypotension like diplopia, bilateral sixth nerve, Meniere's-like presentation, sometimes altered sensorium, unsteady gait, and so forth. So remember, always think about the secondary cause whenever you see a patient of headache. Again, revising you this Snoop 10. If you see it in this Snoop 10, I have written this positional headache, intracranial hypertension or hypotension. So this was a case of intracranial hypotension. Thank you. Now, we can have the tea, they will serve to you. We'll be asking about a dozen of the questions to sir, and you'll be answering me. On your behalf, I'm asking him because he's an expert of a headache. Right, Rahul? Is it okay? Yeah. And after that, immediate that question answer session is over, the 10, 12 questions, then you can have 5, 7 minutes of a break for the toilet and so, and then we'll immediately send. But the tea will be served right on so that, we just go on. I'll be asking the questions. My light will be on. So migraine prevention is something on which I'm going to ask the questions. If you really see that, a lot of people are not using the preventive drugs of the migraine, right? We treat migraine with only acute medication, which everybody knows it, but preventive medication is sometimes, इसमें डालो, इसमें मेरे में, निकाल दिया क्या? इसमें, हाँ. The preventive medication is used less often in the patient of migraine, and therefore, I'll be asking the questions about the preventive medications. So, if you overall see the migraine sufferers, out of 100 patients, nearly 40 of the patients of migraine, they need a prophylaxis of migraine, what we call preventive drugs. But 13% of the patients only receive this drug. Rest of the patients are not receiving the preventive drugs of the migraine. Since they are not receiving it, why? Where is the problem? So, and therefore, I'll be asking various questions to our beloved sir about the preventive aspect. You can also interrupt, give your opinion as well. In fact, I want you to shout the answer and then he will tell us. First question is most simple, which those who are in the beginning, they know this first question. So the first question is, when do you use the preventive pharmacological treatment in migraine? Madam? More than 2 episodes? 4 episodes. So, yeah, that's true. Sir, what is your answer? When do you use the preventive pharmacological treatment in migraine? In the patient who come to you in OPD, 100 patients, so where do you select? इसमें देना है, इसमें नहीं देना है?
See, what you said is right, कि if there are 4 or more number of episodes of migraine headache in a month, then the patient, according to those guidelines, should be started on prophylactic treatment. But it can sometimes happen that the patient has only 1 episode, and that 1 episode is very severe, with vomiting and everything, and it is causing loss of working time for the patient, which he doesn't want to lose. So in that patient also you can start the treatment. That is one issue. Second is, if the patient's perception of headache and suffering is to such an extent that he doesn't want to get a single episode of headache, then probably you are justified in starting the patient on migraine prophylaxis, even if the number of headache days are less than 4. So that is not a hard and fast rule. It depends on the patient's perception. I do not want to have even a single day of headache. And there are medicines available now which are almost very effective in preventing headache, especially the monoclonal antibodies, etc. So 4 is the minimum number, but single episode, very severe headache with vomiting, or even if there are less than 4 episodes in a month and they are not very severe, but they are not getting controlled properly, aborted with the abortive therapy like whatever, naproxen, sumatriptan, etc. They are not working in those acute episodes. Then also the patient may want to be put on the.
So point well taken, 4 or more episodes, those who impact the social personal life, when the optimal acute drug is ineffective or acute medications are there to take frequently a lot of acute medication, that is where you would use this prophylaxis of migraine. Thank you for the great answer. One more question. Which medications do you use, and should the choice of the migraine preventive drugs be determined by the preventive comorbidities? First we'll ask them, which medications do you use? Shout. Propranolol. Huh? Fulnarizine, propranolol. Amitriptyline, valproate, sometimes topiramate. Yeah, so yeah, like So what are your choices? What drugs do you use in your practice? And do you really look for the comorbidities when you are using these drugs?
See, now there are multiple multiple classes of drugs which are used in migraine prophylaxis, as you have already mentioned. So choosing a particular drug is little bit tricky, and we do look into comorbidities. Now the commonly used drugs are amitriptyline and topiramate. In my practice, I am telling you, amitriptyline and topiramate I use a lot. Among these two also, topiramate is my favorite. Especially it is useful from comorbidity point of view. If you look at it, then if the patient is obese, then it is added advantage of using topiramate. It has some weight loss benefit. Another, and for amitriptyline, if there is insomnia, sleep issues, or co-occurring depression, then amitriptyline is very good. So we use amitriptyline in those patients. If the patient is already having hypertension, and then probably we would use beta blockers, propranolol or metoprolol, ethanol, whatever, mostly propranolol. So these are the comorbidities which I look for actively. And also I keep in mind whether the patient has some contraindications for these drugs. For example, if the patient is, if you take beta blockers into consideration, if the patient has asthma, then probably I would not use beta blocker. If the patient's heart rate is already low and there is bradycardia, then also I would not use beta blocker. If depression is there, beta blockers can cause depression, though it can be argued how frequently they cause, then I would not use beta blocker. I would use amitriptyline instead of that. For topiramate, I ask the patient specifically if they have angle closure glaucoma. Angle closure glaucoma patients, I don't use topiramate. Or if they have any vision problem, for example, I don't use usually, because topiramate can cause angle closure glaucoma and corneal edema. I have had 2-3 patients who developed acute corneal edema and complete blindness after topiramate. I had 1 or 2 patients who developed severe angle closure glaucoma and loss of vision with 1 dose of topiramate. Another contraindication, or little bit careful you have to be, if the patient has renal stones. With topiramate there is a chances of renal stones. So
in Saurashtra, every 5th or 10th person would have renal stones.
Yeah, so then it will be little tricky to use topiramate.
If you don't do sonography, but you know, it's such a belt.
But from efficacy point of view, it is one of the most effective drugs for preventing migraine prophylaxis, topiramate. And even a small dose, 25 milligram or 12.5 milligram also makes a difference, and it reduces the monthly headache days. So these things I look at. Weight is another issue. Weight, already there is obesity, then amitriptyline and flunarizine I usually avoid because they cause a lot of weight gain. If it is an elderly patient, then we look at the prescription of the patient, whether he is getting some other medicines which can have interaction. So you look at the entire prescription. Now valproate in young women is a strict no. For valproate, considering the teratogenic effects, side effects of this particular this thing. So this is the comorbidity.
If those who have a lot of dizziness, that is where you like flunarizine?
Flunarizine we used to use if it is migraine with aura, then I think flunarizine, I use flunarizine. Dizziness and vertigo, flunarizine can be used. But again, keeping in mind the weight issue with flunarizine, and sometimes some patients really don't tolerate flunarizine. There is a lot of sedation. Also with amitriptyline, many patients the sedation is a side effect of amitriptyline. So most of the patients will have some sleepiness with amitriptyline. So we start with a very low dose of like 5 milligram, and then if the patient tolerates, then after 10 days we increase it to 10 milligram. But in some patients, they are kind of hypersensitive to amitriptyline, and they become very sleepy, and they just cannot sit only, just they fall like that because of sleep. Then in those patients you are not supposed to use. So beforehand only tell the patient that little bit sedation will be there, but over a period of time it will go. But in some patients, if you are very sleepy and you can't just remain awake the next day, then probably you are hypersensitive, you have to stop and you can't take this medicine. Another thing is this with topiramate is this paresthesias. They have lot of paresthesias. Topiramate gets lot of paresthesias. Hand paresthesias, face paresthesias, feet paresthesias. So many patients don't tolerate that. If patient already is having complaint of paresthesias, then I don't use topiramate. Some patients have mild paresthesia, in those patients you can give potassium supplements or fruit juice and the paresthesias disappear. You can use the paresthesias in a, you can use that symptom to judge that the effect of the medicine has started, and you can tell the patient once the paresthesia they start getting paresthesia, that means the drug is started working, and slowly it will work like that. You can tell.
You know, we have one pediatrician. When he sees a child, if on third or fourth day of admission, the child gets a fever, he would say, oh, bring the sweets. My child also had on the fourth day fever. If you get on fever on fourth or fifth day of the entry, you are lucky. Then you have a good chance of recovery. So similarly, in your case, if you say your paresthesia, very good, drug is working, and that's how you would motivate that patient. Thank you for this. So one more question. What should be the effectiveness of the, when do you assess the effectiveness of the migraine drug? You start the treatment for the migraine, say topiramate, amlodipine. When do you assess, okay, the drug is working or it's not working?
Typically after 3 months, the literature says that after 3 months you have to assess the efficacy of the drug, and you assess the efficacy by asking the patient the number of monthly headache days or monthly migraine days. Monthly headache days is the number of days the patient has headache. There may not be migraine features like nausea, vomiting, photophonophobia. Monthly migraine days is headache days with migraine features. So you ask them how many headache days were there, and in the first visit only you ask them how many days in a month they get headaches, and you write down monthly headache days, MHD, 5, 10, 15, whatever it is. And then at the follow-up, you ask them again. So normally patient will say, kuch fayda nahi hua, like that. So then you ask them, how many days you have headache this month? Then they'll tell, 5 days, 6 days. Then previously you already written 15 days. So 15 days have come down to 10 days. It's very good, like that. So the literature says you assess after 3 months. But 3-month time is a very long period. You may not get back the patient. He may not turn up. So what I tell them is that you observe for 1 month or 1.5 months. And if you find that there is at least some benefit and there is some reduction in the migraine headache frequency, then you consider that the medicine is working.
Absolutely.
And after 1.5 months, if there is no benefit whatsoever, then the medicine is not working, then you come back to me. But at the end of 1.5 months, if you think that some benefit is there, that means medicine is working, you continue for 3 months and you come back to me after 3 months.
Sure.
So that is what I tell.
Thank you. One more question. If a migraine preventive drug is ineffective, is it appropriate to give combination of the 2 migraine preventive drugs? You have tried it one, he comes to you, sir, kuch fayda nahi hai, bekar. Then next time you start 2 drugs or you start 1 drug?
So if the medicine is totally ineffective, there is no change in monthly migraine days, monthly headache days. Mind you, there are other parameters also which you have to take into consideration to detect the efficacy of the medicine. That is severity of the headache, headache freedom after use of abortive therapy when on prophylaxis therapy, and headache freedom using abortive therapy when not on prophylaxis therapy. So many patients, not just the frequency of headache comes down, the severity of the headache also comes down, the duration of the migraine attack also comes down, and they are more easily controlled by the naproxen or whatever it is. So headache may not completely go, but it is milder. Some patients, the most bothersome symptom, many patients the most bothersome symptom would be headache itself. Some people it will be nausea, vomiting, photophonophobia, whatever, weakness. So most bothersome symptom also relief could be there with these medicines. So if it is completely ineffective, then you have to stop it, go to another medicine.
But do you use combination anytime?
Combination therapy can be used to your advantage, like if you want to neutralize the side effects kind of. So amitriptyline causes weight gain and topiramate causes weight loss. So you can just use both of them together to neutralize the side effects. So in that way you can use a combination therapy, or you can use a lower dose of both the things to prevent the side effects.
Sure. Thank you. So yeah, so combination is a helpful thing. So like if we can combine like beta blocker with anticonvulsants or with tricyclics, or like anticonvulsant with tricyclic and so forth. Yeah. So how long should effective migraine prevention be continued?
At least 1 year.
Okay. So generally when it's episodic, 6 months, 9 months, sometimes we stop, and if it's a chronic one, little bad one, then you may continue for 1 year or so. Yeah. What are the successful criteria? When you say that migraine drug has really worked, it's just the patient says, or you have some other reasons to measure also? Okay, this
as I told you, most bothersome symptom, monthly headache days, severity of the pain, response to abortive therapy, or you can use the migraine disability assessment score, MIDAS,
MIDAS.
MIDAS, or headache impact test.
HID6 questions.
Questions to find out, but in a busy OPD it may be difficult, so you can ask your assistant or somebody to, or just have a form, or you can grossly, at least you can ask the monthly headache days. It's very easy. You know, how many days in a month you get headache.
So more than 50% reduction, you are happy enough to say that you are.
But in the trials which we have done a trial on Erinumab. I had 30 patients on Erinumab when the drug was launched in 2018-19 I did. So in the trials, the efficacy what they demonstrated was only 1 or 2 days reduction in monthly headache days. Only 1 or 2 days reduction, 2 days reduction, 3 days reduction, significant benefit. Because you are documenting it on a randomized trial, a randomized blinded trial. It is a very powerful tool. If you are demonstrating that the headache days have decreased by 1 or 2 days also on a blinded randomized trial, that means the medicine is very
हमारे यहाँ patient doctor change कर देगा, थोड़ा ही कम 10 में से 8 हुआ है, छोड़ो.
In the trial it is showing that 2 days headache, number of monthly headache days have reduced by 2 days. That means in real world it will be very effective. It is very effective, that means. For all epilepsy medicines, the seizure frequency has to come down by 50%. Not that seizure freedom, you don't have to achieve seizure freedom with the medicine. Only 50% reduction. But in real world, you see, if you give that particular medicine, 70-80% of the patients, there is no seizure. So it is like that only.
Yeah. So in individuals who are discontinued the migraine preventive after a successful treatment, what are the criteria for restarting this?
Again, if the headache recurs after a period of 1 year, some patients, if you give for 3 months, 6 months, then they remain headache free, or the headache frequency becomes very less for next 1 or 2 years. But again, if they start getting headache in the same frequency, then probably you have to restart therapy.
So same criteria for migraine that you consider. So which preventive medication is suggested for the people with chronic migraine, not episodic, chronic, 18 days, 15 days, 20
My
days?
personal choice is topiramate and amitriptyline, topiramate and monoclonal antibodies.
CGRP, yeah, okay, fine. So yeah. So what are the suggested drugs for migraine in children and adolescents? What do you use?
In children, I use cyproheptadine.
Okay.
There are some studies with amitriptyline and topiramate also. You have to give them according to the weight and milligram per
Maybe lower
0.5
dose.
milligram per kg, something like that it is. So that according to that you have to give.
Okay. What migraine preventive drugs can be used in the people with over the age of 65?
Depends on the comorbidities what the patient has. Depends on the comorbidities and cardiac conditions, etc.
Okay, fine. So what is the recommended approach to the people with migraine with medication overuse? Those who are taking a lot of drugs, how do you deal with those patients?
So the medication in MOH cases, the medication which is overused has to be stopped. So you can stop it in either 2 to 3 different ways. Either you just stop it and start the patient immediately on prophylactic medicine like amitriptyline or whatever, topiramate or botulinum toxin or monoclonal antibodies, or you reduce the dose of the overused medicine and simultaneously introduce it, or you stop the medicine completely and then give a prophylactic medicine. But commonly what I do is I just abruptly stop the medicine or taper it over a period of few days or weeks, and parallelly starting the patient on prophylactic
and you give another drug for the acute symptoms?
Yeah, if there are acute symptoms, you give another drug. But many times, if the patient is chronically using a particular molecule, then it is very difficult to remove the patient from that molecule, and you may have to just give it in a very small dose for a period of time. Now, in one of the headache meetings, the expert, I think Lipton or somebody had come, and he said that he used this sumatriptan in a patient of medication overuse headache for like 1 year. The patient, he was not able to get the patient off sumatriptan, half tablet, like daily.
So if there is one condition when you need to refer a patient to a colleague, refer the patient of MOH. He doesn't improve with you, he will not improve with him either.
Some patients may need admission. Now in a government hospital, we are at a liberty. We just keep the patient admitted for weeks together. And with admission, IV fluids, sister coming, taking blood pressure pulse, and with that environment of being taken care of, headache becomes less. injectable medicines can be given, paracetamol, like that.
Which migraine preventive drugs can be used during pregnancy and lactation?
Pregnancy and lactation, we are very careful to use the prophylactic drugs. Valproate is strictly no, amitriptyline and beta blockers. There is some evidence that it can be used, but I usually don't use. Magnesium can be used, and non-pharmacological therapies like remote neural stimulation.
Okay, REN device, you do Nerivio device is what you use.
Nerivio or something like that can be used.
Are you aware of Nerivio device, any of you? No, we'll show you the video after this Nerivio device, how it works and this thing in this 5 minutes break.
Or else if the patient is very anxious, stressful, then plain simple paracetamol has to be given.
Okay. So avoiding valproate pyramid and other scopolamine in few patients. Some people do nerve blocks as well.
No, Botox or nerve block is another option.
Yeah. So thank you, sir, for this thing. Wonderful question. We'll break for 5-7 minutes, and in this 5-7 minutes, if you want to see the Nerivio device, one of our colleague has brought it, and sir will show you a demo if you want to use it, or else you can see the video of this Nerivio device. This is applied over the arm, and you can see this video. Now watch, Karan. And we'll break for 5-7 minutes. 5-7 minutes. No, you don't necessarily. I'll share with you, all of you, those who want to see. We can break for 5-7 minutes. But have another DVD say just. आवाज करो भाई. Yeah, this is a Nerivio device. If anyone wants to see, have a demo, sir will show you. Jack, it is here. In 5-7 minutes break, you can have the look at this device if you want to see. Otherwise, video is good enough. Actually, it is put in the arm. It is applied alternate day, say 45 minutes, and you take it for 3 months, and you get a pretty good result. For pregnancy, I think this is one of the wonder drugs. For medication overuse headache, this is a wonderful arm. The only thing is the cost. For 3 months, it will cost around 36,000 rupees. Yeah, but it's a wonder, isn't it? Okay, we'll break for 7-8 minutes, and then we meet. Okay.
बराबर है?
हाँ, बराबर है. आपके केसेस थोड़ा डिफिकल्ट है भाई हमारे क्राउड के लिए. हमारा क्राउड सिंपल है.
लड़कियों अच्छा वो लोग आते हैं.
वो तो ऑफिसर गोल्ड मेडलिस्ट है भाई वो. तो है.
A migraine headache involves an inflammatory activation of the trigeminal vascular system, which conveys nociceptive information from the head and face through the trigeminal nerve and the trigeminal cervical complex to brain regions involved in pain processing.
in my life, new life to me. Thanks to Dr. Reddy's.
नमस्ते, मैं उषा बोराना, मैं हाउसवाइफ हूँ और मुझे 6-7 महीने से एक साइड में माइग्रेन का तकलीफ था। बहुत पेन, इस साइड से बहुत पेन होता था। फिर मैं डॉक्टर के पास गई, उन्होंने मुझे 1 महीने भर का दवाई दिया। तो मेरा दवाई 4-5 दवाई था मेरा, तो मैंने वो दवाई लिया, लेकिन मुझे थोड़ा मतलब ठीक लगा। फिर मैं वापस गई तो मैंने बोला मेरे को काफ़ी रिलीफ नहीं है, तो उन्होंने मुझे निर्व्यू के बारे में बताया। तो फिर मैंने वो यूज़ किया तो मुझे उससे काफ़ी फ़र्क लगा। मेरे पहले रोज़ पेन होता था, अभी मेरा 6-7 दिन में एक बार होएगा या फिर ज़्यादा कुछ शोर शराबा होएगा तो मेरा पेन होता, वरना मेरा रोज़ पहले कैसा था, पूरा 6-7 महीना पूरा आधा पेन होता था। अभी मुझे वो रोज़ होना वो बंद हो गया है। इससे मुझे काफ़ी फ़र्क पड़ा। तो इसे यूज़ करना भी काफ़ी कंफर्टेबल है, मतलब अपन यूज़ कर सकते हैं।
Okay, now we begin the next session. Yeah. Yeah. Ankit? Where is Ankit? Is Ankit around? Dr. Ankit? उस आदमी को दिया था वो स्लाइड चेंजर, ढूंढ क्या उसको। चलो, we'll begin with the case. Yeah. I'll be presenting 4 small cases of pregnant lady, pregnant peripartum period, postpartum period. 21-year-old lady, she's a known case of sickle cell disease. She came in the 3rd trimester. This was her 2nd pregnancy. Both pregnancies were complicated by multiple vaso-occlusive crises and she requires admissions. She was readmitted at 38 weeks due to recurrent vaso-occlusive crisis and she received a blood transfusion. Next day morning, she developed sudden severe headache, 10 out of 10, and she was unresponsive to analgesics. Her blood pressure was 146/93. So what is the diagnosis and what is the next step that you would do? Slide changer. Okay, fine. So what is the diagnosis and what is the next step that you do in this patient? What is the diagnosis? What are you thinking? 10 out of 10 headache, hypertension, pregnancy hypertension. What do you think? Okay, that can be a thought, but what generally people think, the common thought is any person, what is the definition of preeclampsia? Preeclampsia is the rise of the blood pressure after 20th week of the pregnancy with either proteinuria, or if you do not have proteinuria, then you have to have one of the 5-6, and both the hepatic dysfunction, liver dysfunction, or you can have this pulmonary edema, or you can have headache, or visual disturbances, or thrombocytopenia. If you have any one of those with the hypertension which had begun after the 20th week of pregnancy, then you think this is a preeclampsia. And those who do not have this other criteria, then you look for the proteinuria. No more the proteinuria is compulsory for the diagnosis of preeclampsia, which you initially used to say. So with the after 20 weeks of pregnancy hypertension, either you need a proteinuria or you need one of the symptoms. So this patient had a hypertension and a headache. So it was thought, you are all right when to think. So bleed is a thought, stroke is a thought. So in this patient, gynecologist had seen the patient, Press is a thought, excellent thoughts. You all have excellent thoughts. So in this patient, but gynecologist thought that this is a preeclampsia, and they sent all the lab reports for the HELP syndrome. What is HELP syndrome? What is HELP syndrome? Hepatic and low platelet and? What is hemolysis? When do you say it is a hemolysis? How much? 600, above 600 that you get, that's the right area. And how much is elevated liver enzymes? Even 2 times per patient, people say it's enough. And how much is a low platelet? Less than 1 lakh, yeah. So if you get that, that's a severe variety of preeclampsia HELP syndrome. And this patient was started on magnesium drip, thinking of preeclampsia, delivered vaginally overnight. Headache improved after the delivery. So people were happy. It's a preeclampsia. But she continued to have magnesium drip with the suspicion of the preeclampsia. And later that afternoon, she developed the weakness of the left arm and the numbness. And so gynec resident saw even a facial droop was there and the neurologist was called. And this was the CT scan which was done after the hemiparesis was documented. If you see carefully this CT scan, there is a bleed right frontal bleed is there is some mass effect is there is some subarachnoid blood is there. But you know what? This bleed hasn't happened when the hemiparesis had happened. It had happened much before, because you can see this edema all around. So whenever you see a edema, it doesn't happen in the first 1 hour or 2 hours. It has been over a day or two. So when she developed that 10 out of 10 headache after the blood transfusion, that is a time when this bleed has happened. And therefore, you should diagnose this patient at earliest, as you rightly said. Think about the stroke, think about the venous sinus thrombosis in this patient. So sickle cell disease and stroke in pregnancy, I have a word to say that this sickle cell disease produces everything. It produces arterial stroke, it produces venous stroke, it produces intracellular hemorrhage. And therefore, your suspicion of doing the scan should be very low, and you should immediately do a scan in all these patients, because it carries significant morbidity both to the mother and the child, including pregnancy loss, preterm delivery, preeclampsia, eclampsia, and a stroke. So suppose this patient did not have, suppose this patient comes to you with a hemiparesis. Would you thrombolize this patient? Suppose not a bleed, suppose ischemic stroke. Sickle cell disease patient comes to you, would you thrombolize? Suppose it is not a sickle cell disease, and the patient comes to you with hemiparesis during the pregnancy, would you thrombolize? Yes. So no sickle cell, you will thrombolize. How many of you thrombolize the patient of the pregnancy patient? Nobody would thrombolize. Neither sickle cell disease nor pregnancy is a contraindication for IV thrombolysis. You must thrombolize all the patients. Stroke is an emergency. Mother gets a priority. You have to thrombolize the patient, right? And you know what? This thrombolytic agent does not cross the placenta. And so you should not worry about this. Bit of a bleed risk is always there whether or not the person is pregnant. And therefore, you should consider thrombolysis if it is a ischemic stroke. It does not apply in this patient. Here you have to look for the other causes, as you said, that press or the other diseases like intracellular hemorrhage because venous sinus thrombosis and so forth. What about imaging? Would you do a CT scan of a brain in the patient who is pregnant, if need be? Those who say yes, raise the hand. આટલા લોકો સ્કેન કરે છે, બાકી નથી કરવાના. સપોઝ કોઈ પણ જરૂર પડી ગઈ પેશન્ટ બહુ હેડેક થયું હોય, સપોઝ એમાં નથી, પાલતાણામાં છીએ, કરો. You should do MRI, I have no doubt about that. But if you do a CT scan, you should not be scared of doing the CT scan. My message is that the amount of radiation for one plain CT scan is 0.001 milligauss or 0.01 milligray, as that is what the exposure child would have. But the toxic dose which has been recommended in books is a 50 milligray. So 50 જ્યારે exposure થાય એટલે કે 200 વાર સ્કેન થાય ને ત્યારે પેશન્ટ ચાઇલ્ડને હાર્મ થાય. એક સીટી સ્કેન કરવામાં શું વાંધો પડે? So if need be, yeah. Shield, abdominal shield, we always apply that. And then, so even further you reduce it. So this is, my message is, it's a very negligible amount of the exposure that the child gets. So even if the CT angiography is required, for example, if you are suspecting a large vessel MCA stroke and you want to do a thrombectomy, you can do that. Or if there's a vascular malformation, contrast even iodinated CT contrast is no problem. You should do it if need be. Of course, unindicated nahi karvanu, because there is always a bit of a risk of neonatal hypothyroidism, which is really a theoretical risk, and it is very safe in lactation. For MRI, of course, MRI is a great thing. The only thing in MRI is you should not use contrast MRI. So gadolinium should not be used in pregnancy. It is safe in the lactation. One more case. 29-year female, she delivered full-term uncomplicated pregnancy, discharged home postpartum day 2. All good. On day 3, she developed severe headache, high blood pressure, readmitted and treated with magnesium drip and labetalol. થોડા કઈ સારા થઈ ગયા, સાહેબ ઘરે જાઓ, and she went home, which is a very common thing in our practice. And so headache became intolerable after the discharge and she collapsed. And the blood pressure was 185 or 110. And the CT scan was obtained. And this CT scan had shown this bleed. This is a bleed. And if you see the CT angiography, you see there is a multiple areas of the vasospasm. Can you see this? This vessel is not like this vessel full. There are multiple areas of the vasospasm. So what is the diagnosis? No, yes, RCVS. So it's a reversible cerebral vasoconstriction syndrome. RCVS and PRES are two cousins. So when there's a severe surge of the blood pressure, then in this situation, in the pregnant lady, you have to think of the RCVS, and which previously we used to call it postpartum angiopathy. So they come with a bleed, and there is a vasospasm of the multiple areas of the large and the medium-sized arteries, and it is a transient basically. Sometimes on the first scan, you may not get the vasospasm. So you repeat a scan after a few days, you may get that vasospasm. And typically, these patients present with a thunderclap headache, बहुत जोरदार headache. If you remember that Snoop 10 in that one of the criteria, or if somebody has a rapid headache, thunderclap-like, you have to think in terms of RCVS and other causes like subarachnoid hemorrhage. So thunderclap headache is a presentation of the RCVS. And his brother, Press, they would come with a posterior vasogenic edema, and so that patient will come with the seizures, hemorrhages, and focal deficits. And here there is a, because of the endothelial dysfunction, there is a posterior edema. Previously we used to call Press, but nowadays it has been found that this edema not only occurs posteriorly, but it occurs anteriorly in the cerebellum and the brainstem as well. So, but still the word has become famous, Press, and we keep using the word Press. And both these conditions are very well seen in the postpartum period. So this is once more I'm showing you. These are the RCVS, multiple sites of the vasospasm that you see. If your eyes are trained, it's for good. Otherwise, we have a good radiologist friends. They will see for us this RCVS and tell us. And this is a scan of the vasogenic edema or Press. Case 3, 26-year female. She had a history of undifferentiated connective tissue disorder, positive APLA, positive ANA. She was on hydroxychloroquine. On the third pregnancy, which was complicated with migraines, and she was put on aspirin. How many of you believe that aspirin should be given in this situation? And why aspirin is given to the pregnant lady? Any of you are aware of that? Just because not APLA. See, those pregnancy which are high risk for developing preeclampsia, nowadays after 12 weeks of pregnancy, there is a trend to give the aspirin. So it is not just APLA, but it is given in those who are diabetics type 1 and 2, those who have renal disease, those who have uncontrolled hypertension. So these are the patients who are likely to develop, or those who have preeclampsia in the past. These are the patients, or multiparous patients. So these are the patients who are likely to develop preeclampsia one more time, and therefore, and this applies for definitely indication to prevent the next stroke or next preeclampsia. Despite this, this patient developed the preeclampsia at 35 weeks, and she delivered by the cesarean section. She went home, things were okay, but she presented 2 weeks postpartum with severe headache and confusions, AKI, thrombocytopenia, and she was found there was splenic and the renal infarcts. And she was started on anticoagulants, but she did not improve. Headache and confusion did not improve. And therefore, MRI was done, and it is showing the multiple infarcts on both the sides of the brain. So this multiple infarct suggests that, and with this whole picture, she was diagnosed having a catastrophic antiphospholipid syndrome, which I think only 30 people are seeing more and more. I'm getting the reports from there. And so, yeah. So what should you do to treat the patient? How do you treat this patient? Catastrophic APLA. How do you treat? Heparin he was already on, not doing well. When you get this multiple infarcts, so diagnosed with catastrophic antiphospholipid syndrome, you have to do a plasmapheresis. And so in this patient, plasmapheresis was done, and she made a good recovery, and subsequently she was put on the warfarin. So hypercoagulable disorders and stroke in pregnancy, both APLA and lupus, both are associated with high pregnancy morbidity. There is an increased risk of miscarriage, arterial and venous thrombosis, infections, and preeclampsia, and that's why we put on aspirin in all these patients after 12 weeks of pregnancy. And thrombophilia, whether inherited or acquired, there is a significantly higher risk of the stroke, and therefore you should be very careful when these patients come to you for the phone. And there is an increased risk not only occurs during the pregnancy, up to 12 weeks postpartum, this risk remains. Last case, 34-year female, she had gestational hypertension. She presented on postpartum day 8, she was at home. She came with a severe headache, and the blood pressure was 140 over 90. And so we were treated with magnesium, thinking it's preeclampsia, because preeclampsia can occur after the delivery and postpartum period as well. And so headache did not improve, and therefore neurologist was consulted. And with the deep history taking and other things, the MRI was done, and it had shown that there was a carotid artery dissection was there, internal carotid artery dissection. This is a thrombus which you see over here, and this is a dissection. So cervical artery dissection in pregnancy, a word is that there is an increased risk of this dissection up to 5-fold. Mostly it is in the postpartum period. Some people say that the push during the pregnancy when they are delivering the child is responsible for this, but this complication doesn't occur on day 1 and 2. It occurs after a few days of the discharge. So push is, and a lot of people who have even gone for the cesarean section, they even get this dissection, and therefore it is not necessary that that push is responsible. And so, but one of the most common cause in this dissection is a hypertensive disorders. In half of the patients it was found. What are the hypertensive disorders of pregnancy? Anybody? When I say hypertensive disorders of pregnancy, what does it mean? It means gestational hypertension, preeclampsia, eclampsia, and it means chronic hypertension, and chronic hypertension superimposed preeclampsia. So these hypertensive disorders would have a higher risk of the dissection. And second thing is a trauma. Trauma is another frequent cause of the dissection, and it is not uncommon, even in our setup also, the lady getting a slap from the partner after the delivery, and somehow complicated story, but it is known. So I presented you 4 cases: postpartum, hypertension, and headache. And so my message is that whenever you see a headache in pregnancy and postpartum period, you should not be dismissed. You should give a real regard and investigate that patients. Preeclampsia is associated with multiple neurovascular complications: RCVS, press, cervical artery dissection, venous thrombosis, arterial stroke, subarachnoid hemorrhage, intracranial hemorrhage. Most pregnancy-related strokes are seen in the postpartum period, and so delay in the diagnosis and misdiagnosis are common. Thank you. Any questions?
Yeah, this is a very interesting case. A 54-year-old female from Uttar Pradesh. She was a homemaker. She came with the complaints of seizures and decline in cognition since 4 months. So this patient was initially evaluated at Uttar Pradesh by multiple neurologists and also in a medical college, and she was being treated for abnormal movements and irritability, aggression, etc. by psychiatrists and neurologists, and subsequently they realized that the patient is behaving abnormally and is not able to understand what is being told and has forgetfulness. The patient was apparently all right 4 months back when she started having these particular type of movements which were being treated by a psychiatrist. So you can clearly see that there is twitching of the left side of the face with facial deviation, which is happening continuously. Now it looks like the patient is conscious and she is looking at you. There is also jerking of the left upper limb. You can see again, jerking of the left upper limb like that. I have multiple videos of this patient wherein they have taken videos at home where she becomes suddenly violent and starts moving randomly in sleep. And for this, she was thought to be suffering from a psychiatric condition and was being treated by psychiatrists. So at our hospital also, she was referred to the psychiatry department, and she was admitted there for almost 1.5 months before they realized that this could be seizures with this facial twitching and jerks and like that. So during these episodes, she used the volume is not there. She used to shout and just verbalize and vocalize abuse, something like that. So they thought that it is a hysterical. And then she was referred to us. Relatives noticed that the patient has become more irritable. She gradually had decline in her cognition. She would forget where she has kept her things. She would forget what was told to her a few hours back, would forget to deliver messages to her family members, and she was making mistakes while cooking food. She was initially admitted, as I told you, psychiatric ward, treated for psychosis by antipsychotics. However, since she did not improve and there was worsening, and then at a particular stage they thought that this could be seizures. So that time the patient was referred to neurology department. So this is a classical case wherein neurology is masquerading as psychiatric presentation. So initially it was thought that it is a psychosis. The patient has gone into psychosis. But it is not just plain psychosis, it is a neuropsychiatric manifestation. That means the psychiatric manifestation is because of underlying neurological condition. Now if you localize this problem, you can localize it to the limbic system because there is memory disturbance. So the temporal lobe is definitely affected in the hippocampus and the nearby areas. Likely right more than left because there is more of behavioral problem. These seizures are focal seizures with, sometimes it is with awareness, sometimes it is without awareness. So it is temporal epilepsy with facial twitching to the left. So right hemisphere definitely is affected. Contralateral face area, facial motor area, temporal area, operculum, etc. Subacute memory impairment, involvement of the memory circuit or the Papage circuit. Behavioral changes, irritability, wandering, psychosis-like features that again suggest that there is involvement of the amygdala and the orbitofrontal lobe, the temporal lobe, etc. So it is gradually progressing over a period of 3 months. So it is definitely a subacutely progressing condition. It is not very acute, neither it is very slow like a degenerative condition. It is subacute condition. So whenever there is a subacute condition in the nervous system, you have to think of either inflammatory, infective, infiltrative lesion or a space occupying lesion. So subacute limbic encephalopathy with focal seizures was our diagnosis. And the differential diagnosis was like a case of a rapidly progressive dementia with seizures. And the dementia is in the form of behavioral abnormalities and also memory problem. So we thought this is definitely a case of autoimmune limbic encephalitis. So the likely causes we thought is autoimmune encephalitis or paraneoplastic limbic encephalitis. Other conditions were also considered, as I told you, neoplasm, for example, a glioma or something growing in the frontal region, then going into the temporal region, or infiltrative lesion like as I presented another case, lymphoma, parenchymal lymphoma can present like that. Degenerative is very unlikely because it is relatively it is a subacute presentation, not a chronic insidious presentation like a degenerative condition. Metabolic toxic also is unlikely. Metabolic toxic usually will be acute in presentation and there will be fluctuation in sensorium. Sometimes patient is normal, sometimes patient is completely confused like that. And there was no known metabolic factor like her blood biochemistry was completely normal with creatinine, thyroid, liver function tests and vitamin levels and everything was normal. So we definitely thought that it is a subacute presentation of autoimmune encephalitis. So in this particular age, around middle age, limbic encephalitis because of LGI1 encephalitis was thought of. NMDA, I showed you a case, it usually presents in the young age in women, but at a younger age. Paraneoplastic possibilities are there, but the patient didn't have any known malignancy, but we always keep that in mind, especially in women for breast cancer, lung cancer, ovary cancer, etc. HSV encephalitis doesn't present like that, it is usually acute presentation. Neoplastic, I told you. Tuberculosis also possible, but then fever, headache, vomiting was not there. There were no constitutional symptoms. CJD, also low probability. There was no myoclonic jerks to the patient after a period of 3 months. So most important, what we have to know that this is not psychiatric condition. This is a neurodegenerative condition, neither it is a metabolic condition. So this is excluded from the history. And first thing what we did is we took a transfer of the patient and then investigated the patient further. And as the autoimmune encephalitis was high on card, we sent straight away the autoimmune encephalitis panel and her LGI1 came positive. So it is a case of LGI1 encephalitis, limbic encephalitis because of LGI1 antibodies. So this patient then received methylprednisolone, 1 gram pulse methylprednisolone for 5 days followed by plasmapheresis, and subsequently the patient was put on azathioprine for relapse prevention and as a steroid sparing agent, and the patient recovered completely over a period of few weeks. So the conclusion is in any young or middle aged patient with the new onset seizures and subacute, the course of illness is very important. Subacute presentation of cognitive or behavioral problems, limbic encephalitis has to be considered, and it is almost limbic encephalitis only unless it is proven otherwise, there is some other condition. So we have to keep this in mind that neuropsychiatric manifestation of these autoimmune encephalitis, limbic encephalitis has to be kept in mind in this particular age group. Another similar case I will show you, 60-year-old man presented with forgetfulness is 1 month. Now herein that earlier patient was hyper kind of irritable and aggressive, abusing. This was apathetic and he stopped going to work since 2 weeks and was being treated for depression. They thought that he has become apathetic, not interested and not going for his work, everything. So they thought it is a case of depression and then he was treated for depression with antidepressants. Then subsequently he was referred to neurology department when he started getting jerks in the left upper limb like that, and that time they thought that it could be something neurological. On examination there were facial and upper limb jerks which is typical of So here. So these are facial jerks, and here you can see the arm jerk also here. Just see here. This. Every few seconds the patient is getting these jerks. So these are faciobrachial dystonic seizures, which are very characteristic of LGI1 encephalitis, limbic encephalitis because of LGI1. So this patient again had LGI1 encephalitis or limbic encephalitis. So same thing, initially mistaken as psychiatric problem, it could be behavioral problem, hyper excitation, irritability or apathy, depression. And then once the patient develops these neurological features, then the patient is referred. But in any subacutely presenting case, we have to keep this in mind. So rapidly progressive dementia plus focal jerks, keep in mind autoimmune encephalitis or CJD, but CJD will have stimulus sensitive myoclonus. Depression could be a presenting feature in both these situations, autoimmune encephalitis, CJD or degenerative condition also, Alzheimer dementia. They may initially present with depression like features or apathy, but then it is a very insidious progression. Here it is rapid progression and then there is seizures. When a patient presents cognitive decline over weeks or few months, not years, and has focal jerks or myoclonus, you should first consider two dangerous conditions, CJD and autoimmune encephalitis. And depression or hyperirritability psychosis is a misleading diagnosis, and it can just distract you from the real underlying disease. So whenever a patient is referred to us with these complaints, we always keep this in mind and advise the imaging. Many times imaging will be normal, but if the patient has this type of hard findings of seizures, the first case had a focal seizure continuously and the second had faciobrachial dystonic seizures. So we are quite sure that this is a autoimmune encephalitis, and I can empirically just start treatment pending the reports, because the earlier you start the treatment, the better will be the response in these cases. Thank you.
Some of these patients of the, LGI1 would have hyponatremia, and so people sometimes are dragged to the diagnosis of hyponatremia producing that encephalopathy, and they are misguided that way.
Yeah.
Again, a very simple case. 37-year female, she came with a recurrent episodic and chronic vestibular symptoms since last 4 years. The episodic symptoms were of 4 years and the chronic vestibular symptoms are of 1 year. So she presented with that. In the past history, she had since 20 years history of occasional migraine and generalized anxiety disorder. Now we describe both the episodic and chronic vestibular symptoms. This episodic vestibular symptoms had been since 4 years in the form of the spontaneous episodes of the spinning or a rocking vertigo. It was aggravated by the head movements and usually accompanied by nausea, photophobia and phonophobia. She experienced bilateral mild tinnitus, but there was no oral fullness and no hearing loss. The episodes would last either half a day or sometimes it go up to 2 days also. In some of these episodes, she developed unilateral throbbing episodes, but rest she got only photophonophobia and nausea. Second type of the disorder that she described is, so since last year, she has been experiencing near on the daily basis episodes of lightheadedness and mild unsteadiness. This lightheadedness and mild unsteadiness would be aggravated by her own movements or by walking through the busy stores. Bazaar ma jao to lage padi jai like that. And even when she's scrolling on the computers or on the mobile smartphone when she's using, she'll feel uncomfortable, unsteady and tend to fall. And also while watching the action movies, she's uncomfortable. So, and she felt better when she was recombinant. And she had undergone repeated neuroimaging, audiograms, lab tests, all were normal. She was worried about having multiple sclerosis and a brain tumor. She had restricted her activities because of her daily symptoms to the extent that she would become incapacitated because of the attack. And neurological examination, oculomotor examination, vestibular examinations were all normal. What is the diagnosis? One says mania, one says migraine. Anybody? You have to shout. This simple case. vestibular migraine is a good thought, yes. So see, the patient's episodic vestibular symptoms along with the long-standing history of migraine, they are consistent with the vestibular migraine, of course, that's true. She had a history of bilateral mild tinnitus, which raises a doubt whether this is a Meniere's disease. See, in Meniere's disease, generally you have unilateral tinnitus, deafness, and fullness, and they are all fluctuating, unilateral and fluctuating, and they progress over a period of time. This 4-year bilateral mild tinnitus in a person who gets photophobia, phonophobia, and recurrent headaches along with this vestibular symptoms, this favors that this is a vestibular migraine. The criteria for the vestibular migraine is you need to have multiple episodes of this moderate to severe vertigo from 5 minutes to 72 hours. Along with this vertigo, you need to have, in half of the episodes, you need to have migrainous symptoms. These migrainous symptoms can be either a headache, or it could be photo or phonophobia, or it could be visual aura. If any of these are present in half of the patient, half of the vertigo situations, then you say this is definitely a vestibular migraine. And so in this patient had a photo and phonophobia in bulk of the episodes, and some she had a headache. So more than half of the episodes were associated with this condition and vertigo, and therefore it was a vestibular migraine. You will come across some situations when the person has a history of migraine, but the vertigo occurs separately and these migraine episodes occur separately. They do not occur together, and that is where you will use the word probable vestibular migraine. So yeah. What about this another episode that she was getting? She was also getting these episodes of now daily unsteadiness, non-vertiginous, dizziness. This was consistent with which entity? One with the episodic symptoms. What is this chronic? Psychiatrist. Kamlesh bhai kahan gaya? Where gaya? Okay. What is this? $1 million question. This is very common vertigo. This is triple PD, persistent postural perceptual dizziness. This is not uncommon. એમ નહીં કહેતા મેં નવી વસ્તુ કીધી છે. This is very, very, very common. Persistent postural perceptual dizziness. ઘણા બધા લોકોને વારે ઘડી ચક્કર આવતા ને 10 ડોક્ટરોને બતાવે ને સારું કંઈ મેળ જ ન આવે પછી then they become like this. અરે મને મજા નથી આવતી, અરે હું બહાર જાઉં ન જઈ શકું and this. So it is persistent. It is postural. જ્યારે ઊભા થાય હાલે ચાલે ત્યારે જ થાય, સુવે ત્યારે કાંઈ નહીં. And it is perception થતું હોય. It's a dizziness. It's not really a true vertigo. So bit of unsteadiness. This is triple PD. And so the final diagnosis is vestibular migraine plus triple PD. So that is our final diagnosis. Although the episodes of vestibular migraine are few per year, 10-12 મહિને વર્ષના થાય છે, they are briefly disabling, but she was more affected by this daily symptoms of triple PD, which has made her life miserable. Catastrophic thinking and avoidance behavior was there because of this triple PD. So is vestibular migraine common? How many of you say vestibular migraine is common? It is very, very common. It's very good. It's the most common cause of recurrent spontaneous vertigo. બેઠા બેઠા જો આમ ચક્કર શરૂ થઈ ગયા વારાઘડી આવતા હોય, think of migraine as one. In fact, number 2 highest that vertigo that you see, number 1 is BPPV, second is a vestibular migraine. In one of the meets, we have been taught that if you see a patient of vertigo, ask him the age. If he say above the age of 50, write the diagnosis BPPV and then take the further history. If you see below the age of 50, write the diagnosis vestibular migraine and then ask the history. That much common is a vestibular migraine. So vestibular migraine should always be in our differential diagnosis. It is more common in females, but it is grossly underdiagnosed. And therefore, in all young patients below the age of 50, ask for the history of migraine and try and associate if it is there. Of course, you have to look carefully at that patient. What types of vertigo are noted in vestibular migraine? Anybody? કેટલા પ્રકારના vertigo હોય? You get either a unprovoked episodes of the rotational or even a to and fro vertigo. Not necessarily it has to be rotational. You can also get a head motion intolerance. થોડું માથું હલાવીને મજા નથી આવતી, આમ ગમતું નથી. That's not necessarily it has to be like this. So head motion intolerance is also common. Third is a positional vertigo. BPPV ની જેમ જ સુવે કે બેસે તો જ ચક્કર આવે. But this BPPV like phenomenon in vestibular migraine would be a few hours or એકાદ બે દિવસ માટે હાલે. And you see in the younger patients. And when you do a Dix-Hellpike test or supinol test, that is negative. So a younger patient, few episodes of which looks like a BPPV is actually not a BPPV. BPPV usually seen elderly, of course you can see in all the age groups, but they last for few weeks or days when they come to you. But here it will be few hours or 1 or 2 days BPPV like phenomenon. Another is a postural unsteadiness like phenomenon. કોઈ ઘરમાં ઝઘડો થયો હોય અને પેશન્ટ આપણે આમ કહીને બતાવવા આવે તો આપણે એમ કહીએ કે આ તો માનસિક છે. But actually they are one of the episodes of the vestibular migraine. So these all episodes, 4 types of the vertigo that you get in vestibular migraine can occur either in isolation or simultaneously, or they can occur even sequentially. So therefore, you should respect all these symptoms. What is the examination finding that you get in a vestibular migraine? Anybody? Vestibular migraine patient આવે તમારે, it's very common. If you start looking at it, you will see આટલા બધા આપણે મિસ કર્યા હતા. It's very, very common. So હર 10માં પેશન્ટ માઇગ્રેન વાળાને વેસ્ટિબ્યુલર માઇગ્રેન હોય જો તમે એને સરખી રીતે ઇવેલ્યુએટ કરશો અને માઇગ્રેન તો કેટલું કોમન છે. So what is the best? So if you get the patient, see the patient between the episodes, the examination finding is normal. You don't get any finding. But during the episode of vertigo, if you see, you get all the varieties of the nystagmus, upbeat nystagmus મળે, downbeat મળે, horizontal મળે, gazy walk મળે, દુનિયાભરના nystagmuses, oblique nystagmus મળે, but that will disappear in a day or two. So if they disappear in a day or two, then you think that this is related to the migraine. But if it happens for the first time, you have to investigate that patient. The patient સાહેબ આ તો એક દિવસે મટી જ જાય છે, કાયમ આવું જોઈએ છે આમ તેમ. Then you are reassured. એ જ દિવસે એને સ્કેનમાં પુશ કરવાની જરૂર નથી. Otherwise, when you get a central nystagmus, we push the patient for the MRI. But you call the patient on next, after 1 or 2 days when the migraine is gone, these all findings would have disappeared. So whenever you see a patient with headache plus vestibular symptoms, see, migraine is very common in the community, right? So બધા migraine પેશન્ટોને જે કંઈ વર્ટિગો આવે કે બધા વેસ્ટિબ્યુલર migraine ન હોય. So first thing is rule out others. Rule out others. So suppose patient આપણે એમ કે મને BPPV જો સૂવો અને બેઠો ચક્કર આવે migraine patient એમ કે, so first you have to do is a Dix-Selpike test and supine roll test and rule out BPPV. તમારામાંથી કેટલા લોકો Dix-Selpike test કરે છે? Wow, I'm so impressed. Everybody should do it. Everybody should do it. આ આવડી જાય ને એક તમારા પ્રેક્ટિસમાં એક મજા આવી જશે because એક જ દિવસ 2 દિવસના પેશન્ટ બીપીપીવીનું ઇમ્પ્રૂવ થઈ જાય and it's just lying and sitting. How many of you do supine roll test, rollover test? એ તો સહેલામાં સહેલું છે. પેશન્ટને સુવડાવો, આ બાજુ જુઓ, અડધી 1 મિનિટ રાખો, પછી આ બાજુ જુઓ અડધી 1 મિનિટ. હોરિઝોન્ટલ nystagmus મળે, supine roll test. Nothing. It's really very simplest thing on the earth to do. Supine roll test, you should do all the patients for BPP. So if it is not there, 1 or 2 days history of BPPV like phenomenon, younger patient, think of migraines. Second is a mania disorder. When the patient has cochlear symptoms, ask carefully. Unilateral fluctuating deafness or progressive this thing is. We had one patient who would come with a unilateral deafness. He was a secretary of one of the END and one of my neurologist friend happened to meet that ENT friend. Kya hai hamara secretary ne કાઢીને meanier છે કેટલા વર્ષોથી. And that secretary, he told that secretary to bring the water while he was there. And that secretary told કે સર મારા ધ્યાન નથી આપતું, મને બહુ ચક્કર આવ્યા કરે છે, હવે તો મારું meaniers મોઢામાં આવી ગયું છે, અહીંયા અડું ને બેરું લાગે છે. That's not the phenomenon of meaniers. And she was investigated and she found a vestibular schwannoma. So sometimes menial disease which comes with the unilateral deafness, you have to examine that patient very properly because you may miss the diagnosis of the vestibular schwannomas. So in menial disease, ask the proper symptom, fluctuating hearing loss, deafness and fullness along with episodes of the vertigo. And this vertigo of the Meniere's disease would last from 20 minutes to 12 hours by and large. It's rarely 24 hours. But if it lasts 2 or 3 days, Meniere's goes behind. Of course, we have to think all consider together. And if it is the first time episode of a severe vestibular symptom, then you think of vestibular neuritis and you do a head impulse test. How many of you do head impulse test? Hi, great, you are genius. Head impulse test should be done. તમે head impulse ની side છે, head impulse નેટમાં લખો ને તમે 10 videos મળશે. Just આમ જુઓ. And you can diagnose right at the bedside when you're seeing the patient of severe vertigo and vomiting that this patient has a vestibulitis. Head test is such a phenomenal test. And then you see after that a nystagmus. Look to the right, look to the left. If it's a bilateral, you get a nystagmus, what we call gaze-evoked nystagmus, then suggests a stroke in acute setting. And if it's unilateral, then you are really towards the vestibulitis. And then you see a test of skew. Test of skew કેટલા લોકો કરે છે? Doing test of skew, એક આંખ બંધ કરો, આંખ બંધ કરો. આંખ ઉપર નીચે જાય, test of skew is positive. So that suggests stroke. So you should also do a test of skew. So, I mean, what I wanted to say is, just because the patient has a migraine, you don't just jump to the vestibular migraine. Look at the alternatives. Look for the dangerous Ds, diplopia, dysarthria, dysphagia, and other dangerous D signs in a patient with migraine. And if it is there, think of the stroke as well. But if you have ruled out all this, then you are really thinking towards the vestibular migraine. How do you treat vestibular migraine? Madam, how do you treat vestibular migraine? You educate the patient, reassure the patient about this thing, and talk about the lifestyle factors, and you give simple vestibular suppressant drugs જે આપણે બધા આપતા જોઈએ છે, cinnarizine, beta-histidine, antiemetic. Even if the person has that during episode headache, then you give a triptan also works. And those patients who get multiple episodes in a month, you give them the prophylaxis of migraine. જે તમને ગમતું હોય, topiramate, amitriptyline, beta blocker, whatever. So those who have multiple episodes, you treat it. એકાદ episode મહિને બે મહિને આવતું હોય, just reassure them. What about the triple PD? How do you treat that patient? You do a lot of counseling, maybe involve a psychiatrist, maybe involve a counselor, and you give SSRI or SNRIs. Among the drugs that I like, of the SSRI, SNRI, I like the venlafaxine the most, because it works very well for the triple PD, and it has also been one of the drugs to be used in migraine and vestibular migraine. So if you are fond of this drug like me, then this is one drug that I would suggest that you should try and use more and more. So my pearl of the case is recurrent vertigo with migraine features strongly points towards vestibular migraine, even when the patient does not have a headache. You can have either a headache or a photophonophobia or a visual aura in half of the times. Normal imaging and audiometry does not mean that person does not have a disabling disorder like as we see in triple PD. Daily dizziness worsened by motion, visual stimuli and busy environment suggests triple PD. Vestibular migraine often triggers triple PD. શરૂઆત migraine થી થાય અને પછી patient ઘબરાઈ જાય, 10 ડોક્ટરોને બતાવ્યું vestibular migraine માં, then he converts to a triple PD in addition. And therefore, you have to treat both not only migraine, but you have to treat the triple PD with the and good counseling. Thank you.
This is a 10-year-old female who presented with imbalance and numbness in the hands and feet since 1 month. The imbalance was more in dark and with eyes closed. So she had typical wash basin ataxia. Her speech was normal. There were no other complaints. On examination, the deep tendon reflexes and plantar were absent and there was gross sensory loss. So this is the Romberg's test. With eyes open, the patient is stable. Now the patient is closing the eyes, just see. She is falling. So the Romberg's test was strongly positive, suggesting that there is sensory ataxia and gross sensory loss. So this girl presented with a subacute or relatively acute history, you can say, but not hyperacute, over a period of few weeks, 1 month. Imbalance worse or in dark with eyes closed, ataxia, sensory ataxia, with Romberg's positive wash basin ataxia, distal numbness, areflexia. So this localizes to the sensory nervous system. So the sensory nervous system problem could be in the peripheral nerves, it could be in the dorsal root ganglia, it could be in the roots, it could be in the posterior columns. It could be anywhere. We can't say from the examination only. Main features are sensory ataxia, lower motor neuron size in the sense that there is areflexia, there is generalized areflexia, suggesting that there is peripheral neuropathy or polyradicular neuropathy more than posterior columns. If it is posterior column, then the reflexes would have been present because the spinal reflex arc would have been is preserved in those cases. There is no motor weakness. So motor examination is completely normal. So it is a pure sensory involvement. So what are the possibilities? If it is over a period of 1 month, you have to keep in mind sensory variant of GBS or ataxic variant of GBS, because the patient may progress further, we don't know. It could be Miller-Fisher syndrome if the patient develops subsequently ophthalmoplegia and in the beginning only sensory symptoms, ataxia. It could be a sensory CIDP if the course extends beyond 8 weeks. If the disease keeps on progressing beyond 8 weeks, it could be a sensory CIDP. Very common, we have to keep that in mind, B12 deficiency. It can present similarly. Vitamin E deficiency. Usually they present over a period of few months or years, slowly like that, but we don't know. You have to keep that in mind because it is a treatable condition. Again, paraneoplastic autoimmune sensory neuropathy. So in neurology, whenever we see a patient, the ODP will decide the etiology. If it is an acute presentation, different set of conditions. Subacute presentation, different, chronic, degenerative. Acute could be vascular, toxin, injury, whatever. So this is a subacute. So whenever there is subacute problem in the nervous system, you have to keep in mind inflammatory immune mediated conditions or paraneoplastic conditions. Okay, so in this particular case, we thought that it could be some autoimmune sensory neuropathy or neuronopathy, or it could be GB syndrome, we have to wait, or it can progress, we don't know. Cerebellar and spinal cord is very unlikely, because cerebellar it is not there because there are no dysarthria, there is no nystagmus, there is no limb ataxia. Spinal cord also less likely because there are no pyramidal findings. There is no sensory level, it is generalized sensory loss, and it happened just suddenly, all of a sudden. So technically in the sensory nervous system also it cannot be a sensory polyneuropathy, because sensory polyneuropathies usually start distally and slowly progress like that. Here it doesn't happen like that. You just noticed like that it has happened. So it is relatively acute onset involvement of the sensory nervous system, that is the sensory ganglions. Generalized sensory ganglion involvement, sensory ganglionopathy was the diagnosis. So this is what I have just told you. So in this particular case, we investigated the patient, and her anti-Rho and La was positive, and the patient was diagnosed to have Sjogren syndrome, and she was treated with IV methylprednisolone plasmapheresis. So this case, I have 3-4 cases of Sjogren syndrome presenting like that. They don't respond well. So in spite of this IV methylprednisolone and plasmapheresis, etc., there was only modest benefit, and sensory ataxia was still there. But prevention of relapses is quite effective with the immunosuppressants, azathioprine. So some of the patients have just stabilized, and there is no further progression in this sensory ganglionopathy. Rituximab I have not tried. I have tried cyclophosphamide earlier when it was available. Though recently, I have not tried rituximab. I don't know whether it will be specifically useful, because rituximab it works on the IgG4 and B4. So I don't know whether in Sjogren syndrome. So did it improve or it prevented relapses? So prevention of relapses, cyclophosphamide, azathioprine, I have patients. So the relapses are not there. But for recovery, regain of function, it doesn't work.
થાકી ગયા એવું લાગે છે? થાકી નથી ગયા ને? જ્યારે કહેજો બંધ કરજો. Neurology is something, you know. Okay, I am going to show you a rare case, right? Okay, okay. This 12th standard girl, she came with recurrent episodes of that when she gets up, she'll get this posturings of the limb and last for 5-10 seconds, and then she's okay. Or when she runs from standing, she'll get this episodes lasting like this for a few seconds. And so I'll show you the video how this 12th standard girl with a lot of stress of Gyan Manjari, she comes to you.
When you bring them into hospital, try and get an
Oh God, not working?
you know, it's when you bring them into hospital, try and get an attack, it doesn't happen. So here's a.
So this is the posturing that she's getting. Video is of the home. Just like this, I'm just telling you, describing it. And in few seconds, 10 seconds or so, she is absolutely fine. And she gets multiple episodes per day. I want you to raise the hand. Functional, not functional. Those who say functional, raise the hand. Only 3, 4, 5. બીજા શું માનો છો? Multiple episodes per day, 12th standard girl. She comes in. One more video I'll show you. This, okay, one more video. This boy says, whenever I get up on the chair, I get this dance-like movements. And he came with this. He's initially explaining it, because once I'll get up, I'll get this type of the movements, and finally he gets lots of movements like this. And so he gets up, and little bit it starts, and then he gets that florid movements. You will see it. Look at this. It lasts for a few seconds. Multiple episodes per day. Seen few psychiatrists. Functional, not functional. Functional, raise the hand. But the non-functional, then what it is? What is it? Those who say non-functional, tell me what it is. Madam? Huh? Same repeated episodes, one gets this and one gets this. Multiple episodes per day. No, it just disappears. After the episode is over, person is doing all the normal activities, both of them are all the normal activities, but suddenly repeated episode, it's not epilepsy. EEG was done, MRI was done, normal examination, everything normal. What do you think this is? No rheumatism. Because in rheumatism you get a chorea, but it goes on and on and on. This is just episodes. So these are nothing but paroxysmal movement disorders, which are not being diagnosed most of the time, and they go on between psychiatrist to psychiatrist. These are basically attacks of the involuntary movements, either in the form of the dystonia, which we saw one patient, or in the form of the chorea, or it's a combination of two, without loss of consciousness. And these patients have certain triggers which produce this kind of the movements, and these triggers are various. Now in this patient, sudden getting up was the trigger. So when this we call it as and so depending on the triggers, we say it's a kinesogenic dyskinesia. So when you get a sudden movement, you get this thing. There are other people, once they exercise, after they exercise, they get this type of episodes. And there are others who get these episodes after drinking tea, coffee, alcohol, after a lot of fatigue. So we say there are three types: kinesogenic with the movement, non-kinesogenic means tea, coffee, alcohol, and fatigue, and exercise induced means after prolonged exercise, they get this type of the dyskinesias. Now I'm showing one another video. This is a bowler who does a bowling, and after the ball, focus on the bowler, what episode he's getting, and then you tell me. Before you see that, I'll just describe what is paroxysmal kinesogenic dyskinesia. This is nothing but a sporadic or a familial autosomal dominant disorders. In half of them, you will get a family history positive. Younger patient, below the age of 20, more in males, and provoked by sudden movement or a startle, or from standing to running, they get these episodes. And they last usually less than a minute. Multiple episodes per day. EEG and MRI is normal, and this decreases after the age of 35. So till then you do treat it, and they respond beautifully to a small dose of carbamazepine. 200 ke 300 milligram carbamazepine apo, and the patient arm thai jai. Right? We recently had shown this video to one of our medical officers in our clinic, and next day we got a patient. She said, "Sir, PKD no patient ayu che. This is PKD, paroxysmal kinesogenic dyskinesia." So once you see, you keep diagnosing it. Look at this bowler. Look at this bowler. He's running, he's throwing the ball, and after he stands, on the right side, look at his right upper limb. ત્યાં તો ઢાંકીને વયો જાય છે આમ તેમ. જો છૂટો થાય છે, you will realize that he is keeping his right hand little different. આમ બોલને આમ પકડતો હોય એવું આમ એક્શન કરે. બોલ તો વયો ગયો છે ત્યાં. But you know, he does all this thing. He's getting this posturing. Right leg is also a little bit limping, and then in a few minutes he's over. He's getting recurrent episodes. He saw multiple people. People could not diagnose it. Next video I'm showing you is a boy who says that in the morning rickshaw comes, and therefore he had to run a lot and to reach to the auto to go to the school. And once he runs a lot and finally reaches over there, he gets this abnormal posturings of this thing, like dance kind of a thing, and you do all these things. And then, you know, this remains for a longer duration. And this would remain 10-15 minutes, and then the child is okay. And he was told, khoto show, and he had seen a lot of psychiatrists. કે દોડી દોડીને સારા ઘરે કાંઈ નહોતું, દોડીને રિક્ષા પકડો ત્યાં જવું થઈ જાય છે. You know what? How can this possible? And this is another man who runs a lot, and after that he gets this abnormal posturing right upper limb and the leg. So these two videos are of exercise-induced dyskinesia. So paroxysmal exercise-induced dyskinesias. And the duration of attack in this are a little longer. But PKD initially we thought was a few seconds or less than a minute. This is 5 to 30 minutes. So this છોકરો ટાણી આમ કરે 10-15 મિનિટ થાય, 10 મિનિટ હાલો રેડી થઈ ગયો. તો ઘરવાળા મારે જ ને. But if you are aware of this condition, then you don't do all these things. And the duration and the distribution attacks more in the feet, but can be secondary generalized as well, or sometimes on one side of the body. And these patients are treated with benzodiazepines. But most of the times we say, we have to prevent the next episode by this. This another man, he was an army man. He said, you know, this army man, he would get a night duty. Akho this duty karta hai, night male. So he got a night duty, and night duty કરવા શું કરે? 2-3 કપ કોફી પી જાય, અને પછી ડ્યુટી કરે એટલે પછી હાથ ડાન્સ થઈ જાય. કલાક અડધો કલાક હાલે, સૂઈ જાય તો બંધ થઈ જાય. Once he sleep, it disappears. લોકો એમ કે આ ખોટો માણસ લાગે છે. Look at this army man. After 2 or 3 cups of the coffee, he gets these episodes of the left side. હવે હલ્યા કરે ડ્યુટી શું કરતો હતો, આખું ફોકસ એના પર ચેન્જ થઈ જાય. And this will last for 1 hour. ચાલ્યા જ કરે. So this is paroxysmal non-kinesogenic dyskinesia. This is all are rare, but you should be aware of this thing. That's why I'm showing you. There's mixed dystonia, chorea, and hemiballism, It can be hemi or generalized. Sometimes speech is affected. The problem is the patient ને એક કે બે દિવસ માટે અટેક્સ આવે, 2 કે 3 દિવસ માટે, પછી એક બે અટેક્સ આવે, 5-15 દિવસ આવા અટેક્સ આવે, પછી એકાદ મહિનો કાંઈ ન આવે, પછી ગમે એટલી ચા કોફી પીવે અટેક્સ ન આવે. Now therefore people say that this is all functional disorder, but they are not functional actually. And usually they are long duration attacks. Tea, coffee, alcohol and fatigue, they will all precipitate this kind of attacks, and they get a sleep benefit. And they also respond to benzodiazepine to some extent, but we say that you have to avoid the triggers. The trigger on the cartridge, but migraine ki triggers ne dhyan apo. So we saw 3 types of the disorders: paroxysmal kinesogenic, exercise-induced, and non-kinesogenic. All occurs below the age of 20, lasting 2 minutes, 10 to 15 minutes, 1 to 6 hours. The PKD is precipitated by the movement, exercise is precipitated by exercise-induced, and that non-kinesogenic is precipitated by tea, coffee, alcohol, and fatigue. Hemi or generalized dystonia, family history positive, and all of this you can do a genetic test. They are not fake. PKD you get PRRT2, PAD or exercise-induced you get GLUT1, and PNKD you get MR1 genes. Of course, there is some overlap, but in general, these are the genes that you get positive in these patients, and you do treat these patients. Now look at this video. What do you think this lady has? Quiz. Multiple episodes per day, and she is also having forgetfulness. What do you think? 10 second episodes. Gold medal, madam. What is this? She is forgetfulness, multiple episodes per day. She had a hyponatremia. Sir showed so much of a good, excellent videos. And so this is a faciobrachial dystonic seizures due to LGI1 antibodies. This is autoimmune encephalitis. So therefore, unless you see one patient which you have drained your mind, this autoimmune still doesn't go in your head. So how do you know that this is paroxysmal exercise-induced or non-exercise-induced or this non-kinesogenic dyskinesia? These are secondary paroxysmal dyskinesia. These are not primary. જે મેં 3 પહેલા બતાવ્યા, they are primary. એમાં કોઈ કારણ ન હોય. In between the episodes, if you examine the patient, they are normal. Whereas this patient had a cognitive decline. This patient had a hyponatremia. This patient had a LGI1 antibody. This patient, MRI brain had shown a limbic encephalitis. And therefore, late age of onset means you think that this is a secondary paroxysmal dyskinesia. And there is an interictal examination is abnormal. The sudden onset, unusual precipitating factors. પહેલામાં તો ફિક્સ હોય, ઊભો થાય ત્યારે થાય, અથવા તો દોડે ત્યારે થાય, અથવા તો એક્સરસાઇઝ કરે ત્યારે થાય, અથવા તો ટી કોફી આલ્કોહોલ થાય. આમાં unusual precipitating factors, unusual gait, abnormal labs and neuroimaging, and there is a lack of response over usual drugs. This is another boy who came with multiple episodes of the jerks on one side of the body, and it was seen by many people. And you know what? Despite this jerks, he was given a trial, PKD, બધું આપી દીધું, કાંઈ સારું ન થયું. It was seen that he had abnormal gait, spastic gait હતું એનામાં. Reflexes were brisk, that you don't expect in all those primary dyskinesias, and therefore this patient had a big glioma in the cord, and therefore he required the surgery. So there are various causes of secondary paroxysmal dyskinesia. My message is that you should recognize the secondary causes and if need be investigate those. Like in MS you get this paroxysmal dyskinesia, NMO spectrum disorders, in case you are seeing that patient you get this thing. Cerebral palsy, you get these disorders. Hypoparathyroidism and pseudo-hypoparathyroidism, you get it. Hypoglycemia can sometimes produce. Thyrotoxicose and hypothyroidism can produce. Head trauma can produce. Cerebrovascular disease he can produce. You can see that sometimes patient has a tight stenosis. Lying down, nothing is there. When he gets up, he gets a little bit of a jerk and this is a movement and you go away. And then we call the limb shaking TIA, we call it, in case somebody has heard this. So limb shaking TIA comes like a paroxysmal dyskinesia, and you get a tight stenosis of the carotid. Cord lesion we saw, encephalitis we saw, and sometimes they can be psychogenic. So my pearl of the case is proximal movement disorders are present across the lifespan, from infancy to late adulthood. A good clinical history, including family history, and examination of the patient during the episode and in between the attacks is very critical to make the diagnosis and treatment of this disorder. Thank you.
So this is a 22-year-old female who presented with complaints of numbness in the left hand, which she attributed to lifting heavy bag while shopping. So she went to the doctor and told that there is numbness in the hand. I had gone for shopping. Bag were very heavy, 5 kg. Numbness has happened. See. So initially she was treated with multivitamins and some painkillers. Family doctor like that. Very common scenario. 2 days later, but she developed that the numbness worsened and she noticed some difficulty holding object with the left hand. So then she went to a local physician and they thought that there is some nerve compression happening and was prescribed multivitamins and pregabalin. With that, she was slightly better. That is what she said, but the numbness cannot improve with pregabalin. Pregabalin is used for neuropathic pain. So somehow with placebo effect she was a little bit better. But then subsequently she started getting real neurological, serious neurological symptoms like double vision, which was binocular when both eyes were kept open for near as well as far vision. And then she also noticed a peculiar phenomena. The double vision is more when she looks to the right side and the images are separated far apart from each other when she looks to the right side. Then it further progressed and then she said that she has difficulty in walking and she started losing balance and was swaying on the sideways while walking. There was no history of seizure, headache or any other symptoms. So with this history, what you can think of? Initially there is numbness in the hand, numbness in the left hand, then there is weakness in the left hand, then there is double vision. Looking on the right side, double vision is more, and also there is imbalance. Huh? How? No, we first want to localize the lesion. We can't go to the etiology. We have to tell which structures are affected of the nervous system. MS is etiology. No, first symptom was what? Numbness. Numbness and weakness, na? So that is coming from where? See, numbness and weakness, it is non-specific. It can be because of anything. It can be because of involvement of any nerve over here. It could be spinal cord with motor and sensory. It could be in the cortex also. It could be anywhere in the corticospinal tract along with the sensory spinothalamic tract. So we can't be sure. Numbness can be because of if the lesion is anywhere. You can't be sure only based on those two things. So there is an involvement of the sensory system as well as motor system. That much only you can tell. And the second symptom was double vision and looking on the left side. That is little bit specific. If it is looking on the left side only, either it could be left sixth nerve or right medial rectus, that is right partial third nerve. But there is no history of ptosis. So probably right partial third nerve may not be there. Left sixth nerve could be there. And then another symptom is there is imbalance, that the patient is having imbalance while walking and she falls on any side. So it could be involvement of the cerebellum, some cerebellum or its tracts, anywhere. We don't know where it is. There is no dysarthria, other symptoms are not there. So there is involvement of the nervous system in 3 places. So it is a multifocal lesion. That much you can tell. One lesion is in the near the sixth nerve, nucleus or the nerve or third nerve, sixth nerve, whatever. Then sensory system, motor system and cerebellum. Cerebellum also both sides it is there. It could be both sides of the cerebellum hemispheres, we don't know. So multifocal involvement could be there. The etiology, if it is multifocal, as we have discussed, it is subacute. So it could be again autoimmune, immune mediated or multifocal, some neoplasm like that, we don't know. So this is the examination finding. No movement of this eye. Only this eye is moving to the left side. Here there is no movement. So here entire movements are not there. Here there is only one movement with half movement with nystagmus. It is not seen. So the patient has 1.5 syndrome. So the lesion is where MLF of this side and 6 nerve nucleus of this side. So there is 1.5 syndrome. Okay. So the 1.5 syndrome is very typical for involvement of the internuclear fibers between the 6th nerve and the 3rd nerve, which is very specific. Okay. There are multiple lesions here: subcortical, periventricular, corpus callosum, and in the MLF and this 6th nerve nucleus, or PPRF rather than 6th nerve, PPRF. Okay. So patient had multiple lesions, but the episode was the first episode. Multiple sclerosis is recurrent episode of demyelination lasting more than 24 hours, and the 2 episodes should be more than 2 months apart. So here it is the first episode with so many lesions coming up. So we did a CSF, and CSF showed oligoclonal bands, 8 to 10 oligoclonal bands. So actually even on the first presentation only we can diagnose this case as multiple sclerosis, because there are multiple lesions which localize to multiple areas, and dissemination in time can be, you can use this OCB criteria for dissemination in time. So patient has multiple sclerosis on first episode only. We were diagnosed multiple sclerosis. So the patient was given methylprednisolone for 5 days. She had significant recovery, and then she had risk factors for poor prognosis, that the EDSS was more than 2 even after recovery. Presence of spinal cord involvement was there, I have not shown that. Presence of OCB which is more than 5. Hence she was started on rituximab. She has received I think first dose of rituximab 1 gram. That different regimen which we use, either 1 gram we give or 375 milligram meter square, 4 doses, or 500, then again after 2 weeks 500, like that we give. So patient has received rituximab, and now subsequently she is being followed up.
How many cases here? आप कैसे खत्म हो गए? 1:30 बजे तक है. We'll skip the simpler case. One more simple I'll add. Okay. Yeah. This 71-year lady, she is a known case of hypertension and ischemic heart disease. She presented with irrelevant talk and slurred speech since last 5 days, altered mental status since last 1 day. She had a history of cholelithiasis from 3 years, and she was on Ayurvedic medications, and the last couple of months her abdominal pain and nausea had increased. When you examine this patient, pulse was 100, blood pressure was high, 190 or 110. Her respiratory rate was normal. She was arousable, but she was disoriented to time, place, and person. Her speech was dysarthric, comprehension was impaired. A detailed higher functions could not be evaluated, but when you examine the motor system, nutrition was good, but she was moving all 4 limbs, and she had a hypertonia in both upper limbs and the lower limbs. No involuntary movements. Deep tendon reflexes were 2+, plantars were flexors, no neck stiffness. And this was the MRI. So far, so what comes to your mind? Okay, leave, we'll just see. MRI had shown multiple white matter lesions, on the right cortical and a little bit on the left side as well. And this basal ganglia also look little bit hyper intense. DWI and NGO were normal. Contrast MRI was normal. The other investigation revealed that hemoglobin was 8.2, and she had a microcytic hypochronic anemia. Blood glucose was 137, HbA1c 5.7, renal function tests were normal, calcium normal, electrolytes normal, LFT ammonia normal, thyroid function tests were normal. CSF was also done because of encephalopathy, which showed little high protein, significant high protein, normal glucose, and 2 cells. Somebody somehow sent the biofire panel as well, thinking of infection, and it was all negative, though she did not have the fever. So, what do you think she has? You heard so much of a story. Huh? Paraneoplasty, okay, that's a good thought. 5 days history. NMS, okay, but it's just an irrelevant talk. You know, NMS requires what? You need to have the extrapyramidal features, fever, high CPK and all those features. So yeah. What else? What comes to your mind? Yeah? So how Ayurvedic? Which metal? Mercury. What does Mercury doesn't do this thing? Which other things? Which other metal? Arsenic. Who said lead? Who said lead? You are a king. So 5 things were thought: immune-mediated encephalitis, infective, toxic, metabolic, and others. So among those, somebody said this, that, and you know, and people said, do autoimmune encephalitis panel, it's encephalopathy, done negative. And then you rightly said that heavy metals was thought, arsenic was normal, mercury was normal, and lead was sky high. And this level was above 100. Normally you don't expect lead, but above the 20, if it is level, then it is significantly high. Below that, bit of a high is somehow known. So this was a toxic encephalopathy due to lead. So this patient was taking Ayurvedic medications, and this medication for cholelithiasis, since last 3 years she's been taking, but last 1 or 2 months, since the pain had increased, she had taken a bigger dose as well. And therefore, this heavy metals came from this preparation. This Amruta Guglu and Mansa Pachak Vati, they are the ones which contains the lead. Actually, these are not supposed to contain the lead. Whenever you see any Ayurvedic productions, if they are local made, then the chances of that having the lead are high. So you should ask, kahan bana hua hai bhai? Local made hai? Then you have to be very careful, and you have to think seriously about the heavy metals in this. Otherwise, this is a good product. I am not aware, I am not favoring Ayurvedic, but you know, if it is local made, then the problem arises more. So how do you treat this patient? How do you treat? Who said? What? Yes. Yes, so you give BAL. So she had received the 5 days course of the BAL because affording patient, so diasodium meditate was available at that time it received, and subsequently was put on the penicillamine for 4 weeks. So she started improving after 3 days of receiving this drug. She became alert and oriented in 3 days, and after 5 days receiving, so after a couple of days of that, and there was mild dysphagia at 1 week, and the lead levels had come down at 1 week to 51. So this again favors improvement, just receiving BAL, and so this was the lead encephalopathy, no doubt about that. So when you should suspect lead encephalopathy in adults, you know, we always talk of lead encephalopathy in children. When you suspect, when somebody is having occupational exposures of manufacturing of the batteries, pens, ammunition, and construction materials, these are the people. If they do not use, you know, the safety wears, and if you are not washing their hands, and if they are doing the longer hours of the duty, malnourished people who are deficiency of iron and zinc and calcium as well, these are the ones who get more to this lead encephalopathy. Or another is a traditional medicine, as we saw in this patient, and another is a contaminated alcohol. So the clue to this diagnosis would be a lead lines. So you see this lead lines, these are blue lead lines that you get at the gums. This gives you a clue. And then there is an anemia with a basophilic stippling that again adds to this thing. If you do the iron levels in this patient with anemia, they will be all normal. So normal iron levels in anemic patient, hypertension, encephalopathy, lead lines, occupational exposures, or traditional medicine, think about the lead as a cause. What are the neurological manifestations of the lead toxicity? In adults, they can come as encephalopathy like headache, vomiting, seizures, paralysis, ataxia, or coma, but they more come in a chronic course. In children, they can come with a developmental delay, learning disabilities. You do not realize why this child is having a delay because we do not have the trend and fashion of doing the lead levels. Behavioral abnormalities, ADHD, sensorineural deafness, they can come in the children. In adults, they can come with memory problems or mood disorders, or they can come with a peripheral neuropathy. In our college days, we were taught, if somebody comes like this, think about the lead, somebody comes foot drop. So wrist drop and foot drops are the one we used to think. But it comes with generalized peripheral neuropathy, it can come with the mood impairment and the memory disorders. This is a mnemonic to be remembered for lead toxicity, A, B, C, D, E, F, G, H. A is anemia, B is basophilic stippling, and then again B is a Bortonian gingival lines, C is colicky abdominal pain, drop, wrist drop, foot drop, encephalopathy, facial pallor, growth retardation, and hyperuricemia. Actually, it involves all across the body. So my all of the cases, lead can cause encephalopathy, not just neuropathy. Though lead toxicity is common in children, it can be seen in the elderly. Be on guard with the Ayurvedic medicines. Always check drug and medical history in case of unexplained encephalopathy. You know what? There was one study of the status of lead poisoning. It was said that lead is seen in 1/3 of the old children globally, this poisoning. And 2020 UNICEF Pure Earth guidelines have found that half of the Indian children have high blood levels. You are not supposed to have any lead in the body, and they were high, but it was 5 microgram per deciliter. But it exceeds the WHO's limit, and about 64 million had the about 10 micrograms. So some of the children, in the lower community, they are like, thinking bit of a IQ instead of 100, if they are 90, 95 IQ, you don't even realize that they could be suffering from the lead encephalopathy. And in 23 states of the India, it was found that lead levels were high. And this lead not only comes from this battery work, mining and glass manufacturing and ceramic work and pottery, but they can also come from non-occupational sources like traditional medicine, vehicular exhaust, and household storage batteries, household paints. Even there was one study conducted in Patna. They went door to door and they saw that where this lead is coming so much. Why in Patna they saw a lot of lead poisoning. And they found that this lead was coming from the household utensils that they are using to store, that we are using to make the food, and that we are using to serve. Pressure cooker would have the lead. The bowls that serve, they would have the lead. The tins in which they keep the food, they would have the lead. And so therefore, and this lead encephalopathy, although we say encephalopathy, but then mild high levels would ruin you behind, They would not even realize that bit of a peripheral neuropathy, why it is occurring, bit of encephalopathy, why it is occurring. Second important source they found in that Patna study was turmeric, garam masalas, and coriander. That is where they had found the lead. Turmeric બહુ આમ ચમકતું ચાંદ દેખાતું હોય ને રોડ પર મળતું હોય ને, don't buy that. That can have the lead because they adulterated them with the lead. Thank you. We'll be finishing in 15-20 minutes. Don't worry, I know you all are tired.
पिक्चर बाद में दबा के फोटो बाद में Coming to the next case, he's a 62-year-old male auto rickshaw driver. He came with the complaints of 3 months history of painless progressive diminution of vision in the left eye. There was drooping of the left eyelid and double vision, which was progressive with complete ptosis of the left eye at presentation. So what do you think? Where is the lesion on this history? So the optic nerve, as I told you, anterior to the chiasma, and left eye drooping of eyelid with complete ptosis, that is the third now. So visual acuity, right eye 6, left eye 1 meter, left eye fully dilated, direct as well as consensual reflex, complete ptosis, impaired elevation, depression, abduction and adduction. So abduction also is affected, the sixth nerve is also affected of the left eye. So it suggests that the third nerve and the sixth nerve are getting affected together. So these two nerves come close to each other in the cavernous sinus and the superior orbital fissure. So the lesion could be anywhere there, along with involvement of the optic nerve. So there is a almost complete ptosis. The third nerve is there, but eye also doesn't abduct completely. Pupil is also affected. So this patient, MRI was done, as I told you, superior orbital fissure involvement was there, but the lesion is just involving the optic nerve also. In these type of cases, usually there is a inflammatory granulomatous inflammation over there many times, Tolosa-Hunt syndrome. So many times the etiology is not known, but sometimes you may pick up something. In this case, in this particular case, IgG4 antibodies were positive. It was 3.65. Upper limit is 2. So this is a IgG4 mediated disease, orbital pseudotumor of the left orbital apex. This patient was treated with steroids and rituximab, and subsequently the patient is better. So third, fourth, sixth, now cavernous sinus, superior orbital fissure or somewhere there, IgG4 mediated disease this particular patient had. Another case, 62-year-old male, slightly similar case, no hypertension, presented with History of drooping of left eyelid with subacute onset without diurnal variation associated with double vision. Image separation increases while looking to the right side. Also there is numbness on the left forehead. So fifth now first division is also involved. Vision is normal. There is left eye ptosis, elevation, depression, adduction, left eye impaired, pain temperature impaired in the fifth now division, first division. Rest of the cranial nerves are normal. So again the localization there. You can see here. The big cavernous sinus meningioma on the left side. Another case of cranial nerve involvement. A 40-year-old male presented with no previous comorbidities, presented with 10 months history of decreased hearing on the right side, imbalance while walking and deviation of the mouth to the left side since 3 months. So relatively long history, around 1 year history, 10 to 12 months of decreased hearing, and now the symptoms have progressed to involve the 7th now, because there is deviation of the angle of mouth to the left side. That means there is again involvement of the right 7th now element along with imbalance. So there is the involvement of the cerebellum also. So these three things only tell you that the lesion is in the cerebellopontine angle. Okay. So on examination there is a nystagmus, horizontal beating, jerking to the right side or looking to the right, jerking to the left side or looking to the left. There is impaired conjunctival and corneal reflex. There is Bell's phenomena with deviation of the angle of mouth to the left side. Sensory neural hearing loss. Finger nose examination positive, suggesting involvement of the cerebellum. All cerebellar signs were positive on one side. Bilateral plantar extensor. So the pyramidal tracts are also getting compressed because of the lesion. So now you are quite sure that this is a cerebellopontine angle lesion. You can see here. Here marked dysarthria. Hearing was impaired on this side. No, can't hear. Sensory neural hearing loss, profound. There was a big lesion, vestibular schwannoma. So these patients can present in a different ways depending on which direction the vestibular lesion is increasing. As earlier it was told that the patient presented with vertigo, and then there was a vestibular schwannoma. So this patient didn't have vertigo. This patient presented with reduced hearing, imbalance and facial asymmetry like that. So they can present like that also. Based on how the lesion is progressing and progressively which part of the nervous system it is compressing, the patient can present. So this was a CP angle tumors involving the 7th, 8th and the 5th now first division, CP angle. So the patient was operated and subsequently patient is quite fine now.
Yeah. So again, a very simple case for all of you. So don't say it is not simple. 77-year-old female, she presented with abnormal movements of left arm, left leg and left side of the face. She has a history of diabetes type 2 and she had a poor compliance. She ran out of the medication not taken for 2 weeks before she developed this flinging movements of the left arm upon awakening in the morning, and followed in few days by the similar movement in the left leg and in the face as well. These movements would gradually become worse over a bit of time, and therefore she saw us. The movements would abate during the sleep. Just see the video. Instant diagnosis. Chorea. Okay. What else? Anybody? Hypocalcemia. Okay. Hyperglycemia. So what is the name actually for this disorder? Okay. You are right. So the blood glucose was very high. HbA1c was 12. There was no ketosis. And so the diagnosis left hemichorea or hemibellism secondary to non-ketotic hyperglycemia. This is the correct word, and you all are right. And so this, what is chorea? Chorea is derived from the Greek word which means dance. So these patients are dancing all the time. It's a random and the flowing quality of movements giving dance-like appearance. Randomness is the key. You can't predict. They flit from one body to another body part in an unpredictable fashion. Another important thing is the motor impersistence this patient. હાથ દબાવવાનું કહો તો આમ દૂધ દોતો હોય ને એવું લાગે આમ અથવા તો હાથ ઊંચા રાખવાનું કહે તો ઘડી ઘડી પડી જાય. You tell the patient to stick out the tongue and they would not be able to maintain that stickiness. So that motor impersistence is another very important feature of the chorea. So when you do the MRI in this patient, what do you expect? There was a hyper intense signal in the right side. This you see over here. This is very much seen in case of the non-ketotic hyperglycemia. If you are shown this in the exam, you would say, okay, this is non-ketotic hyperglycemia. What is the sugar? You'll ask simple question. Same thing you can also see on the CT scan, but CT scan is often missed. You know, there's a hyperdense signal seen over here. As compared to this side, there's a little bit of hyperdense signal, and so these are all very commonly seen in this case of the hemichorea, hemibellism. So how do you treat the patient? Basically, you give insulin, which is very simple, and subsequently oral hypoglycemic agents. The chorea may not abate just by correcting the insulin, giving the insulin, and therefore you have to give something more as a symptomatic therapy for the chorea, and you may give haloperidol, start with small dose and gradually build it up. Maybe half or 1 milligram 2 or 3 times in a day is enough, but you have to continue it for a long period of time, for several weeks, even months sometimes. So this is a hemichorea and hemibellismus. So the pearl of the case is, whenever you see an acute onset of a chorea, think of an acquired cause. If you see a chronic chorea, then you are thinking in terms of a genetic. And hemichorea and hemibellismus, whenever you think of non-ketotic hyperglycemia. If it is not there, then you think of a polycythemia vera. A lot of people say phenylchorea. There is nothing like a phenylchorea. You have to look for the cause. Why this chorea has happened? A lot of this chronic chorea going on in the elderly may be a part of a genetic disorder, what we call it Huntington disorders, and there are Huntington-like disorders. But we are always interested in hemi ones because these are all treatable, whether it is non-ketotic hyperglycemia or polycythemia vera. And therefore, blood glucose control is a very important part, but this all patient needs something more than that. So whenever you see a patient of chorea, we always take the help of the body distribution. That gives us a clue why this chorea has happened. Suppose somebody has a generalized chorea and there's a chorea in the forehead, then you start thinking that this could be a Huntington's chorea, which is an adult onset of a chorea, which is genetic chorea. Most of the time, the drug-induced chorea are in this region, orobuccolingual, this region. So if you see it prominent over here with a nice chorea, because after the chorea which has started over here, it can go to the limbs as well in case of drug-induced or antipsychotic-induced chorea. But this gives a clue that this could be a Huntington disease. And orobuccolingual choreas, most of the time we are thinking of tardive chorea because of the drugs. But another important thing is to consider the hepatolenticular degeneration, acquired ones. That can also come with this orobuccal, and then rare causes. Whenever you see a hemichorea, you always think of a structural region on the other side of the brain. But if it is not there, then you start thinking in terms of either non-ketotic hyperglycemia or polycythemia vera. And if it's a child, you think in terms of the Sydenham's chorea. Sydenham's chorea usually comes with generalized chorea, but they can always come with hemichorea, and the other side might be minimally affected. So this body distribution gives a very much clue. Now I'm going to show a lady, you to tell me the diagnosis of this. This lady has come with a 2 years history of a chorea, which has been going on, and this is a generalized chorea. And see, these people are trying to hide it as though they are doing some movements, but they are actually not doing the movement. They also know that automatic dance-like movements is going on. Then they try to show it off. Look at this, there's a forehead chorea as well, upper eyebrows, where there's movements on the face. So whenever eye and forehead, 2-3 years history of a chorea in an elderly patient, what do you think? You all are genius. So this is a Huntington's chorea. This Huntington's chorea is most common adult onset hereditary chorea, and it's autosomal dominant disorders. These patients will come with 3 manifestations. Either they come with a generalized chorea, or they come with a progressive cognitive decline, or they come with a psychiatric manifestation in the form of the behavioral abnormality, irritability, psychosis, suicidal, impulsive, and so on and so forth. So they may land with a psychiatrist, or they may land with a movement disorder specialist, or they may come to you for the dementia. The chorea in the people with Huntington disease can affect all the parts of the body. You name it and it is there affected. So it's a generalized chorea. Now I'm going to show you another boy, 12-year boy. He comes with the hemichorea, and you have to tell me what is your diagnosis. This boy has a right side chorea since last 3 weeks, and this is going on right upper limb and right lower limb choreiform movements. What is the diagnosis? Rheumatic, yeah. So we use the word Sydenham's chorea. So Sydenham's chorea is most common cause of chorea in the childhood. Whenever you see acute subacute chorea between the age of 5 and 15, think of Sydenham's chorea. It's a subacute onset because of group A streptococcal infections. Treatable condition, you look for the throat culture for this bacteria, and you do a ASO test or DNS test, and you look for the heart for the carditis. Symptoms usually resolve over a few weeks. Some people will require a symptomatic treatment, which can be either from haloperidol or simple tetrabenazine. And valproate is one drug which works very well in this condition. You may give a small dose of valproate and it works well, but you have to give it for many weeks or months. This chorea would disappear in childhood, and then when the person becomes pregnant, at that time it may re-emerge as a chorea gravidarum. So chorea gravidarum, the first trimester, somebody gets a chorea, you ask, did you have Sydenham's chorea? I mean, people don't tell us, did you have chorea in the childhood? They would say, yes, they have chorea in the childhood. So that will re-emerge. So chorea gravidarum is just a chorea. You have to look for the cause. It may be Sydenham's, it may be lupus, it may be, Huntington's, or it may be anything else, or thyrotoxicosis. So in the pregnant lady, when they come with chorea, you have to look up the cause. Sydenham is a very important cause which emerges at the pregnancy, and you have to treat with penicillin prophylaxis. Now I'm going to show you another video of a lupus patient who comes with a severe chorea and encephalopathy. And she was treated with methylprednisolone and tetrabenazine, which is a very important drug that works very well in chorea, and in few days she was reasonably better. So chorea is rare in SLE, and therefore whenever you get a chorea in a patient with SLE, think of anticardiolipin or antiphospholipid antibodies. Behçet's, Sjogren's, and celiac disease are another very important conditions to think of whenever you get a youngish patient with this chorea when you are thinking of autoimmune disorders. Anti-NMDA receptor encephalitis, Professor Rahul had told us that this should become with chorea, dystonia, epilepsy, behavioral abnormalities. So chorea can be one of the manifestations of the anti-NMDA receptor encephalitis. So whenever you see a patient with chorea, just ask one thing, how long it has been there. If it is more than 1 year, think of a genetic. If it is less acute, subacute, think about treatable conditions. If it is genetic, it's child, benign hereditary chorea. If it is adult, think of a Huntington's chorea. If it is chorea, acute, subacute, in child, think of Sydenham's chorea. 90% time you will be right. If it is adult, there are a lot of causes. You think of the structural cause, you think of a metabolic cause, non-ketotic hyperglycemia, SLE, Sjogren's, infections, toxoplasmosis, HIV, drugs, levodopa can produce chorea. Even the phenytoin drug, which has given a big dose, the patient can come with your chorea. So acute, subacute means you are thinking in terms of these causes. Thank you. Okay, we will go last. Last, your last. Okay.
Yeah. So this patient, 26-year-old patient, presented with complaints of vertigo, vomiting, followed by imbalance while walking and difficulty speaking since 3 months. So relatively acute onset, of a vestibular syndrome in a young girl. Patient was absolutely right 3 months ago when she started getting vertigo, vomiting, which progressed over a few hours. Then she got ataxia, which worsened over a period of 1 month. And 1 month prior to admission, the ataxia worsened to a point where she actually needed wheelchair and needed help of one person to walk. So it is a progressive cerebellar syndrome over a period of 3 months. She also had imbalance or ataxia of the hands, slurring of speech. So it was a pure cerebellar, complete pancerebellar syndrome. There was no history of exposure to drugs or toxins. There was no sensory motor involvement. Examination, higher mental functions were normal. There was a pancerebellar syndrome and there was nothing else on the examination. There was a nystagmus, scanning, speech, past pointing, all cerebellar findings were there. I'll just show you one simple cerebellar finding. These are tetubitions and gross ataxia. See, not able to touch the tip of the nose properly with both hands. And gross tetubition truncal ataxia, which started like a vestibular syndrome, and this patient was working in Dubai. At that time, in the beginning when she got this vestibular syndrome, she went to the hospital and was being treated for a vestibular neuritis with Stemitil and everything. But the disease progressed over a period of time and she got a complete pancerebellar syndrome. So, immune mediated condition you have to keep in mind. With the subacute progression, cerebellar ataxia, either autoimmune cerebellitis or paraneoplastic cerebellitis. Demyelination is a possibility, slowly progressing, or it has acutely happened and it is static, not improving. Neoplasm metastasis, though there is no history of headache, vomiting, drowsiness, toxin induced possible, especially mercury can cause, but there is no such history. We did an MRI which showed mild cerebellar atrophy. Here you can see this cerebellar folia prominent, little bit here especially. Mild cerebellar atrophy was there. Routine tests were normal, blood parameters, everything was normal. So subacute pancerebellar ataxia, no structural lesion, no evidence of CNS infection, autoimmune markers in the blood negative, viral markers negative, immune mediated ataxia was kept in mind. Antibody panel and oncology screening was done, and her YO antibody came positive. So if there is cerebellar ataxia, subacute presentation, YO, re-YO, these three antibodies you have to keep in mind, and YO came positive, which is an anti-Purkinje cell antibody. This patient was admitted earlier at a private hospital in Mumbai itself, and they thought that there is a spinal cord lesion, and some angiography was done and imaging, everything was done, it is negative. But patient had a typical cerebellar syndrome. So we investigated and we found this antibody positive, and there is a strong association with the neoplasm. So this patient was further investigated by a PET scan, and here you can see some lesion over here in the breast, which was very tiny lesion, showing hypermetabolism. There was high grade metabolic activity and enhancing lobulated lesion in the retroareolar part of the right breast in this patient, okay. And on biopsy it showed a ductal carcinoma in situ, seen in solid cribriform, what a comed or necrosis type, I don't know what, high grade, nuclear grade something with HER2 new positive, so 3+ positive, her and new antigen positive over there it was a high grade lesion, and then the patient was referred to a onco surgeon, but they didn't believe that it is the cause for this cerebral ataxia, and they kept on pressurizing us, it is something else. So then the patient was referred to another center wherein she received the surgery, and for this cerebellar ataxia the patient was given plasmapheresis. After this specific therapy for breast cancer with lumpectomy, chemotherapy, 12 cycles of chemotherapy, but the ataxia didn't improve, and we actually gave plasmapheresis to this patient. Multiple cycles of plasmapheresis were given, but it has stabilized now, but the patient has not improved subsequently. So this we have to keep in mind, subacute presentation, vertigo, vestibular syndrome, acute vestibular, Paraneoplastic cerebellar ataxia or presents like acute vestibular syndrome, vertigo and giddiness and like that. And if it doesn't improve, we have to keep this in mind. Thank you.
Last case. I hope you will have the energy to attend. This 19-year female, she was obese and she came with a history of a severe headache since last 2 weeks, and there was a progressive visual loss in both the eyes. She had diplopia, which was binocular, which means if she closes one eye, the diplopia disappears, and it was a horizontal diplopia. And there was no history of any medications, no alcohol, no tobacco, and family history was unremarkable. So a young lady, headache, visual loss, 2 weeks diplopia. When you examine this patient, there was significant visual loss in the right eye, 20 or 100. Some color vision loss was there in the right more than the left eye, and there was a relative afferent pupillary defect in the right eye. So it means there is something going on in the right more than the left eye. And you do the extraocular movement examination. When she is looking straight, you see both the eyes are deviated inwards, more the right eye. And when she looks to the right, there is an abduction deficit in the right eye. Left eye, she looks reasonably well. So she has got a right sixth cardinal nerve palsy. And if you do a fundus examination, what do you see in fundus? How many of you see fundus? Okay, so you don't see fundus. Generally, you expect a big round disc, good with a lot of vessels going on. Here you see nothing, no margins are seen. You see a lot of white patches, these are all exudates. And you see a bit of a hemorrhagic spots are there and now vessels have disappeared. So this is a very bad papilloedema, it's a severe papilloedema. So whenever you see any severe papilloedema, the first thing is you see the blood pressure and do a scan as well. Malignant hypertension can come like this picture, which would be more or less similar in this patient. So it was not there in this patient. So once you see a severe papilloedema and the person is saying the visual loss, visual loss when the person papilloedema say it's a really alarming things. So perimetry was done in this patient, and whatever black you see around is a loss of vision. Only the central little bit of a vision was left out, and that too she was seeing with the difficulty. So in 2 weeks, she had a significant visual loss. A young obese lady comes with a severe papilloedema, this much visual loss. When you evaluate this patient, rest of the neurological examination was otherwise also okay. Blood pressure was normal. Brain MRI with gadolinium was done, normal. MR venogram was done, normal. So what do you do next? CSF for pressure, to thinking in terms of? Pseudotumor cerebri, yeah, you want idiopathic intracranial hypertension. So some CSF was done, it had shown a very high CSF pressure, about 25 ACE, it is abnormal, it was 63, significantly high, and you need a normal CSF content before you put the diagnosis. She had no anemia, no sleep apnea, no medications. So what is the diagnosis? Idiopathic intracranial hypertension. But because it was a rapid course and so much of a vision loss in 2 weeks, we use the word fulminant IIH or a malignant IIH. So this is a patient of a fulminant idiopathic intracranial hypertension. So whenever you see a patient of fulminant IIH, you do really act very fast. You can't say, lucky dosek diamox aao mahina bachi. No, this is a fulminant IIH. So what do you do next in this patient? Give acetazolamide, 500 milligram, twice a day. Don't give 250 BD. It's a pediatric dose. You may give it start for a couple of days and then immediately jump it if you're too scary. But 500 is the dose. They will all get a side effect. Let it be. But then you do not have much choice. As once you do a lumbar puncture, some degree of the reduction of the headache and the diplopia occurs, which also happened in our patient. And so this patient should not go home. You have to call the neurosurgeon for the surgery. So this patient goes for surgery. We referred to a neurosurgeon. Neurosurgeon, he was referred in the evening, did not come in the morning. And again, the headache and diplopia worsened by the morning because it's a fulminant IIH. And then ultimately, neurosurgeon came and did a lumboperitoneal shunt, was implanted. And after a week or so, you see that vision has improved in both the eyes, color vision has normalized, and no related afferent pupillary defect. And if you see the fundus, it is reasonably stable, which was initially looking flory bad. Now you can see a vessel. Now you can see a little bit of margins are coming up. And there's some degree of improvement in the central vision is there. And after 6 weeks, there's an optic pallor actually, this is seen. And so that means he has stabilized, no more papilloedema. So he has done reasonably well. And of course, the vision didn't come that much we wanted, but there was some improvement. So how do you approach to the patient who comes with a headache and papilloedema? What investigation you do whenever you see a patient headache with papilloedema? What do you do? CT, MRI? MRI. Plain MRI, contrast MRI? Contrast MRI. Contrast MRI, venogram or no venogram? Venogram. So you do MRI brain with contrast and venogram whenever you see a patient with papilloedema. Why you want to do all these things? Because we are worried of the three conditions which are common, and that is the hydrocephalus, mass, and venous sinus thrombosis. So because you can get this hydrocephalus, which can come with headache and papilloedema, you can get mass, which can come like this, and we can get a venous sinus thrombosis, which can come like this. So these are our big threes for our headache and papilloedema. Suppose they are not there, then what do? Suppose MRI is normal, then what? Then you do a lumbar puncture. Why you want to do a lumbar puncture? Only for lumbar puncture to see the pressure or something more than that? You see not only for the pressure, but you are interested in seeing the cells and the protein. If the cells are high, 800 cells, 1000 cells, then it won't be a IIH, then it is a meningitis. But if suppose cells are normal, protein is sky high, 250 protein, then what? Then you think in terms of spinal cord tumors. Spinal cord tumors uncommonly can come like this with a high protein, so you do search for the spinal cord in that situation. But suppose CSF content is normal, so then you are left out with the pressure, right? Let's say you do in this patient of a headache, and diplopia, you do a lumbar puncture, and the pressure is normal. What do you think then? Suppose the pressure is normal, huh? Obstructive MRI is normal. Normal MRI, normal CSF content, and now normal pressure. What do you think? I happen to see one ophthalmologist of the Bhavnagar. She came to me when she was a student, and his father said that I had seen an ophthalmologist for the headache, and she has got a severe papilloedema. He was shivering in my office, and I saw that, and I was thinking, oh God, maybe papilloedema, I'm not so sure. Get an MRI done. And he was really drenching because the only intelligent daughter, she was currently an ophthalmologist, and she was having this thing. And therefore, they found that this lady had not normal MRI. But we did not do LP in that patient. You know why? Because she had a pseudo papilloedema. So if suppose LP is done, you will get a normal pressure and normal content. That's a pseudo papilloedema. And if the pressure is high, then it's an idiopathic intracranial hypertension. This is a photograph of pseudo papilloedema, and this is a photograph of the papilloedema. They look similar, but those untrained eyes. But when your eyes are trained, you know that there is a calcification is there. These margins are not bad. You can very well see the good vessels in that, and so that's a pseudo papilloedema. Whereas look at these margins, look at this vessel, how they are this very different from this thing. But if your eyes are trained to see it, I refer to one of the very, very prominent ophthalmologists in Bhavnagar. He said, I had never heard this word. This is drusen, actually. The word is drusen for this thing. And if you do a B scan of the eye, this is what even radiologists do and even the ophthalmologists do, then you will find the calcifications. So that they will tell us that this is not a true papilloedema, it's a pseudo papilloedema. And whenever you diagnose IIH, always sit back and look once more. Am I missing venous sinus thrombosis? A lot of patients will come with you plain MRI brain, and you look like IIH, you do LP, little bit high pressure and content. You can get even venous sinus thrombosis as well. But you do seriously consider this. Send that MRI to the radiologist, ask him, do you think that this is not a venous sinus thrombosis? If he says, yes, this is not, then you're out. So plain MRI would miss the venous sinus thrombosis. If you're done with contrast, majority of the time, good radiologist will tell you, okay, no need for venogram, I can see there is no venous sinus thrombosis. But if you do all the three things, then it's the best thing. But always look for the venous sinus thrombosis in these patients. So in IIH, how do you diagnose? By headache, papilloedema, diplopia, and tinnitus. These are the clinical features. Do MRI, rule out the intracranial process and venous sinus thrombosis, and then you do LP, confirm the pressure high, and then normal contents. So once you are into the IIH, then you see three things. How bad is the headache? How bad is the diplopia? And how is the visual function? I said visual function, not acuity. Visual function means acuity plus the field of the vision. So everything should be seen in this type of patient. Bad headaches, if you are treating not improving, then you are thinking in terms of shunt surgeries and diplopia. Bad visual functions. How do you know bad visual functions? By seeing acuity, and you do a perimetry. You don't, gone are the days when you used to do this thing. Ketlu dekha hai, dekha hai, na dekha hai. This manual thing of seeing the perimetry kind of thing, you have to use the perimetry. You don't use this fingers to see for the field testings. Now you have to use the automated perimetry. And this will tell us, if you get this much enlargement of the blind spot, this black one, then we say, okay, papilloedema, no problem, you treat the patient. If the person stops the medication and comes to you, he can come to you with this much blackness, more field of vision is gone. Patient may not even know it that there is a loss of field vision, but it will still be a loss. You tell this patient, if you miss the medication more, if you're worsening at this stage, we are going to send you for surgery. And a lot of our patients, what they do, mare jo do, and they stop the medications. And they come with this stage. At this stage, you can't wait. You have to operate these patients. So whenever you see a patient of the IIH, the first thing we do LP, we look for the precipitating factors, drugs like doxycycline or the treatment for the acne, if they are taking, you have to stop that medications. You correct the anemia by giving the IV, and correct the sleep apnea, and you do weight loss is a very important thing. But weight loss works over a few weeks. It doesn't work immediately. But you have to tell the patient, if the obese patient is there, and you have to tell 5% of weight loss is enough for us, and they will agree with you, and then they will go for the weight loss. And then you start with the acetazolamide, minimum 1 gram. 250 BD is a placebo dose. 1 gram is one we give. If the person somehow doesn't tolerate because of the bad taste, tingling and numbness with acetazolamide, then you can think of using the topiramate. But mind you, no oral steroids. Oral steroid temporarily તમને આમ સારું લગાડે, પણ પેશન્ટનું વેટ ગેઇન થઈ જાય અને IIH would worsen. And patient follow-up ક્યારેક નહીં આવે, હેરાન થઈ જશો. So when you get a worsening vision in a patient IIH, if headache and diplopia is more, think of doing the shunt. If visual loss and severe edema is there, do is a optic nerve fenestration surgery. How many of you are aware of this optic nerve fenestration surgery? I mean, what you do is, around the optic nerve, there is a sheath of the durameter. They open up that sheath, and the CSF which is there around that will be relieved. And so the pressure on the optic nerve is relieved. So this is a shunt that people get it done. It's a lumbopetroleal shunt, which mostly people do, or you can do a ventriculopetroleal shunt. This is a optic nerve fenestration surgery. This is the optic nerve. This is the optic nerve, and this is the retina. So around the optic nerve, this is the CSF, and this is a sheath. So they open up the oculoplastic surgeon will open up this sheath, and the CSF pressure, which is doing a lot of pressure on the optic nerve, which gets released, and the person improves in the vision over a period of time. So this is the surgery that you have to do it. But for any reason, if you're not able to do the optic nerve fenestration surgery, even in those patients who have visual loss, even if you do a shunt surgery, it is enough to get the good results. Thank you. So my pearl of the case, pearl of the case is papilloedema is diagnostic, and you do respect it. Respect any patient who is having papilloedema and act quickly. In a young obese woman, think of IIH. Medical therapy with acetazolamide and topiramate is first line, but vision decides the urgency. So vision, do a perimetry, not just say ketlu dekhai che. And the rapid visual decline, it demands surgical intervention, shunt or optic nerve fenestration. Thank you. So we finish over here. If there are any questions, Rahul will tell all the answers. Dr. Rahul, you can come here. If you have any questions, you can ask during the lunch time also. We are just finishing and breaking it up. Okay? Yeah. I hope it was helpful.
API Bhavnagar is heartily thankful to Dr. Jayanti Gurumukhani sir for arranging every time an excellent CME at the end of the year. That gives us a boost up for beginning the new year with more good sessions. We are thankful to Dr. Rahul sir also for coming long way from Mumbai and giving such as an interacting session and so many good interesting cases in neurology. We are thankful to all the participants as well as Dr. Reddy's Pharma for arranging this session, as well as Dr. 4Care Pharma for making the session live. We all will be soon meeting for a non-academic family get-together, probably in the first week of January. Details will come in the group soon. Thank you for coming.
Thank you.